അതിനകത്ത് ഒരു കുട്ടി എൻ്റെ അടുത്ത് പറഞ്ഞ ഒരു ഏറ്റവും വലിയൊരു കാര്യമുണ്ട്. സാർ, എനിക്ക് എന്താണ്, എൻ്റെ അച്ഛൻ മരിച്ചുപോയി. എൻ്റെ ഉമ്മ രണ്ടാമതൊരു കെട്ടിയ ആളാണ്. അപ്പം എൻ്റെ രണ്ടാം അച്ഛൻ എന്നെ ഭയങ്കരമായിട്ട് യൂസ് ചെയ്യുന്നുണ്ട്. നമ്മളെല്ലാം നിങ്ങളെല്ലാം third year, fourth year and all the delegates, I am telling to you, we already studied the particular psychiatric topics and all, and sexually harassment. It's like a sexually harassment. Okay. ആ കുട്ടി എൻ്റെ അടുത്ത് പറഞ്ഞു, സാർ, എന്നെ തൊടുന്നതും എന്നെ പിടിക്കുന്നതും എൻ്റെ ദേഹത്ത് എന്തെങ്കിലും രീതിയിൽ അയാൾ നോക്കുന്നത് പോലും എനിക്ക് പേടിയാണ്. അപ്പൊ ഞാൻ ചോദിച്ചു, മോളെ എന്താണ് സംഭവിച്ചത്? അപ്പം പറഞ്ഞു, എൻ്റെ ദേഹത്ത് പുള്ളി തൊടുന്നുണ്ട്, അതുപോലെ കൂടെ കിടക്കാൻ ഇതാക്കുന്നുണ്ട്. ഞാൻ ചോദിച്ചു, നിന്റെ ഈ രണ്ടാം അച്ഛൻ വരുന്ന രീതി എങ്ങനെയാണ്? പറഞ്ഞു, കുടിച്ചിട്ടാ സാറേ വരുന്നത്. അയാൾ എന്തൊക്കെ യൂസ് ചെയ്യുന്നുണ്ടോ അറിയത്തില്ല. എൻ്റെ ഉമ്മയെ ഒരുപാട് തല്ലാറുണ്ട്. അത് ബിക്കോസ് ഓഫ് റിച്വൽ, ബിക്കോസ് ഓഫ് റിലീജിയസ്, they were married. ഓക്കെ. അപ്പം പെട്ടെന്ന് എന്താണ് സംഭവിച്ചത്? ആൻസർ ഈസ് സബ്സ്റ്റൻസ് യൂസ്. ഓക്കെ. നെക്സ്റ്റ്, can you hear me? You are hearing or not? Okay. രണ്ടാമത്തെ ഒരു സംഭവം എന്ന് പറഞ്ഞാൽ, വേറൊരു കുട്ടി സെയിം സ്കൂളിൽ തന്നെ വേറൊരു കുട്ടിയെ ഞാൻ എന്താണ് കൗൺസിൽ ചെയ്ത സമയത്ത് എനിക്ക് കിട്ടിയെന്ന് പറഞ്ഞാൽ, സർ, ഞാൻ ഗാഞ്ച യൂസ് ചെയ്യുന്നുണ്ട്. സിംപ്ലി ഇത് ബിക്കോസ് ഓഫ് മൈ കൊളീഗ്സ് ഓൺലി ഐ ഗോട്ട് ദ ഇൻഫർമേഷൻ ദ പർട്ടിക്കുലർ സ്റ്റുഡൻറ് ഈസ് യൂസിങ് ദ ഗാഞ്ച ആൻഡ്. പെട്ടെന്ന് തന്നെ അവർ പറഞ്ഞു, എന്താണ് സാറ്, ഞാൻ ഗാഞ്ച യൂസ് ചെയ്യുന്നുണ്ട്. ഞാൻ ചോദിച്ചു, മോനെ നിർത്താൻ നോക്കൂ. ഇല്ല, ഞാൻ എന്തിനു നിർത്തണം? എൻ്റെ വാപ്പ ഡിവോഴ്സ് ആയി പോയി, എൻ്റെ അമ്മ കൂലിപ്പണിക്ക് പോകുന്നുണ്ട്. ഞാൻ ചോദിച്ചു, നിനക്ക് എവിടുന്ന് പൈസ കിട്ടുന്നു? അവൻ പറഞ്ഞു, സിമ്പിളായിട്ട് അവൻ പറഞ്ഞു, എന്തോ എനിക്ക് പൈസ കിട്ടുന്ന എവിടുന്നാണോ? ഞങ്ങളുടെ വീട് പണിയുടെ പൈസ ജഗ്ഗിനകത്ത് അടച്ചു വെച്ചിട്ട് അത് എടുത്തിട്ട് 10,000 രൂപ എടുത്തിട്ടാണ് ഞാൻ യൂസ് ചെയ്യുന്നത്. അതിന്റെ ആൻസർ എന്താണ്? സബ്സ്റ്റൻസ് യൂസ്. നിങ്ങൾക്ക് കാര്യങ്ങൾ മനസ്സിലാവുന്നുണ്ടോ? ഈ 13 കുട്ടികളെ ഞാൻ ചെയ്തപ്പോഴും അതിന്റെ ഒക്കെ ആൻസർ എന്താണ്? സബ്സ്റ്റൻസ് യൂസ് ആണ്. അപ്പം നിങ്ങൾ വിചാരിക്കുമ്പം ഞാൻ ഒരു ഇന്ററാക്റ്റീവ് സെക്ഷൻ ആയിട്ടാണ് ഇത് നടത്താൻ ഉദ്ദേശിക്കുന്നത്. അപ്പൊ നിങ്ങൾ ഒന്ന് ചിന്തിച്ചു നോക്കിയേ, എന്താണ് സബ്സ്റ്റൻസ് യൂസ് ഡിസോർഡർ? ഞാൻ പറഞ്ഞു, ദിസ് ഇസ് ആൻ ഇന്ററാക്റ്റീവ് സെക്ഷൻ. You have to answer. Okay, I am having limited time, like 45 minutes only I am having. Okay, then you can start, anybody. Okay, what's the meaning of substance use? Anybody, you can use that. Okay. You can tell. Okay, just tell. Okay, then just you see this particular PPT, and after that I will ask the particular question and all. Okay, this is the heading I have already put in my PPT. Preventive addiction, better late than never. What's the meaning of that? Preventive addiction, better late than never. You people are thinking that, okay, only alcohol is addiction, MDMA is addiction, otherwise cocaine is addiction, ganja is addiction. But I want to tell to you, extra addiction is like internet addiction. Am I right? Caffeine addiction, thein addiction. We are having different types of addiction we are having. Okay. Anyway, through my PPT, within limited time, I will explain all the things and all. Okay. Okay. What's the meaning of this one? Preventive addiction, better late than never. What's the meaning of this one? You just think. We have to prevent the addiction before we are getting addicted. Understood or not? Okay, I'm not, because we are having the online section and all, that's why I'm not using the particular Malayalam and all. Okay, you just understand this is like a what preventive addiction means. What we have to prevent the particular addiction before we are starting the particular substance use. Okay, next. Okay, when the use, what is addiction? When the use of alcohol and or more mood altering drugs causes problems in the individual's family, social work, school, legal, physical, and or emotional aspects of the life. Already I have explained what all are a substance within a limited period. Okay, we are taking coffee. Okay, we are taking the particular tea. We are taking the particular Sprite. We are taking the particular alcohol and all. But I am telling to you, whenever the particular thing is crossing off your life, നിങ്ങളുടെ ലൈഫിൽ ക്രോസ് ചെയ്ത് പോവുകയാണെന്ന് നിങ്ങൾക്ക് തോന്നുവാണെങ്കിൽ that is addiction. For example, നിങ്ങൾ means you people have to take the tea for morning. Okay, whenever you people will wake up, you people have to take the particular tea. Okay, morning 6 a.m. but coffee we are telling like that. Okay, next time, okay, evening time also you people will take. That is okay. But if you people are taking 40 teas and 20 teas and 20 coffees, that is not okay. Understood? That is called addiction. Whenever we are using the caffeine, the MDMA, the particular alcohol, ganja, and any substance unnecessarily, that is called addiction. You are understanding my class or not? You are getting or not? Okay. Okay, next, whenever we are getting the particular addiction, how we will identify? നമുക്ക് എങ്ങനെ മനസ്സിലാവും particular ആയിട്ട് നമ്മൾ addicted ആണോ? അതിന്റെ കുറച്ച് എക്സാമ്പിൾസ് ആണ്. I am telling to you the particular things, the behavior changes we are getting. First of all, change in attitude, personality for no identifiable person. Whenever we are speaking, whenever we are addicted to anything, for example, we are addicted to caffeine, we are addicted to MDMA, we are addicted to any thing, then how we will change our attitude? You just identify that. Okay, change in attitude, personality for no identified person. നമ്മൾ എങ്ങനെ സംസാരിക്കുന്നു, ആ സംസാരം അത് ചേഞ്ച് ആയിരിക്കും. For example, somebody is asking, what's your name? Shiny. Okay, Shiny madam will ask to me, okay, if I am like a addicted person, Shiny madam will ask to me, okay, sir, what's your name? Then I will tell my name is like Liju James. Okay, then next Shiny madam will ask to me, sir, evidnu varunu? Okay, then I will change my topic because I am in my reality only. Understood? ഞാൻ എന്തോ ആയിരിക്കും പറയുന്നത്? ഓക്കെ, ഞാനാണെങ്കിൽ എന്ത് പറയുന്നു, അവിടുന്ന് വരുന്നു ഇവിടുന്ന് വരുന്നു, എന്താണ് വാട്ട് എവർ ദ ഷൈനി മാഡം ഈസ് ആസ്കിങ്, ഐ വിൽ നോട്ട് ടെൽ ദ പർട്ടിക്കുലർ സബ്ജക്ട് ആൻഡ് ഓൾ. ദാറ്റ് ഈസ് ദ ഫസ്റ്റ് സൈൻ ഓഫ് ദ പർട്ടിക്കുലർ അഡിക്ഷൻ. ഡിഡ് യു അണ്ടർസ്റ്റാൻഡ് ഓർ നോട്ട്? The particular person will change their identity and whatever they are telling, we also didn't recognize. Okay, shall I go to next slide? Okay. Change in friends, new hangouts. Change in friends means, okay, for example, some of our friends will not like this alcoholism, this MDMA, the particular things and all. Okay, they will tell to us, okay, don't use this type of, നമുക്ക് ഇതൊന്നും ഉപയോഗിക്കരുത്, നീ അങ്ങനെ. ഓക്കെ, അവര് അപ്പൊ എന്ത് ചെയ്യും? they will change their friends. അവരുടെ ഫ്രണ്ട്സിനെ ചേഞ്ച് ചെയ്തിട്ട് ആൽക്കഹോൾ ഉപയോഗിക്കുന്ന ഫ്രണ്ട്സിന്റെ അടുത്തോട്ട്, ഇല്ലെങ്കിൽ എന്താ പറയുന്നത്, MDMA ഉപയോഗിക്കുന്ന ആ ഒരു ഗ്യാങ്ങിനെ they will group together. Okay, anyway, finally I will tell one more story to you people, how the track, the mafia of ganja mafism, we already caught, like we had a camp on 10th February. We already did a camp particular on school. I will not tell the particular school and all. We already caught with the help of excise department and all. We already caught the particular mafia, ganja mafia, alcohol mafia for students and all. I will tell the final thing after some break. Okay, next. When the use of alcohol and okay, decrease performance at school, work and home. Okay, what's the meaning of that one? Whenever we are using the particular substance use, you people might be know, you people will not work properly. നിങ്ങൾ നല്ലതായിട്ട് വർക്കും ചെയ്യത്തില്ല, നിങ്ങളുടെ ഒരു സ്വഭാവം മാറും, എല്ലാ കാര്യങ്ങളും മാറും. Okay, next. PPT change illa. എന്താ പ്രശ്നം എന്താണ്? Okay. Okay, next is change in activities and hobbies. Okay, whatever are the hobbies you people are having, it will change and all, and change in habits at home whenever. Okay, and BSc third year and fourth year, you people have performed a very well role play. I can't play because of time limit. I can't play. I couldn't play that one. Especially BSc fourth year have played very much good one thing in our camp and all. I have seen and BSc third year also. Okay, in that is a real life experience only. Okay, real life experience only. Then that is an answer for this one, change in habits at home and all. Okay, next, loss of interest in family and family activities. Every time the particular member should have what MDMA, ganja, and all the things they want. Okay, they are too much happy about the particular things and all. Okay, next one is like a excessive need for privacy. And shall I ask one more question to anybody? You can explain. Sandra is here. I have told already. This is like an interactive section. Okay, Sandra, you can explain the particular section and all. You have played very well. Okay, I have seen the particular video. You have explained. Okay, Sandra, just you explain. Okay, simply I am putting PPT and I am explaining, means that is no value for you people. No. Okay, just come for here. No. And BSc third year, Hari Prasad. Okay, also just come. Because why I am telling means this is like BSc fourth year role play for school health program in Munderi, and this is for Chedana. Okay, and they will explain what all are the things. Substance use disorder only they have played very well. They have played. If you people want, I will mail to you. Okay, you just come to the stage, please. Just share your experience. What was our thing?
Yeah, actually, this camp and I was substance use started school. അത് കഴിഞ്ഞിട്ട് പിന്നെ നടക്കുന്നത് എന്താണെന്ന് വെച്ചിട്ടുണ്ടെങ്കിൽ ടീച്ചർ അമ്മയോട് ചോദിക്കുന്നു. അമ്മയ്ക്ക് ഡൗട്ട് തോന്നിയിട്ട് സ്വാഭാവികമായിട്ട് അമ്മ എന്ത് ചെയ്യും ബാഗ്. അങ്ങനെ ഞാൻ സ്കൂളിൽ പോയിട്ട് വരുന്നു. അമ്മയുടെ ബാഗ് ചെക്ക് ചെയ്യുന്നു. അതിനകത്ത് ഒരു പ്രോബ്ലം പിടിക്കുന്നു. അത് അപ്പം അമ്മ കാര്യം മനസ്സിലാവുന്നു. പിന്നെ അമ്മ ടീച്ചറെ വിളിക്കുന്നു. അതിനിടയിൽ കുറച്ച് വാല്യൂ ചെയ്യുന്ന കാര്യങ്ങളൊക്കെ ഉണ്ട്. സബ്സ്റ്റൻസ് യൂസ് ചെയ്തിട്ട് അത് പിടിച്ചു കഴിയുമ്പോൾ എന്തായിരിക്കും കുട്ടി കാണിക്കുന്ന സംഭവം ഒക്കെയാണ് ചെയ്തത്. അത് കഴിഞ്ഞ് കഴിഞ്ഞിട്ട് നമ്മൾ കാണിക്കുന്ന കൗൺസിലിംഗ് സെക്ഷനാണ്. കൗൺസിലിംഗ് സെക്ഷനിൽ in this counseling section, the counselor will be motivated me or he will console me to solve this one. And after that, then I will be a good student in the class, and regularly I will be in the class. And this is the end of this topic. And after this session, students came to me and tell me that so you have played well, and that was a good motivation or that was a good example for us, and how to be that like use of the substance abuse will be leading to this type of social issues, and what are the problems both in the family, etc. and all. Thank you.
Thank you, Sandra. And this is like a motivational story. This is an actual story. That's why I have already written this script and all. What all are the things I felt about myself? That's only I have written. That's screenplay. This is done by BSc 4th year in camp. I am too much happy about that one. And next is BSc 3rd year. And please use the English language. Okay. Okay, you are having 3 minutes, 4 minutes. Okay, you can tell. Okay.
അങ്ങനെ ബാംഗ്ലൂരിലെ സാഹചര്യം നമുക്ക് എല്ലാവർക്കും അറിയാം. അങ്ങനെ അവരുടെ ഗ്രൂപ്പിലൊക്കെ ചേർന്ന് ഒരു എന്താ പറയാ സബ്സ്റ്റൻസ് അബ്യൂസിലേക്ക് പോവാണ് ആ കുട്ടി. അപ്പൊ ഈ ഫാമിലിയുടെ അവസ്ഥയൊക്കെ ഭയങ്കര പാവപ്പെട്ട ഫാമിലിയാണ്. അവര് ലോണൊക്കെ എടുത്തിട്ടാണ് ഈ കുട്ടിയെ പഠിക്കാൻ വേണ്ടി വരുന്നത്. അങ്ങനെ ഈ കുട്ടി ഒരു ഗ്യാങ്ങിൽ പെട്ട്. അപ്പൊ ആ ഗ്യാങ്ങിലുള്ളവരെല്ലാവരും ഇങ്ങനെ സബ്സ്റ്റൻസ് യൂസ് ചെയ്യുന്ന ആൾക്കാരാണ്. അങ്ങനെ പിയർ ഗ്രൂപ്പിന്റെ പ്രഷർ കാരണം ഈ കുട്ടി അതിന് അഡിക്റ്റായി. അങ്ങനെ അഡിക്റ്റായി കഴിഞ്ഞിട്ട് പിന്നെ അവര് ഭയങ്കര വയലൻസ്, അതായത് ഫാമിലിനോട് ഫ്രണ്ട്സിനോട് എല്ലാവരോടും ഭയങ്കര വയലൻസ് ആയിരുന്നു. അങ്ങനെ ഈ കുട്ടീനെ ഒരു ഫാമിലിന്റെ പ്രഷർ കാരണം അവര് ഡി അഡിക്ഷൻ സെന്ററിലേക്ക് കൊണ്ടുപോകാം. അങ്ങനെ ഡി അഡിക്ഷൻ സെന്ററിലെ ഒരു സീനാണ് അവിടെ കാണിക്കുന്നത്. അങ്ങനെ അവര് കൗൺസിലിങ്ങും കുറെ തെറാപ്പീസ് കൊടുത്തിട്ട് ആ കുട്ടീനെ നോർമൽ ലൈഫിലേക്ക് കൊണ്ടുവരാൻ വേണ്ടി ശ്രമിക്കുന്നത്.
Okay, thank you, Hari Prasad. Okay. Anyway, they have shared their experience. It's like a real story. Whenever the particular fellows after +2 and something, some students are going to abroad, or some students are going to out of states like Bangalore, North India, something. Okay, I am seeing the particular thing that these particular students are too much good in what? In Kerala and all. And after that, they are going outside. What they are doing, I didn't understand till now. Because I was in tuition field, like 9th, 10th, +1, +2. I was teach like zoology and something, okay, biology, 9, 10, +1 and +2. And after that, one day I have seen a particular lady, I will tell, not female, lady. I didn't understand. In a cafe, I have seen that particular lady with the hair cutting like a model. Then, sir, you understood who am I? Then I didn't understand. She is not Deepika Padukone. She is not anywhere else. Okay. Then, sir, I am your student. Too much putty. Understood? Too much putty, whitish putty, and too much lipstick and all. Then I was asked, you are Jiva or not? Okay, that's her name. Okay, Jiva or not? Then, yeah, I am Jiva, because you only told no, we want to change our lifestyle. Okay, what I have told, we want to change our lifestyle, but not in face. We are having our own culture, and now She is in an addiction center, and she was in addiction center and she committed suicide also. Understood? But I am telling to you, whenever you people are going to abroad, whenever you people are going to out of state, you people have to see whatever I am telling right now. It is an actual story only. I am not making any story. What all are the stories or screenplay I have made to the particular BSc third year and fourth year? That is from my life experience only. Okay. And next of all, okay, you people BSc fourth year, anyway, you people go to abroad. I am sure about that one. Okay, you people, somebody wants to go abroad or not? BSc fourth year, you people are going to complete your course now. Anybody? BSc fourth year, I am asking to you. Anybody wants to go? Yes or no? Okay, what do you people will do over there? Okay, you people will earn money. Okay, that is not my section. Okay, next I am going to different substance addiction. What all are the addiction section is there? First of all, alcohol. Second on drug addiction. Third on marijuana. Fourth on inhalants. Fifth on methamphetamine. And final on cocaine. Okay, in this, I am dealing only on about marijuana and methamphetamine. Okay, recent study, you people can, okay, in our MIMS library, you people will see recent journal of mental health nursing, volume 24, page number 242. You can write, that is TNMC, Tamil Nadu Medical Council, but the particular a journal is there, and 24th page number, 24 only and 424 page number, you people have to see what is the common use of addiction. That is MDMA. What do you mean by MDMA? Did you hear about that or MDMA? I have already told it is like methamphetamine. MDMA, you can, you have heard or not? Anybody? What is MDMA? You people can hear, no? Can you hear me? Okay, you just tell. Amalda, you just tell about MDMA. Powder substance. Okay. You just think that previous 6 weeks I am hearing about the particular news like channel news, Manorama, say whatever it is. Okay, and from Delhi also we are getting the particular thing MDMA. If the particular person has caught by MDMA 3 gram, 4 gram, 5 gram, something. Okay, MDMA means it's like a powder form only. Methamphetamine, that is the particular generic name only. How we are using this one means we are using by heating the particular MDMA, and after that we are injecting. Okay, we will take the particular spoon, and after that we will, what we will do, the we will heat like a 3 degree or 4 degrees Celsius, and after that we will get a particular solution. After that we will take the injection syringe and we will put. And otherwise, the second, this one is like we will take the particular paper, and after that we will put the particular powder, and after that what we will do, smell it. Understood? I am not using, just I am telling to you. Okay, anyway, alcohol, and for example, the recent in psychiatric hospital, when wherever I was supervised in psychiatric hospital, I was seeing alcohol ADS patients are very much low in this Kerala. Am I right or no? Alcoholic patients are there. Basic third year, I am asking to you. Very rare, no. Too much patients are like what? MDMA. Am I right or not? Am I right or not? I want to hear from your voice. Am I right? Okay. And see, every hospital, 92% of particular substance abuses are like MDMA. and marijuana. And the age limit is like, that is too much emotional, 22-25, 22-26, including girls also. Understood? Including girls. Okay, you can search anywhere, everywhere, whatever, all other things I am telling you, people can search that. Okay. Anyway, okay, ADS, we are having the particular de-addictions. Okay, and next one is like a marijuana. We are having the particular de-addiction centers and inhalants. So what's the meaning of inhalants? Inhalants means what? ഇൻഹലൻസിനെ പറ്റി നിങ്ങൾക്ക് എന്താ പറയാം? ഒന്നും അറിയത്തില്ലല്ലേ? ചുമ്മാ കുത്തിരിക്കണോ? ഒരു സർട്ടിഫിക്കറ്റ് ഒക്കെ കിട്ടും അങ്ങനെ പറഞ്ഞിരിക്കണോ? ഇൻഹലൻസ് എന്ന് പറഞ്ഞാൽ നിങ്ങൾക്ക് ഇറേസർ അറിയാമോ? യു പീപ്പിൾ നോ ദ ഇറേസർ. ഓക്കെ, നൗ വി ആർ ഗെറ്റിംഗ് ദ കറക്ഷൻ പെൻ. ബിഫോർ ദാറ്റ് വി ഹാവ് യൂസ്ഡ് ദ പർട്ടിക്കുലർ ഇറേസർ. One liquid and one white color bottle. Am I right or not? You have seen or not? Shaini madam, you have seen that correction pen. Okay. Inhalants means that particular a whitener. Okay. Did you see that one? Okay. Some students, because only 20 rupees are there. Okay. Only 20 rupees, and they people are, especially +2 student have already inhaled that on. They have addicted the particular what inhalant. Once more I will explain. Before, nowadays we are having the particular correction pen. Please remove that one. Okay. Before that, before 5 or 6 years, we are having 2 types of bottle. Okay. One type of bottle is like a correction liquid, like white color. Am I right, sir? White color, and next one is like a white eraser. Okay, we will mix, and after that only we will use that on. Nowadays we are getting that on within 20 rupees, and after that what we will do, the particular students will inhale and they are addicting. In Chedana, I didn't tell that one because Dr. Suresh sir is coming over here. That's why I can't tell that one. And one student, the particular +2 student, was addicted for that eraser. Understood? Okay. Anyway, and what I am telling, inhalants means what? Like shoe polish smell, varnish smell, and this eraser smell, and spray smell. This is like inhalants. Understood? If they are addicted, what is the meaning of addiction? We are crossing our limitation, means that is addiction. Okay, next is cocaine. Cocaine, you people know about cocaine is already vanished from Kerala. Nowadays we have to fear about alcohol, and especially methamphetamine, because MDMA. Okay. Next is like a family matters. Okay, how this will affect in our family? You just see that guarded secrets, codependency, loneliness, assumptions, unhappiness. Guarded secret. What's the meaning of guarded secrets? Because we will hide all the secrets from our parents. Normally, I have already told to you what I have told you. Okay, whenever we are using particular alcohol, we will hide all the things. We will hide all the things from our family. Normally, a particular child or particular husband or particular wife or anybody who are using the substance use, means any substance abuse, automatically they will change their character. Guard a secret means they are having their secrets only. Okay. They will brush, they will use some of chewing gum, they will use some of something you can identify easily. Second one is codependency, emotional, social, and physical on a person. Codependency means whenever they are using particular things, they will speak emotionally with you. Okay. Normally, for example, if I am too much friend with Nasim sir or Riju sir. Okay, whenever I am speaking normally, sir will understand. Okay, Lisa is speaking normally, but whenever I am using anything else, automatically Riju sir or Nasim sir will understand, okay, why sir is speaking like this. That is emotionally speaking codependency. Understood or not? Did you get my point or not? Okay. Next one is loneliness. Always they are telling like that, okay, I am alone, like that, because they are in their reality, they have used the particular substance use and something, although automatically they will think like that. Okay. Next one is assumption. Assumption means what? What's the meaning of assumption? Sir, can you tell assumptions means, sir? Very good, sir. Okay, thank you, sir. Assumptions means find faults. Okay, they will not agree. Okay, I am using this much things, I have used this much thing. They will not agree, and they are telling some excuses because of this one, because of love failure, because of that thing, because of this thing. They will use like that only. Okay, unharmless, no gratitude. They are always what? Their reality only. Understood? Once again, I'm repeating: God are secrets, codependency, loneliness, assumptions, and unhappiness. Anybody is having doubt, you can ask. You can shoot up the questions and all. Any doubts? Okay. Next of all, what all are the family roles we are having in the particular addiction? First one is dependent. If a person is having any type of alcoholism, any type, even a student, okay, you people are having too much delegates are over here. Some students are having, or some delegates are having, the husband is like alcoholism, means students are like alcoholism. You people have to support them. Support them means what? കുടിക്കാൻ സപ്പോർട്ട് ചെയ്യണമെന്നല്ല ഞാൻ പറഞ്ഞത്. എന്താണ് ഡിപ്പെൻഡന്റ്? ഡിപ്പെൻഡന്റ് എന്ന് പറഞ്ഞാൽ അവര് മീൻസ് ദ പർട്ടിക്കുലർ ആൾക്കാരെ എന്ത് ചെയ്യണം? നിങ്ങളൊരു കൗൺസിലിംഗ് സെക്ഷൻ ഇല്ലെങ്കിൽ ഡി അഡിക്ഷൻ സെക്ഷന് കൊണ്ടുപോകാൻ നിങ്ങൾ മോട്ടിവേറ്റ് ചെയ്യണം. കാരണം ഒരുപാട് സ്ഥലങ്ങളിൽ നടക്കുന്നുള്ള കാര്യമാണത്. അപ്പൊ നിങ്ങൾ നല്ലതായിട്ട് യു പീപ്പിൾ ഹാവ് ടു മോട്ടിവേറ്റ് ദം. ഡിപ്പെൻഡന്റ്. എനേബിളർ മീൻസ് the particular wife or husband should be enabled to handle the particular situation. ഒരാളെ തള്ളിക്കളയാൻ എളുപ്പമാണ്, ഒരാളെ ലൈഫിലോട്ട് തിരിച്ചു കൊണ്ടുവരാൻ ഭയങ്കര പാടുമാണ്. You people have to remain that. And one more thing, first of all, you have to find out that what is the actual problem of that particular fellow or student or anywhere. Okay. Next one is hero. You should be like a hero. If I am using alcohol and I am speaking like this, that is not good. Am I right or not? How I will tell, okay, don't use alcohol, don't use tobacco, don't use the particular thing. And if I am not using alcohol, if I am not using the particular thing, then only I can tell to you people what? Don't use this one. Okay, then should be a hero. We people have to have not to use the particular thing and be a lost child and mascot. Okay, why I have add this on? Because around 230 counseling I have done in my career. 230 counseling, and some of counseling I have already, okay sir, I have lost my child, I have lost my lover, I have lost my, and blah blah blah, too much. Then what is the final solution? They have already find out the alcohol, they have already find out the MDMA, they have already find out the marijuana, they are addicted to cigarette, they are getting satisfaction. Understood or not? Okay, that's why mascot and this scapegoat means we are hiding ourselves. Scapegoat means ചെമ്മരിയാടിനെ കണ്ടിട്ടില്ലേ? അതുപോലെ തന്നെയാണ് നമ്മുടെ ചിലവരുടെ സ്വഭാവം. നമുക്ക് എന്തൊക്കെ പ്രശ്നങ്ങൾ ഉണ്ടാവുന്നു, what all are the problems we are having, we are hiding ourselves only. Don't hide ourselves. And you people, why I am taking this class means everybody is coming and taking too much slides. So I am not liking that. You people have to understand, you have to find out in your family, and you people are teachers also. Okay, then first find out what's the problem the particular alcoholic students are having What's the particular problem she or he is having? First find out, and after that you people can treat easily. Please give support. Otherwise, they will not stop. Okay, anyway, I have already told the last one story I will tell. Okay, if we are giving the particular support to that person, she or he will stop. That's the sure. I have already told 230 counselees I have dealt. Okay, next. Okay, next on family matters. The effects of addiction on family, the family secret. Family requires intervention, all have affected, all need treatment. See, 4 members are in a family, the husband is like alcoholism. Then we have to give the treatment to everybody. Understood? Every time we are giving pressure to the particular husband means again, she or he will drink. Understood? That's the meaning. The family secret means family requires intervention, because we have to find out why why the particular wife is scolding the particular husband, why the particular children are scolding the mother, and we have to analyze the particular family matters and all. Okay, that is the meaning of this PPT. Okay, stages of addiction. You can read this one. I will not explain. You can read. You can see now. That side also you can see now. Can you hear me last? Okay, you can read this one. Okay, just read. What's your name? I'm asking to you. What's your name? You just introduce yourself, and after that you just read. How we are going to take addiction. See, addiction means not alcohol, everything, caffeine, anything, spray, everything we will get the addiction and all. Okay. You can see this one. Okay, okay. And introduce and you just tell. Okay.
I'm Arina from DMOS National College.
Okay.
Stages of addiction, active reinforcement, social training, exhaustion, compulsive use, binge drinking, dependence, withdrawal.
Okay, anyway, thank you. Okay, okay. Anyway, acute reinforcement, social drinking, because whenever we are going to particular time and all, okay, we will drink together. What happened? What happened? Are you hearing or not? Okay. Acute reinforcement, social drinking, something. Whenever we are going to a particular party, we will drink. Okay, that is okay. Automatically, it will dependence. It will goes to the particular dependence, and whenever we are getting addiction, then withdrawal symptoms will come. Okay. Next, protracted withdrawal in the sense, whenever we are thinking, okay, one of the teacher told, okay, one of the council told, okay, don't use this one. Okay, then we are already withdrawed the particular alcohol, anything, then protracted withdrawal, because we are struggling for withdrawing that alcohol. Okay, that is called a protracted withdrawal. Recovery. Why I have put a question mark means recovery is in our hand only. Okay. Control yourself. Control yourself. That is the final PPT for me. Okay. Understood or not? Once again, I'm going to wind up my section. You people have to find out that you people will get too much notes from the psychiatry textbook. But everywhere, anywhere, the addiction means what? We people can find. And in this also, you people will use some of the materials like a substance use. And finally, I want to wind up the one thing, wind up with one story. ഞാൻ ലാസ്റ്റിൽ ഒരു സ്കൂളിലൊരു കൗൺസിൽ നടത്തിയ സമയത്ത് ഒരു 8ാം ക്ലാസ്സിലെ ഒരു കുട്ടി 14 വയസ്സേ ഉള്ളൂ. ആ കുട്ടി ഓട്ടോമാറ്റിക്കലായിട്ട് എന്താണ് കഞ്ചാവിന് അഡിക്റ്റ് ആണ്. ഞാൻ എന്തുകൊണ്ടാണ് മലയാളത്തിൽ പറയുന്നതെന്ന് പറഞ്ഞാൽ നിങ്ങൾക്ക് മനസ്സിലാവാൻ വേണ്ടിയാണ്. കഞ്ചാവിന് ഭയങ്കരമായിട്ട് അഡിക്റ്റ് ആണ്. അവൻ എൻ്റെ അടുത്ത് പറഞ്ഞ, സർ ഐ ഡിഡ്ന്റ് യൂസ് ദ പർട്ടിക്കുലർ തിങ് for 1 week. Then I have told, okay, that is very good. Okay, you are not using. Then I have asked, what's the reason? അവൻ എന്താ കാരണം പറഞ്ഞെന്ന് അറിയാം. സാറേ, ഒരാഴ്ചയായിട്ട് പോലീസ് ഭയങ്കര എൻ്റെ ഈ പൈസ ഇല്ലാതുകൊണ്ടാണ്, ഞാൻ വെയിറ്റ് ചെയ്യുവാണ് കഞ്ചാവിന് വേണ്ടി. പറഞ്ഞ കാര്യം മനസ്സിലാവുന്നതാണ് നിങ്ങൾക്ക്. ഈ സ്കൂളിൽ അത് അവന്റെ കൂട്ടത്തിലുള്ള 12 പേര് പെൺകുട്ടികളാണ്. ഡിഡ് യു അണ്ടർസ്റ്റാൻഡ് ഓർ നോ? എനിവേ, നിങ്ങൾ വളർന്നു വരുന്ന എന്തുവരും നഴ്സിംഗിന്റെ എന്തുവരും നിങ്ങൾ ഒരുപാട് സ്ഥലങ്ങളിൽ പോകുന്നതാണ്, പല ഡെലിഗേറ്റ്സ് ഉണ്ട്. അപ്പം നിങ്ങൾ ഏറ്റവും കൂടുതൽ ചെയ്യേണ്ട ഒറ്റ കാര്യമേ ഉള്ളൂ, എന്താണ്, നിങ്ങൾ ഫൈനലായിട്ട് ഡി അഡിക്ഷൻ എന്താണെന്ന് മനസ്സിലാക്കുക. നിങ്ങൾ നല്ലതായിട്ട് എന്ത് ചെയ്യുക, നല്ലതായിട്ട് വൈൻഡ് അപ്പ് ചെയ്ത ഒരു സെക്ഷൻ ഉണ്ടാക്കുക, അവരെ കൗൺസിൽ ചെയ്യുക, അവരുടെ വാട്ട് ഓൾ ആർ ദ പ്രോബ്ലംസ് ദേ ആർ ഹാവിങ്. ഫസ്റ്റ് യു ഹാവ് ടു ഐഡന്റിഫൈ ദാറ്റ് ആൻഡ് ആഫ്റ്റർ ദാറ്റ് ഉണ്ട്. അതർവൈസ് യു പീപ്പിൾ ആർ ടെല്ലിങ് ബ്ലാ 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 സംതിങ്, ഡി അഡിക്ഷൻ സെന്റർ ഈസ് ദയർ, that center is there, that is not worthful. You people have to counsel them, you people have to take care of them, and after that you people have to support them. Then only you people will get that person backward. Okay, thank you. I am closing my section and thank you for your support. And
audience, please get your doubts clarified related to the session. Now time is open for that.
you can ask any question to me, please. You should ask, because this is like a vast section. I only got 45 minutes, but it is not like 45 minutes talk and all. You can speak. എന്തെങ്കിലും ഡൗട്ട് ഉണ്ടെങ്കിൽ ചോദിക്കാം. Can shoot up the doubt and all. Okay, Marwa, you are having doubt. I am thinking about that. Okay, because I am not having time. My slot is going to over. Okay, you just ask. Anybody? Anybody is having doubt?
Now I invite Professor Isha S to present the moment to Mr. EMERGENCIES as a token of our appreciation. Thank you very much, sir. Audience, please be silent and listen to the next session. Dr. Salman, senior cardiologist, Rajasthan Scan. With an experience of more than 10 years in the field of interventional cardiology. And alumnus of the prestigious already lies in complex coronary interventions, peripheral vascular interventions, structural heart interventions, rhythm management device implantations, and advanced cardiac imaging including cardiac CT and MR. Dr. Salman Taylor's basic medical training, MBBS from Catholic Medical College, and his MD in internal medicine from MGM Medical College, Indore, MP, where he was at gold medals. He pursued BA cardiology from AIMS, Delhi. He is a member of the Royal College Association and a fellow of the European Society of Cardiology. He has several publications, national and international, to his credit and has co-authored several books in cardiology. It's my honor to invite Dr. Salman Taylor to talk about emergency management of acute coronary syndrome. Welcome you, sir.
Thank you very much. Thank you very much. This should be given on February 14th, I think, but so then 2 days late. I'll still keep it anyway. This is to wake you all up in case you were sleeping. Yeah. Just excuse me for just 1 minute. Right. A very good morning to everyone. Yeah. So at the outset, I'd like to thank the organizers of this wonderful conference, Dr. Asuma, Dr. Shajila, and the whole team. I think these guys are doing a very good job. A fantastic topic here on nursing emergencies. Like I said yesterday, the object of this CME, I think, you guys will be bombarded with so much of topics. It's imperative that at least a few points one should take home, and that will add to your particular, everybody has one storage of information. It's not infinite, but take a few points from my talk, take a few points from the next talk, take a few points from the previous talk. That should be good. Ranjit, E-light and no, this one. Ceiling light. Ranjit, ceiling light off. Right. So I am in the Department of Cardiology here, and today's topic, which I'm going to discuss, is on emergency management of acute coronary syndromes. Okay. So who all are familiar with the term acute coronary syndrome? Could you just raise your hand? Acute coronary syndrome. Who all has heard of this terminology? This word, acute coronary syndrome. Just raise your hand. Nobody's going to put you in jail or anything. Nobody's heard of the word acute coronary syndrome. That's fantastic. Nobody. So then I think I'll go back. Okay. See, acute coronary syndrome, if you talk to a normal person, it's another word for a heart attack. That's all. Okay. So like MI, so the acute coronary syndrome. So we will, yeah. So I'm quite surprised that nobody's heard of this terminology. Surprised and disappointed. Anyway, okay, so we're just doing the Zoom sharing right now. So acute coronary syndromes is a terminology for all these chest pain syndromes which are due to coronary artery disease. And previously we used to say MIs and all this. So since there are a lot of different types of MIs which we'll be discussing, so that's why they've all clubbed it into the terminology of acute coronary syndromes. So that is that. So what we are going to be discussing is acute coronary syndromes. Okay. So unfortunately, in our country, ischemic heart disease is the most prevalent cause of morbidity and mortality, and it's the #1 killer in our country. So one might think that it's road traffic accidents, one might think it's cancer, one might think it's stroke, but no. Cardiovascular disease is the #1 cause of death in our country. So since we hear people dying left and right here and there, so not much of us are very much observant of this particular fact, but all of us have a role to play in this particular disease. So knowing this, especially as nurses, especially as physicians, the healthcare professionals, understanding the symptoms of coronary artery disease and coronary syndromes will help us save one life at least in the future. So that's the point of this particular talk, So we have a relative, we have a patient who's coming with a probable acute coronary syndrome. we know how to deal, we should know how to deal with it in the basic way and what should be the treatment for that particular patient. And that patient which you treat is going to survive. Okay, so you have a 40-year-old guy who comes with chest pain and he says it is gas trouble, and then you say it could be an acute coronary syndrome, and then you admit the patient and then you give him on the correct treatment pathway, and then he was otherwise scheduled to die that evening, but because you intervened properly, he survived. See, that's very important. You see a lot of people dying because they don't have the opportunity to correct treatment and correct care. So another person thought it was gastrics, he took some Gelusil, he drank, he sat there in the evening, he's dead. So that's a problem. There's a big burden for coronary artery disease, which not like we think. It's very important and which we should pay a lot of attention to. Coronary artery disease, like I said earlier, if you can divide it into stable and unstable coronary artery disease. Again, a stable coronary artery disease means I have a block, okay? So, but it's around like a 70–80% block. I don't know about it. So my symptom is that for last 4 years, I've been having angina on exertion while climbing up 4 flights of stairs. That's it. Otherwise, no problem. I'm doing normal activities and all that. It's been there for 3–4 years. If I climb the 4th floor, then it's just painful. This is stable coronary artery. It's there. It's not disturbing me much, but it's there. Now, people can have different varieties of stable. That is, if it is more severe, he gets it on minimal exertion, moderate exertion, or severe exertion. So that's how you define stable artery disease. It's been there for some time and then it's continuing only on exertion. What is unstable? Now, unstable means it's not like that. It is happening at rest. The patient was okay for the last so much time. Since 2 days, he's been having recurrent chest pain. So that's something unstable is going on inside that coronary artery. So that's unstable. Now, within unstable CAD, so this unstable CAD is called acute coronary syndromes. Okay. Now, acute coronary syndromes means something which is happening acutely and it's happening a chest pain syndrome or something which is related to the heart and it is unstable. Now, we have defined distributed acute coronary syndromes as 3 types. You have unstable angina, you have non-ST elevation MI, and ST elevation MI. Can anybody raise their hands who have heard any of these 3 terms in the past? I have heard. Okay, now some hands are going up, so that's good. This side, nobody has heard of him. That's very nice. So this part has not heard of these syndromes. Maybe they cannot see from there. I don't know. But yeah, so this is important at least. So from a cardiology perspective, when a patient comes with chest pain and it is a cardiac chest pain, he will fall under one of these 3 syndromes, either unstable anginas, NSTEMI, or STEMI. Okay, we'll discuss each of these, what is happening. Now, mind you, a patient who comes with chest pain to the casualty, 100 patients come with chest pain, 70% are going to be non-cardiac, okay? Around 70–75%, or 20 or 25% only are going to be cardiac chest pain. If it is a cardiac chest pain, he's having an acute coronary syndrome and will be one of these 3 things. These 3 things are clinical diagnosis. How we are going to understand? So we look at, what do we look at when you get a chest pain? What do you do in the emergency department? We do an ECG, troponin. So these are the basic things which we do. So if a patient has STT changes, look at ST segment depression or T inversions, and his troponin comes out negative, okay? He's got chest pain, his ECG's got some changes, but troponin is coming negative. We classify that patient as having unstable angina. So that means it is an acute coronary syndrome, but it is, out of the 3 variants, it is one of the earlier categories. Now, the second category is the patient has got some STD changes. He's got chest pain, but his enzymes have come out positive. The troponin is positive. He is therefore classified as non-ST elevation. So ST elevation has not happened. So I'll go to ST elevation next. That patient has got gross ST elevation. ST is the ECG change which you're seeing. So this is the highest grade of an acute coronary syndrome. That patient has got severe pain. So this is called what we say a massive heart attack or something like that. So STEMI is because is the topmost VIP category in acute coronary syndromes, and you need acute, fast, immediate emergency care. And STEMI, we are calling it non-ST elevation because ST elevation has not happened. So what happens actually in an ST elevation MI, what happens? The coronary artery is fully occluded. In end-STEMI, it's actually a partial, something like a 99% disease. Some critical flow is there, which is maintaining circulation. That's why ST elevation has not happened. In unstable angina, it's something like a spasm of a tight disease, and infarction is not happened. Once there is myocardial injury, your troponins rise. Okay. In ST elevation MI, you don't actually need to look at the troponin because ST elevation itself is enough. You do not wait for troponin. You have to initiate treatment. Okay. Now, other than that, if you have a chest pain, you have some ECG and the troponin is positive, it may be other things other than MI. So like myocarditis, pericarditis, pulmonary embolism, Prince metal angina, and aortic stenosis, hypertensive emergency. So these are all not very common, but it can happen. You should keep it in the back of your mind. But the first and foremost importance is for a acute coronary syndrome. Right. So now suppose we have this guy. So we'll start off with this case. So this is a 58-year-old gentleman. You can see him all exercising very well. He's a very fit guy. He never smokes, never drinks, good past health, no family history. He does swimming, regular exercise, aerobics. Okay. And then suddenly, one fine day after swimming, he's got the central chest pain. Okay. Got central chest pain. And previously, he didn't have any angina. There's no sweating, no shortness of breath. And after 1 hour, he's okay. He's comfortable. So then he comes to casualty and you are having a look at it. Okay. So, and then you look, okay, is everything okay? BP is okay, pulse is okay, temperature is okay, he's looking fine, he's comfortable. He's saying that he had 1 hour back, he had some chest discomfort. So what do you do? Okay. So Google his symptoms, what it could be, what could it be? So that, is he having something? So what do you do? So this patient will tell you what, okay, it's not chest pain, it's not cardiac attack or chronic problem. Still I had some chemin biryani or something like that, and maybe some gas trouble. This is all the patients will say like this. Why? Because whenever an earthquake happens, it'll either be in Indonesia or Turkey. It can never be in Calicut, no? Always earthquake happens somewhere else. Always a volcano will erupt somewhere else. We always think that we will not get that disease. So that's how the brain works. It is not going to happen to me. So that's the human psychology, is that this is how it happens. But what the caregiver, like us, the healthcare profession, should ask for typical and atypical symptoms, whether how typical is an angina. Ask all about how long has it been, do you have any risk factors? Did he, if he's a chronic patient, did he use any sublingual nitrates and all that? So that is a crucial part of the evaluation. So it's not only chest pain. Angina equivalents can also, they can say central chest pain, going to left arm. You could say, some people say pressure, some people say tightness, discomfort in the chest. Sometimes you may go to the epigastric region, sometimes you go to the neck. Jaw discomfort is very, very highly specific in my experience for this. If a person says chest going like this, is definitely there's a coronary artery disease. And some people who are diabetic may say just dyspnea and sometimes even fatigue. So you have to be cognizant of this fact. Now this chart shows, the right side shows which are the likely symptoms suggestive of chest pain, like how I said these symptoms. If it is on the right side, like sharp pain, putana pain, poking pain on deep inspiration, these are not like cardiac, some positional pain, you turn this side pain, turn that side pain, look up pain, those are not cardiac. Deep breath pain, that's not cardiac. So pain on little bit exertion, heaviness, central, these are the typical pain. So assessing the typicality of pain is very important because everybody need not have an ECG variations. Then obviously we're going to check the ECG. As I said earlier, we differentiate whether it is ST elevation. After you take your quick history, you check whether an ECG ST. Once you ST elevation, all the history taking stops and you have to immediately triage for treatment, obviously. If there is no ST elevation, you look for dynamic changes and then see if you want to do. So this is the patient's ECG, okay? Now, most of us may not be very familiar with ECG reading, but the basic cardiogram we need to know. So this ECG, is there anything wrong with this ECG? Yeah, how many think this ECG is abnormal? Very few think it's abnormal. So actually it's a normal ECG. Okay, so there's nothing wrong with this. You can see the ST segment and all is okay. Let me see. Laser pointer, yeah. So we look at this area, the ST segment, we look at the T wave. So T wave is all upright everywhere. See, it's up, 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 up. Here, T wave motion AVR is a normal finding. Sometimes you may get in lead 3, that's a normal finding. So if you don't see any gross, it's okay. So this patient has got a normal ECG. Now this patient has got chest pain, normal ECG. Now you're again scratching your head. Now what to do? Now this is another big problem. Now we just send him home. What to do now? We'll give him some Pantocid. That's a big problem. So that is why evaluation of history is very important. When you have typical symptoms, irrespective of the ECG, you have to take care. So do you discharge the patient? Do you admit and observe? Do you start aspirin? Do you start heparin? Do you start streptokinase? Do you call the cardiologist on call and send for a primary angioplasty? That's difficult. So here that can be a dilemma. Whenever you're in doubt, whenever you have to admit and observe for serial ECG changes, serial troponin estimation. That is the only way you can find out. If it was an ST elevation, it is very easy. If you have dynamic ST change, you have to look for that after 1 hour. If the patient has a recurrence of pain or some ST changes, that's the problem. If he has ST depression, you have to find it out. T-wave inversions, you have to look for. A normal ECG does not exclude an acute coronary syndrome. Like I said, in unstable angina, the patient can have just typical pain, but ECG, it's not visible, that's all. So serial continuous monitoring yields increasing lead. So this is how generally how this is going to be looking like. So this is an normal ST segment. This is ST elevation, and this is an ST depression. So at least you should understand the ST going up and down is one basic thing which you should try to see. If you're seeing some ST depression, you escalate the problem. All the cardiologists say there is some problem. Even if you're at a primary healthcare facility, you know that there is something wrong in the ECG. Okay. Then comes the cardiac biomarkers. We all know cardiac biomarkers, troponin, we all, like most of you said. Then comes the other cardiac markers are CKMB and myoglobin. Okay. The most commonest one which you use is troponin. Myoglobin is just for theoretical purpose. It's the earliest marker which is done. Nobody uses this in clinical practice. CKMB is there, available in various peripheral health centers. It is good, but it has got a rapid decline downward. So it's not as sensitive as troponin. So nowadays, troponin is available everywhere, but wherever you have CKMB, that also can be used. Troponin is the most specific and sensitive for cardiac injury. Now, cardiac injury means troponin will rise. So it is the only one problem is you have a lot of renal dysfunction. If you have renal dysfunction, like creatinine is 4 or 5, little bit of troponin can be elevated. Otherwise, very specific for cardiac injury. So when a person says some atypical pain, the troponin is minimally elevated, it is a red flag. You should admit the patient and start treatment. Now, in the troponins, the guidelines in the American Society all recommended high sensitivity troponin is better. So you have the classic troponin and the high sensitivity troponin. Most of our labs nowadays have high sensitivity troponins. Now, one interesting thing which I want to show you is troponin. Why it is very good is this blue thing which you're seeing on top is how the troponin rises. You know, it's like your pregnancy test. Now it starts positive after 9 days, the urine pregnancy, something like that. This one starts only after 3 to 6 hours, the rise. Then it will peak at around 24 to 36 hours over here, and then it will stay positive for 1 whole week. Okay, so the patient says 4 days back I had a pain, but then that time I did not say pinna makkal parni endailum can't say thiru. So then they come after 4 days, then what you do? So then you say troponin can still be positive, and that helps us in diagnosing the previous acute coronary syndrome 4 days back. So troponin rises for around 4 days. CKMB is not like that. CKMB comes down within day 1 or day 2. So then the duration is that, and the peak duration is less. So that's why we use troponins a lot. The only negative part of troponin is that it takes time to rise. So suppose if I have pain right now, so immediately if I go to troponin, it will not be positive. So I have to wait for around 1 to 3 hours for it to become positive. So till that time, I have to look for the clinical features. I have to look for the ECG and the hemodynamic parameters. That's the most important thing. Now back to this, our original case. Our poor guy is still sitting there in casualty. What to do with him? So we admitted him because you people said that his pain is very typical. So we said, okay, chalo, we'll admit him. Then ECG repeated, but no interval change. The second set of markers, the first one was like the second set, CKMB and the troponin was markedly elevated. We started him on medical therapy, did an angiogram, an LED, there was tight 90% block, an angioplasty, and stenting was done. So this is how an angiogram looks. This is the left anterior descending artery, which is the main artery of the body, of the heart. And you can see a 90% block here, which was stented. So this person, so you say he's very much exercising, he's a fit guy, he doesn't have smoking, alcohol. how he develops this. These things, there's no answers for all of these things. People develop. This is genetic predisposition. He may have had dyslipidemia, which he did not look. He may have had family history, but we don't know. But when a person comes with typical symptoms, you cannot negate the fact. Patients will keep on telling you that it's gas and all that. Even when we get, if we, in God unwilling, that if we were to get some, we will always think that it's something else. But look at the typical features of a central crushing pain, heaviness, radiating to left arm, radiating jaw, and lasting for some time, increasing on exertion. That's a cardiac pain, and do an ECG and copy. So that's how we evaluate such a patient. So this shows that even the absence of common risk factors does not mean that ACS is impossible. So how does the probability increase? Suppose a patient is having diabetes, smoker, hypertension, dyslipidemia, age, family history, so then obesity. So then the probability keeps on increasing. So for this person, we were having our little bit confusion. It's the same guy, if he's 65-year-old, diabetic, smoker, family history of heart disease, previous pain, then he's having chest pain. There's no confusion at all. Confusion is going to happen in the young chap who's exercising, who's having a chest pain, and we want to think that he's not having chest pain, a coronary problem. That's the important thing. Okay. So there, if anybody of you who are in future going to work in a different setup, so you can be working at the primary, secondary, or tertiary level cares, the recognition of this is very important. That is most important. See, if there is a great ST elevation MI, nothing is going to happen. Why is there's not going to be a diagnostic problem? Because somebody will see ECG and say, take an ambulance and go to a tertiary level care. Now the problem is going to happen with this patient. Somebody tells that you don't have anything, and you take some pantoprazole or something, and you take some Inji, Valtuli, and then gas medicine and all that, then there lies the problem. So if you evaluate it properly and your clinical sense was sharp, you will escalate the problem. Serial monitoring is very important. So we'll go one by one into each of the clinical syndromes which I told you. STEMI. So we call this STEMI, ST elevation myocardial infarction, which is the biggest coronary syndrome which we are all. So the common man will say massive heart attack, belly attack, all these things, but this is the most important thing which one should be very careful of. So what happens here is this particular thing. This what we are seeing is the ST elevation. This is the syndrome which we are all scared of. This means that the main artery, coronary artery, is fully occluded. Okay, it's fully cut. Cut meaning it's occluded, and so that whole area of the heart is undergoing necrosis. The ST elevates. ST elevation is a sign of that. The other things like TV inversion and all that is seen in your non-ST elevation. So in management of STEMI, it comes after in different ways. So what all we can do in a pre-hospital setting? The initial management in the ED, then reperfusion, meaning reperfusion means you want to perfuse the coronary artery and perfuse the heart. We'll discuss on that. Initial adjunctive therapy, pharmacology, what we give, and risk stratification after MI. So these are the broad headlines. So pre-hospital management very important. Again, different levels of care. I'm getting a chest pain in my house. Depending on where you stay, like if you're in the West, you're in the Middle East, you're in India, you're in a rural area, you're in a forest area, you might have different outcomes for this. Time is myocardial, regardless of the strategy. So prompt reperfusion is important. So many people, they don't seek care for many hours, but ideally, we need to have some emergency medical service to initiate treatment of this. So what happens here? This is a chart which shows the typical delays which happen. So this patient is having chest pain. He himself wastes a lot of time thinking that it's gas or something like that. Then after some time, his kids and all say, "Chalo, we'll call somebody. We'll try to call an ambulance if it's available." And then that ambulance delayed to come to pick him up. Okay, all that time the heart is getting damaged and damaged and damaged, and then you come and then you do something. Whether you diagnose a STEMI. And then there is some system delay, the hospital is there, from casualty, go up to cath lab, whatever. So all this, the patient delay, emergency medical service delay, system delay, all this contributes to the total ischemic time. So whatever we can do once you diagnose a STEMI to bring down this time, you can save his heart. I don't know if many people of you have seen patients with heart failure in our ICUs and all that. Heart failure patients, a big majority is because of this ischemic time was very delayed. That heart muscle becomes permanently damaged and therefore it becomes heart failure. Then there's nothing to do about it. You have to prevent this so that this ischemic time is clear. How do we do that? Okay, now if we have a good setup, now a good setup is something in our imagination, but unfortunately, even in here in Calicut, we don't have this good setup. But ideal situation, what should happen? You have symptoms, immediately you call your ambulance services, and then immediately EMS services dispatch an ambulance, and on the scene, the person takes an ECG at home or while in the ambulance, and then contacts the cardiologist or the physician in the hospital, diagnoses that this is problem like an ST elevation MI, immediately give your loading of aspirin, clopidogrel, and if possible, start streptokinase if the cardiologist okays it during the ambulance before reaching the hospital. Such a patient, if you are able to do, his heart muscle is going to be back to normal in most of the cases. But it's difficult. It's possible, but it's difficult because there are a lot of delays, system delays, which is happening. So anyway, so pre-hospital management is very important. So from there, the ambulance has to decide whether the nearest hospital is PCI capable, that is emergency angioplasty capable, or non-PCI capable. So that's a big thing. Now, how to understand that? That is the thing. So here, if the time to PCI is, if you can do it in less than 120 minutes, if you can go to your nearest, the cath lab procedure starting, if you can manage it within 2 hours, you should immediately go there. Suppose if you are very far and your anticipated delay to get to such a hospital is very far, you have to go for a thrombolysis therapy. Okay, once you're in the casualty, you have to do all your basic stuff, your ECG, monitoring, take your bloods, take an X-ray and all that. And then you have to decide on this flowchart. This flowchart may be a little bit confusing, but the important thing is two things: whether you do emergency angioplasty or you give streptokinase, fibrinolysis. Okay. Now, fibrinolysis, for example, in our hospital, in our department here in ASTER MIMS Calicut, we've stopped fibrinolysis since last 20 years because we are a primary PCI enabled hospital. So anybody who comes here will immediately go for a primary because that is the superior modality for treatment. Now, if you do, your hospital does not have that. Okay. So if you're saying that you can transport this patient within the next 30 to 60 minutes to the nearest primary PCI hospital, then you should do that. No, it is 2 hours far. Okay, then you thrombolize because time is myocardium. More time you waste, more muscle is getting damaged. After some 4 to 6 hours of an occluded artery, that heart muscle becomes permanently damaged. So that's the problem here. So this is the flowchart just to say that if your door to balloon time and stuff like that, how much time you have to make the decision whether you want to thrombolize here or you want to refer. If your referring time is too much, then you thrombolize and then refer. If you can go within half an hour or something, do that. That is better. So this is what that chart shows. If your anticipated time is more than 90 minutes for referral, the lack of access to a skilled PCI center, and or yeah, if you have less than 1 hour symptom onset, that is just fresh MI, 30 minutes, you can immediately lyse. So that's even better than maybe or cath lab access is not available, difficult vascular access. All these patients, you go for fibrinolysis. In primary PCI, which is the better treatment, you have to do it irrespective of in patients with cardiogenic shock, increased bleeding risk. Streptokinase has got a bleeding risk. And when the diagnosis in doubt, elderly age like 75 plus, we don't want to give fibrinolysis. And when you have a delayed symptom, 3-4 hours of pain, no point in giving fibrinolysis. Fibrinolysis works only if you are within 0 to 3 hours. Okay. So these are the general things, and success depends on time of therapy. Generally, within less than 30 minutes, very good for thrombolysis. Less than 90 minutes, very good for primary PCI. Okay, so these are the agents like streptokinase, alteplase, the retaplase and tenecteplase. These are the usual drugs which we give for thrombolysis. The different doses are given. There are absolute and relative contraindications. Basically, if you have had a recent major surgery, a recent bleed, or anything like that, which has got a bleeding tendency, you do not give thrombolysis, whatever, because this patient will just die or have some. Relative is if you had a recent minor stroke, pregnancy, 1 week postpartum, anything which is predisposing to bleed, you have to. So that's why history is very important. PCI and STEMI, if it can be done rapidly, lesser risk of recurrent MI, and that's good. So this is just exactly what I said earlier. Primary, this is a slide which shows about early primary PCI. Okay, so early adjunctive treatment. So what are the other pharmacology which we give? We all know that so many drugs. This is a pharmacological slide where what are the drugs? Can any one of you tell us what are the common drugs which we give in an MI patient? Very easy. Aspirin, clopidogrel, statins. Yeah, stop. Okay, that's good. That's good enough. So aspirin, and so you need at least 2 main drugs. That is an aspirin and clopidogrel. Aspirin plus clopidogrel is actually called a P2Y12 inhibitor. That's the pharmacology, because there are 3-4 types of clopidogrel. P2Y12 inhibitors. Can be either clopidogrel, prasugrel, or ticagrelor. Now ticagrelor is also called Brilinta. So for ACS management, ticagrelor is nowadays preferred because it's got a better efficacy. So aspirin loading plus one of these drugs. So any P2Y12 inhibitor you have to load. Okay, so the loading is, I'm not getting into pharmacology, and also it is good to load a statin also. It is not in the class 1 recommendation, but statin loading early will help in plaque stabilization and better outcomes in the future. The other things which we give are GP2B3 inhibitors. These are IV antiplatelet agents. Heparin you may give. Oxygen if the patient is having some kind of pulmonary edema. You can give morphine, which is a very good agent for pulmonary edema, as well as pain relief. So opioids, especially morphine, is very cardio friendly. Beta blockers may be given in the first 24 hours. And NTG if the patient is having ongoing pain. ACE inhibitors for heart failure, and of course statins. So these are the other drugs which I'm not getting into details. So you go for a PCI, or once you do an angiogram, whether you want to do PCI or CABG depends on the anatomy. I'm not going to get into that, it's not very important. Right. So a patient who's having multivessel disease, very difficult anatomy, very calcific anatomy, after an angiogram, you may need to go for a CABG. Sometimes we just do a small ballooning and then send after 1 week for CABG. That's the point of this particular slide. So yeah, so after an MI, risk stratification is there. Suppose we tried all our best, but still the LV function is bad. Whether this patient is at the risk for the most commonest, biggest problem after an MI is tachyarrhythmia, ventricular tachyarrhythmia. So we have to evaluate whether there is an arrhythmic substrate. This patient, one will say that we did an angioplasty, very successful, and then we go home, patient dies. Why that happened? Because that patient can develop a VT. The ischemic myocardium is very sensitive for this thing and can develop VT. So that's why we give beta blockers as a class 1 agent to prevent ventricular arrhythmia. So this kind of stratification, if the patient has a large MI, you have to give beta blockers. Smallish MI, you can give lesser dose of this thing, but arrhythmic substrate we have to quantify is what is important. In ischemic risk, after 1 month, we can do stress test to see how well we did and all that. That's okay. LV function, again, after 1 month, we do an echocardiograph to see how well the LV function improved. In arrhythmia risk, which I mentioned earlier, some people have got severe LV dysfunction even after 35 to 45 days. Such patients, we can also be a candidate for ICD implantation for prevention of sudden cardiac death. In the US, all patients after an MI, if you have severe LV dysfunction after 1.5 months, they get a prophylactic ICD implantation for prevention of sudden cardiac death. We don't do that here because of cost issues. Primary PCI is the standard of care, which I said earlier. Like this, for example, this is a 65-year-old patient whom we saw recently. He had crushing central chest pain. What do you think this ECG looks like? What is there here? There is ST elevation in V1, V2, V3, V4, suggestive of it's an anterior ST elevation MI. So V1, V2, V3, V4. This is the anterior leads. This is anterior. Anterior ST elevation MI is a big thing. So we did the initial. So once you get anterior ST elevation, there is no cost, no question. You have to take them for a primary PCI. So this is what we did. This page. This is an angiogram which is showing. What you're seeing here is, this is the left circumflex. Here, there was supposed to be another black, but it is fully occluded. You can see that in this next coming up picture. Yeah, this is supposed to have been a big artery over here, but it is totally occluded. So what we did was, Next slide. This is how we do an angioplasty. We put wires into this particular artery. We try to aspirate the contents. We may need a balloon like in the next image that you're seeing. And this is the final angioplasty result. Okay, what you can see on the left here is a fully opened up artery. Just to compare, if you want to, sorry. Yeah. This is the post angioplasty. You notice that it was totally occluded before and it's fully opened up. So basically, this much area of the heart was under risk. This is the part which becomes necrosed, and this is the part which is causing the chest pain. So there's a stent here which is successfully being placed. Okay, so this patient is a 44-year-old lawyer having burning chest pain since 2 hours. What does this ECG show? Again, ST elevation, but here it is more in 2, 3 and AVF. This is suggestive of an inferior ST elevation, which is also very important. And this patient, again, if you are in a PCI center, you immediately take up for a primary PCI. Okay, we took up for an emergency angioplasty, and we saw that you see this is the right coronary artery, which is totally occluded. It is supposed to be coming all the way down. Again, right coronary artery is occluded. So what we do is we put a wire into that and we start to extract all the thrombus. This is the kind of thrombus which we get after thrombus aspiration, which is inside the coronary artery. And then you see there is some flow happening after taking out the thrombus. Some little bit flow happens, but then the full flow is restored only after putting a stent. And this is the final result. So then you see the beautiful reperfusion which is happening after this thing, and the chest pain resolved and it's shifted to ICU. So we are able to, the why fibrinolysis, this is better than fibrinolysis, because in fibrinolysis, the opening up rate is only 50%. It's like a toss of a coin. It may open up, it may not open up. In primary PCA, we are ensuring, we are guaranteeing that we'll open it, we are not leaving anything to chance. In fibrinolysis, if the clot is very hard and organized, it may not resolve. That's the problem in fibrinolysis in streptokine. So that is why primary PCI is the treatment of choice. This is another patient, 35-year-old student. Okay, he had anterior ST elevation. I took him up. So this is your shot, which is, you can see here. There is supposed to be a big artery over here, but it's totally blank. Totally blank. This is an occluded LED. Okay, again, we did a ballooning and a primary angioplasty, and this is the final result. Okay. Sorry. Yeah, this screen on the right, this is the final result, which is showing the opened up artery. Young people also get anterior wall MI. That's the problem. One day we used to say only for 60 plus and all that. All that is gone. Our ICU is always filled with 35 and 40 years of people. So our risk factor modification is something we should always tend to. So unstable angina and NSTEMI is the other one. These are usually clubbed together, unlike STEMI. This is, you may not rush up to this thing. So unstable angina and NSTEMI, like I said, in unstable angina, the tropa is negative. In NSTEMI, the tropa is positive. That's the only difference, but the management is similar. In that, once you, what you need to do here is, what I would like to tell you is how to assess if the patient is having this thing. You go for the early or the 1 hour troponin. This is called the 0 or 1 hour. The European guideline says do 1 at 0, do 1 at 1 hour. What? Troponin. So the change of troponin at 0 to 1. Here we do at 0 and 3. There are some 0 and 2 guidelines. Now they are advocating 0 and 1 if you're doing high sensitivity. If it is negative at 0 and it becomes just a minimal positive also at 1, then you are diagnosing an ACS. That's the thing. But these all confusions happen whether you're confused whether it's an ACS or not. That's the main thing. This is called the 0-1 hour rule out test. Some people go for the 0-2 hour and all that. So then if you rule out and both of them are negative, you can discharge or observe in the ward. If it is ruled in with a positive 1 hour test, you have to admit it in the ICU and start treatment. Okay, again, these are the drugs which we use, the same similarly. Timing of invasive, we can probably go for an early invasive or a late. It's not as urgent as STEMI. Okay, so immediate invasive strategy is when recurrent pain, cardiogenic shock, ventricular arrhythmias, you have to go immediately, irrespective of this. Now, early invasive, that is within 24 hours, the patient is stable, but dynamic ST changes, risk scorings are available. You can do it within 24 hours. So that's how we do it in STEMI. You can give some heparin, wait and watch, stabilize, give some NTG, and then go for it. Okay, so these are the drugs and all that. I'm not going to get into that. We have a lot of risk scores available. These are all calculators which show us the risk elevation category, whether it's a high risk NSTEMI or a low risk NSTEMI. all these risk factors predicts the mortality. More the risk score, more the mortality. You can see those graphs at the end. More the risk score, the 14-day mortality is very high. What are the complications? This is my last slide. In all ACS, you can have tachyarrhythmias. Very important, always have a defib nearby you. You can have heart failure because of a large anterior wall MI. You need to give your IV Lasix NTG. You can have mechanical complications like cardiac rupture, valve damage, which needs specialized care, cardiogenic shock. You may need an IABP, inotropes, again, advanced care. Bradyarrhythmias, especially in inferior wall MIs, may need temporary pacemaker and atropine, and bleeding because you're giving all these agents like aspirin, clopidogrel, heparin, thrombolysis, etc., which may need to be managed appropriately. So, and pericarditis is also a rare complication sometimes. So the final message which I'd like to say is whenever we need to always stay vigilant of the patients who are having chest pain, have a high index of clinical suspicion to diagnose acute coronary syndrome and refer appropriately for such treatment. Thank you.
Audience, if you have any queries, now the session is open.
So usually when the moderator says the session is open for questions, no questions means either everybody's understood everything or they understood nothing. Nothing anymore. Yeah, so I think anyway, thank you very much. If there's no question, we'll conclude, right?
Now, I invite Dr. Shibita C.H., Vice Principal, Next for the Nursing President, Dr. Salah.
Thank you, thank you. Okay. Sure. Thank you. Thank you.
Thank you, ma'am. Thank you, sir. Dear delegates, you can replace now for your tea break and you can refresh yourself now. Thank you so much. Thank you.
emergency that requires immediate management. So what are the various psychiatric emergencies? Usually the psychiatric emergency service that is provided by professionals. Of course, the professionals are mainly from the field of medicine, nursing, psychology, and social work. And we all know that the need for psychiatric emergency, it is rapidly increased from 1960. The requirement for the various people and the requirement asset for psychiatric emergency has rapidly increased from 1960s, especially in urban areas. There are various reasons for the rapid increase in the need for psychiatric emergencies. I will come to that later. See, psychiatric emergency means it's a behavioral problem. So that could be manifested as violence. So usually in the professionals working in the field of psychiatric emergency, they are always exposed to the risk of violence. Usually the people coming to psychiatric emergency, so-called patients, they may come either on a voluntary basis, or they may be referred from other people of other specialty, including psychiatry also, or sometimes they may come from on an involuntary basis. Patients may not be willing to come for. Most of the patients are coming on involuntary basis only. They may be tied up and they may be brought forcefully to the emergency psychiatry department. So here, the intervention in psychiatric emergency that comprises usually the stabilization of the various life-threatening conditions. The life-threatening condition may be this psychiatric emergency could be sometimes a manifestation of underlying some other medical condition, or it could be a manifestation of the primary psychiatric condition itself. Sometimes the emergency medical condition could be, maybe it could be due to intoxication, it could be due to infections, or it could be manifestation of primary psychiatric condition, means it could be an acute psychosis, sometimes exacerbation of schizophrenia, it could be a sudden manic excitement. All these we will discuss later. So here immediately what we have to do that, if it is the condition is life-threatening to the patient, that will manage immediately, or if it is threatening to other people, that also have to manage. So depending on the condition, we have to work rapidly and urgently. So when we come to the history of psychiatric emergencies, I told you that there is a sudden surge in the need for psychiatric emergency service. That could be due to sometime, it could be due to deinstitutionalization. What is deinstitutionalization? That means recently, maybe over the period of few years, there is a tendency that most of the patients, they are admitted, long stay patients admitted in various mental hospitals. There is a tendency that all these patients are getting discharged. Maybe that is due to the invention of newer antipsychotic medicines. These patients can be discharged and sent to the community. But unfortunately, sometimes after reaching the community, many of these patients will stop medicines. Or even if they are continuing medicines, maybe due to some sudden life event, change in lifestyle or something, that can lead to exacerbation of their underlying psychiatric problem. So again, they may come to hospital, come with exacerbation, and they had to be hospitalized. So that is the impact of deinstitutionalization. Then, because of the increasing number of medical specialties, we know that we have got various medical specialties, subspecialties. So all these specialties will refer patients with psychiatric emergencies. So all these are the reasons for the sudden surge in the need for psychiatric emergency. See here, we are looking at the symptoms of the patient only. When the patient comes to the psychiatric emergency, immediately we may not be able to arrive at the psychiatric diagnosis. What is the immediate patient's presenting problem? Based on that, we have to manage. That means we are not looking at the diagnosis. We are looking at the symptom profile of the patient. So here we are giving only individualized care. Even if it is schizophrenia, we are not going to the protocol-based treatment for schizophrenia. Or if it is mania, we are not looking at the protocol-based treatment for mania. Sometimes the even if this is schizophrenia, the presentation may be violence. or even if it is mania, the presentation may be with a suicide threat. So what is the immediate presenting problem? That only we'll look at the initial phase. Then the delivery of emergency psychiatric services. See, the place where the emergency psychiatric service, the services are provided, that can be called as psychiatric emergency services. It is called as called in various names. Psychiatric emergency care centers, comprehensive psychiatry emergency program. We can call it in different names, but whatever be the name, the management is same. So here we are working in a team. So the team members are mainly the professionals from medicine, nursing, psychology, and social work. All these team members will work alongside psychiatrists and emergency physicians. See, we know that many of these people will come with intoxication, delirium, withdrawal delirium, poisoning. So definitely, so it could be the emergency service could be the manifestation of an underlying physical disorder. So definitely, the service of an emergency physician is essential. So this facility, the emergency psychiatric service, can be housed in a psychiatric hospital, it can be housed in a general hospital, or it can be the psychiatric emergency room itself, the casualty, so-called casualty. Then see here in emergency psychiatric service, we are providing 24-hour service, round the clock service we have to provide. It's a protected environment. Here, usually the patients, maximum we can keep the patients for 3 or 4 days. Within 3 or 4 days, we have to manage the crisis situation. Then once the crisis, that emergency period is over, then either we will, sometime we can discharge the patient and we can send the patient back home, or sometime we will send the patient for to the inpatient psychiatric ward, or we will send the patient to medicine, depending upon the presentation. We have to do that. So we have to find out appropriate alternatives to psychiatry. Sometimes the patient may not, there may not be any need to send the patient for psychiatric hospitalization. So we can send the patient to community. We can sometimes send the patient to a halfway home. We can sometimes send the patient to a rehabilitation center. So depending on the situation, we can do like that. Here, psychiatric, I told you earlier that the psychiatric diagnoses are secondary. Within the 3 to 4 days, we are managing the emergency psychiatric situation. And once the patient has come out from the emergency psychiatric situation, then only we'll think about the primary psychiatric diagnosis and the whatever protocol-based treatment that we'll think at the later stage only. So here we will assess the patient's problem. Here we have to implement a short-term treatment plan. So here maximum we'll have 10 meetings with the patient. That means 10 direct sessions with the patient. We can call it as a 24 hours holding area. All the emergency services we have to utilize here. Suppose patient has got cardiac arrest. Sometimes patient is in poisoning. We have to do the poison management techniques. Everything we have to have in this 24 hours protected area. And most of the psychiatric emergency services will have associated 24 hours telephone counseling also. It need not be only the management in a hospital or in a casualty. There we have to have 24 hours telephone counseling also, especially in suicidal cases and all. We need telephone counseling also. So what are the various psychiatry emergency conditions? Of course, suicidal patient, agitation, could be depressed patient, could be mania, could be schizophrenia, violence, could be due to any psychiatric condition. Then minor emergencies are grief reaction following the death of some loved one, near one, rape, disaster, panic attack. Then there are n number of medical emergencies that can come as psychiatric emergencies. Delirium due to many medical conditions, metabolic encephalopathy, acute extrapyramidal reactions, neuroleptic malignant syndrome, serotonin syndrome, overdosage of psychiatric medications, overdosage and withdrawal of many substances of abuse. All these are various conditions, emergency conditions. Then psychiatric conditions, schizophrenia, especially paranoid schizophrenia, exacerbation, mania, delusional disorder, personality disorder, especially antisocial personality, borderline, emotionally unstable personality, alcohol intoxication withdrawal, like that. Any other types of abuse, intoxication withdrawal can produce delirium. Then PTSD, post-traumatic stress disorder, dementia with the behavioral problem, even learning disorder to some extent can come as emergency to the emergency setting. Many neurological conditions, especially that the brain infections, viral, bacterial, any infection, encephalitis can present with behavioral problem. Herpes simplex, herpes encephalitis, HIV, all these can present with the psychiatric manifestations. Head injury, various type of head injury, seizure, post-epileptic phenomena, hepatic encephalopathy, Huntington's, Parkinson's, movement disorders, all these can present to the psychiatric emergency with a behavioral problem. Endocrine, thyrotoxicosis, thyroid crisis, hypothyroidism with sedimentous psychosis, manifest as depression with agitation, hyperparathyroidism with severe anxiety like panic disorder, hypoglycemia. Many patients they may think that it could be with the autonomic manifestation. Hypoglycemia can manifest with severe anxiety. Hypoxia, electrolyte, especially hyponatremia in elderly patients can come to the casualty with the behavioral problem. Hyperammonia. Hyperammonia is again a problem, especially in alcohol-dependent patients. Hyperammonia can manifest. Even sodium valproate can produce hyperammonia. So that can produce behavioral problem. Infections, even vitamin deficiencies, temperature, hypothermia, all these can produce psychiatric emergency. Then one of the important psychiatric emergency we have to consider is suicide. Suicide attempt is definitely a psychiatric emergency. That is number one psychiatric emergency. When we look at the suicide scenario in Kerala, you know that Kerala is called as the capital of suicides in our country. It comes to Kerala comes to the third state among the suicide states and compared to all other states. On an average, 9,900 people are committing suicide in Kerala every year. That recent rate is 27.2 per 1 lakh population. That means there is one suicide per hour in Kerala. Kerala population is only 3.4%, but the contribution of suicides coming from Kerala compared to the total national population is very high. Then the suicide rate is higher in urban compared to rural area. You know that the psychiatric emergency situation is more in urban area. When we look at the study of completed suicides, what we can see that 90 to 94% of the suicides are due to an underlying mental disorder. When we do a psychological autopsy, we can see that many of these people are suffering from a diagnosable, treatable psychiatric conditions. And the number one condition is depression, followed by alcohol abuse and schizophrenia. So depression is otherwise known as a new age killer because the suicide rate in depression is 15%. The risk is suicide risk is very high in almost all psychiatric conditions, but it is not that much for organic conditions. But for substance abuse, the risk is somewhere middle between depression and between the primary psychiatric conditions and this organic conditions. Suicide attempt is more in the young age group compared to the very children and other age group. And the suicide among 15 to 30 years is very high. And this number in this younger age group, the number of suicide is increasing over the period of time. Suicide is more common among unmarried people. But in Kerala, the situation is different. Kerala, when we look at suicides, 60 to 70% of the suicide is happening among married people. And see, even though I told you that suicide is more common in people suffering from mental disorders, in Kerala, the situation is different. Suicide is more common due to family problems, more common in married people, more common among people with the 30 to 40 years. So marriage itself is a risk for suicide in Kerala that we have to study, we have to explore. So this finding unmarried, unemployed, and most of these things are Western studies. What we need to have is our own studies and our own observations. But anyway, the suicide risk is very high among people with mental illness. Another observation is that suicide is more common among males, but suicide attempt is more common among females. So suicide more common in males, attempt is more common in females. That means female, the suicide attempt is a cry for help. So most of the people with a suicide attempt can come to the casualty. We have to take care because that is a cry for help. If you are not providing adequate help and if you are not able to find out the underlying reason for the suicide attempt, they may attempt within 6 months, the chance for committing a successful suicide is 60%. So what are the psychosocial factors leading to suicide attempts? Mainly some problem in the family, sudden loss of dear one, friends, or the important people in the family, humiliating sort of life events, unfaithful partner, infections, legal issues. These are the main reasons for attempting suicide. Among young, the reasons are mainly the relationship problem, exam-related anxiety, tension, etc. The most common symptom that forerunner of suicide attempt or suicide is hopelessness. Hopelessness, helplessness, worthlessness. So that can lead to suicide. Usually suicide attempt or suicide may be an escape from an unbearable situation or to produce some change in others or in the environment, or a combination of escape and sometimes it may be a manipulative action also. 50 to 80%, when we are looking at people with a suicide attempt, what we have found that 50 to 80% of these people have conveyed their wish to commit suicide. They have conveyed to the treating physician or even sometimes a psychiatrist also. But unfortunately, most of the time, that the chance for their suicide, that their suicidal intent was not detected, and that was the reason for their suicide attempt. Management, any case of suicide, any psychiatric patient or any patient with a crisis situation, you have to ask whether there is whether they are thinking or contemplating about suicide. So that should be in psychiatry. Asking about suicide should be a routine part of your assessment because that is a powerful predictor of future suicide attempts. See, there is a common belief that asking about suicide or suicide ideation will instigate or that will encourage the person to commit suicide. But that is totally wrong. That will not lead the person to suicide. So always in an emergency psychiatric setting, you should always ask every patient about the intent or their thinking about the ideas of suicide. In very severely suicidal patient and depressed patient, ideally to immediately to reduce the risk of suicide. What is the immediate treatment? ECT is the #1 treatment to reduce the risk for suicide. Of course, we have got antidepressant drugs. Now we have got ketamine. You know that for depression, for the immediate control of depression, for 24 hours control of depression, we can give ketamine. We can give ketamine either orally or intravenously, but the effect will be there only for 1 day. So antidepressants are there, ketamine is there, ECT ideal, and I told you, in an emergency psychiatric setting, we have to have a 24 hours helpline. In Calicut, we have got a helpline here, Tunnel Suicide Prevention Center. People can call or they can directly they can contact the center. They can call. They can email. They can WhatsApp. Lot of services are there. So that crisis intervention center is also very good for controlling suicidality. Now, another psychiatric emergency is psychosis. Psychosis can be an acute psychosis or an exacerbation of chronic psychosis, like schizophrenia. Sometimes patient can come with the exacerbation. So here, this is a psychiatric emergency. Here, sometimes acute psychosis we have to manage immediately with antipsychotics. Sometimes this chronic psychosis, that's acute exacerbation may come. So the reason for this acute exacerbation may be the patient might have stopped their antipsychotic drug, or patient might have developed some new life event. They may be taking drugs regularly, but suddenly they might have developed a new life event. Some of their dear one might have expired, that can lead to exacerbation, or they might have lost sleep for some time. So changing their life pattern, lifestyle. So these are the various problems that can lead to exacerbation of psychosis and presenting the patient to psychiatric emergency services. So depending on the situation, we have to manage accordingly. We have to obtain the first thing, any case and any emergency psychiatric setting, first thing that we have to get a detailed medical workup. Medical and psychiatric history, we have to perform a short mental status examination, whatever minimum psychological testing possible within that short period of time. Neuroimages, some very much needed, especially to rule out infections, injuries, etc. We have to do the appropriate investigations. Then within that short period of time, we will have a differential diagnosis. We may not be able to make the appropriate correct diagnosis. Differential diagnosis is enough, and then we'll prepare the treatment plan. So based on that, we'll manage the patient accordingly. If we are not detecting the medical problem, we may lose the patient. If we are not correctly identifying at least the differential diagnosis, we are not reaching about the psychiatric aspect. Sometimes it can lead to suicide attempt, suicide, etc. It can also lead to violence. So we should be always watchful about the patients coming to the psychiatric emergency services. Lot of personality conditions can also come to the casualty. Personality disorder is some problem related to their cognition, thinking, their affect or interpersonal areas, and that can lead to lack of impulse control and violence, impulsivity. These are the main problems with personality disorder. Especially, you know that emotionally unstable personality disorder, or the antisocial personality, borderline personality, histrionic personality, all will come in this area. So these are the people who will come to the casualty with emergencies. Emergency could be due to sometime impulsivity, violence, suicide attempt, drug intoxication, etc. So very difficult to manage these people. Unfortunately, the prevalence of personality disorder in psychiatric emergency setting is very high. Now, another psychiatric emergency is with the anxiety. Anxiety, I told you, it could be a manifestation of underlying medical condition. Hypoglycemia can come with the anxiety, severe autonomic activity. Thyroid, hyperthyroid crisis can come with the severe panic attacks like mitral valve collapse, cardiac arrhythmias, even ventricular fibrillation. People may come to casualty thinking that it is panic disorder. So we have to rule out that medical problem. Then it could be a manifestation of some primary psychiatric condition. Depressed people can come with the suicidality, they can come with the severe agitation, anxiety. Or it could be a primary psychiatric disorder itself. What is that primary psychiatric disorder? Panic disorder can come with the psychiatric emergency. Phobias, lot of phobias, generalized anxiety disorder, obsessive compulsive disorder, PTSD, adjustment disorder. All these can come to casualty with the severe anxiety. So first we have to give a safe harbor. That means we have to control their anxiety by various drugs. Anti-anxiety medicines are there. Then we have to find out what exactly is the reason for anxiety and manage accordingly. Then what are the disasters? We know that various natural disasters are there, like tsunami, flood. Then man-made disasters are there. Morvi Dam, no? Then Union Carbide tragedy. Lot of tragedies can occur, man-made tragedies. Sudden breaking of one bridge, something like that. So all these are various disasters. So that disaster can produce various reactions in the people. In the people, they are witnessing the situation, experiencing the situation. There may be a sudden shock. They may be feeling overwhelmed, immobilized, unable to do anything. They may develop sudden panic attack. They may be totally confused. So they can also have vivid memories, nightmares, apathy, withdrawal, re-experience of the same situation with a panic attack. What we will call that condition? Sudden re-experiencing of the same situation. And that is post-traumatic stress disorder. Then when the person is exposed to that severe sudden disaster, that can lead to panic, acute stress reaction. After some time, we experience the situation is panic disorder. So all these we have to manage. So here, in these disasters, especially man-made or water disaster, first we have to look at the medical condition. If it is life-threatening to the patient, we have to manage the medical problem. Then we will look at the psychiatric condition. If there is no any medical problem, if there is only panic-like attack or acute stress reaction, then we will manage the psychiatric situation. Okay. Then another psychiatric condition is emergency situation is abuse. Abuse can be physical abuse, verbal abuse, sexual abuse, emotional abuse is also there, emotional blackmailing. So all these are various types of abuse. See, usually depending on the vulnerability of the individual, capacity, coping ability of the individual, that can lead to various outcomes. Sometimes can lead to dangerous outcomes also. That can lead to anxiety, fear, hopelessness, helplessness, sleeping problem, etc. So management is usually a coordination of psychological help is there needed, medical help is needed, and legal consideration. If it is a rape, then what we have to do? We have to immediately inform the police about the criminal offense committed here. So we have to get identifying data, identification details, everything, and we have to have appropriate treatment, medical treatment, that physical examination, collection of medical legal evidence, determination of risk for pregnancy, everything we have to do. Then another psychiatric emergency is delirium. Delirium could be due to n number of medical conditions. So how can you manage delirium? Delirium, some psychological treatment that we can do for management is we have to keep the light on even at night. Why we are keeping the light on? To reduce their confusion. Then we have to remind the patient that this is morning, this is afternoon, this is night, and we have to tell the patient date, month, etc. Always we have to remind the person about the time, place, and person. What are the drugs we can give? Symptomatic management of delirium, what is that? We have to, for the agitation, restlessness, reduced sleep, delusion, hallucination, and all, we can give haloperidol. The dose may be from 0.5 to 2 milligram. We can give IV or IM. And if the delirium is due to substance or alcohol withdrawal, then the ideal medicine would be lorazepam. Anticholinergics are usually we will not give because that can aggravate delirium. Anticholinergic delirium itself is an entity, so we will not give any anticholinergic. Substance intoxication and withdrawal. See, all the substances of abuse, including alcohol, cannabis, cocaine, morphine, heroin, all these can produce intoxication and delirium. So what we have to do? If the patient is in delirious, patient will be very excited. So we have to calm down the patient. If the patient is very excited and if the restless, what we have to do? We have to restrain the patient. We have to restrain and we have to give medication also. We can give haloperidol. We can also give lorazepam. The dosage we have given here. If the patient is severely confused, febrile, and if the patient has electrolyte imbalance, dehydration, then what we have to do? We have to shift the patient to medical ICU because all these patients require urgent medical attention. Then once the patient's condition is stabilized, once the medical problem is over, manageable, then we can have our own psychiatric management. Then what about drug overdose? Drug overdose could be, most of the time the drug overdose may be psychiatric drug overdose. Many of these people will be taking psychiatric medication and they may be taking this medicine, psychiatric medicine, as overdose. So with the tricyclic antidepressants and carbamazepine, if they are taking overdose, that can lead to cardiac arrhythmias, that can lead to ventricular fibrillation and death. So we have to be very careful. If it is alcohol, barbiturate, heroin, morphine overdose, what will happen? Respiratory arrest. So always we have to keep a vigil on respiration and other vital functions also. If it is antipsychotics, what all things can occur? Acute extrapyramidal reactions, pseudo-Parkinsonism, dystonia, oculogyre crisis. Which is the life-threatening dystonia? Laryngeal dystonia, that can lead to stridor and sudden respiratory block, upper respiratory tract block, that can lead to immediate death. Akathisia, all these are various emergencies related psychiatric drugs. And then how we can manage dystonia? We can give anticholinergic drugs like promethazine, Phenergan. What is neuroleptic malignant syndrome? It is a very life-threatening complication with antipsychotic drugs, especially if the patient is getting high dose of parenteral antipsychotic drugs, especially with the high potency antipsychotic drugs, like haloperidol. If the patient is getting injectable haloperidol, very high dose, that can lead to NMS. So NMS is a very life-threatening, chance of death is 20%. If the patient is febrile, tachycardia, hypertension, tachypnea, confused state with autonomic dysfunction, then always we have to keep the probability of NMS. Immediately stop the offending drug. We have to manage the patient symptomatically. We have to correct the fluid and electrolyte balance. Antipyretic measures we have to start. Then what is the ideal drug? It is due to central dopamine blockage. Central in the midbrain dopamine blockade is the reason for NMS. So we can give dopamine agonist, bromocriptine we can give dandrolene. These are the drugs for NMS. Then serotonin syndrome. See, for depression we are giving SSRIs, specific serotonin reuptake inhibitors. If you are giving SSRI in combination with the MAO inhibitors, you all will be knowing about MAO inhibitor drugs. If you are SSRI combined with the MAO inhibitors, that can produce serotonin syndrome, which is almost like NMS. So here again the symptoms are hyperthermia, increased sweating, confusion, excitement, hyperreflexia, hypotension. So again, that can lead to dangerous consequences like disseminated intravascular coagulation, rhabdomyolysis, cardiovascular collapse. Chance of death is very, very high. So if all these symptoms are there, immediately you have to give the possibility for central serotonin syndrome. You have to manage. What are the drugs? Dantrolene, cyproheptadine, these are the drugs. ECT, most of you people might have seen ECT, but many of you people have seen ECT in films, but that is not ECT what we are giving in psychiatry emergency. We are giving ECT as modified ECT under general anesthesia will give with the muscle relaxant. So under anesthesia with the muscle relaxant. ECT is ideal for highly suicidal and depressed patient. If the patient is not taking food or fluids, not taking medicine, if the patient is catatonic, if the patient is very violent, if the patient is not if the patient is not responding to medicine, then the ideal treatment would be ECT. Generally, for any psychiatric condition, 6 to 12 sessions of ECT is needed. That convulsion, that should be there at least for 20 seconds. See, when the patient is totally paralyzed with muscle relaxant, how can we detect that patient is having convulsion? We'll put 2 EEG electrodes, and by looking at the monitor, we can find out whether the patient is getting seizure or not. Then, then the next non-specific, not psychiatric diagnosis. When a patient comes to psychiatric emergency with agitation and violence, what we can do? Usually, violence is more common in unemployed young people, less than 40 years. These people are more prone to have violence. Coming from low socio-economic group, if there is past history of violence, if the patient is not taking medication, psychiatric medication, there is a chance for violence. So what are the predictors, signs of violence, impending assault? They may be showing anger, they may asking for demanding immediate attention, loud voice, excitement, staring eyes, staring look, flared nostrils, flushed face, hands clenched or gripping. They may be pacing up and down the room, pushing furnitures. They are uncooperative, suspicious, with the scanning eyes. They may be shouting, sudden movements. All these are the predictors of impending violence. So how can we treat them? We can give non-specific sedative agents, especially antipsychotics. Haloperidol in combination with the lorazepam we can give for controlling violence. We have to give physical restraining also. Then once the patient is under control by giving injection, by physical restraining, then only we can do the physical examination. A violent patient, can we do immediate physical examination? Then you'll be in trouble. So we cannot do that. So once the patient is manageable, then we can have the examination and other lab investigations. So in a violent patient, when brought to a casualty, there should be adequate security staff. Then the consultation room should have an entry door and exit door. If the patient becomes suddenly violent, then we have to escape from the situation. So there will be two doors. There should be a call button to ask for help. When the patient becomes aggressive, then immediately we have to call for help. Then in a violent patient, when we are talking to the patient, we should be always respectful, calm. We should not keep the eye contact with the patient. When we are always looking at the eyes of that person, then the person will feel that we are trying to threaten him. So prolonged eye contact has to be avoided. We have to remove all the potential weapons from the room. Even even a pen can be a potential weapon. They can stab us with the pen. So all these potential usable things, pen stands, all these things we have to remove from a psychiatric emergency room. There should be adequate staff also. Then, what are the strategies to prevent assault? See, when a violent assaultive patient comes to the psychiatric emergency setting, we should answer all their questions very softly, simply, and honestly. Evading and some defensive answers that will provoke the patient, that can lead to violence. We should be empathetic and calm with the patient. We should keep our hands visible. When we are hiding our hands, they may think that we are keeping some weapon hiding from the sight of the patient. And always keep the doors open. Do not bolt the door, do not close the door. Keep the door always open. Always stay at least an arm length from the patient. This is to protect ourselves from the kick from the patient. Then our body language also should be in a non-threatening manner. When we are showing some sudden movements with our hands and legs, that they will take it as a threatening message. And then these are the various things that we have to adopt when we are seeing a violent patient. Then physical assault. Whenever there is a physical assault or an impending physical assault, we have to call for help. How we can, when the patient is trying to kick us with their legs, we have to deflect with our own legs. Their punch also we have to deflect. For that, always we should not stand in front of the patient. Always we should stand on the side of the patient. Then only we can escape from the kick and punch from the patient. Then always, if the patient is very violent, unmanageable, and if the situation is not safe to stay there, then we have to escape from that situation. We have to run from that situation. Then if the patient is biting us, what we have to do? Should we pull our hand? If the patient is biting our hand, do not pull. Then that will lead to taking our flesh. So when when a person is biting us, we have to press the biting area to the mouth of the patient, mouth and nostril. So what will happen? The patient will develop breathing difficulty. Then only the patient will release us. Then only the biter will release the biting part. The same way, when the patient is grabbing our hair, what we have to do? Should we run? Then we lose our hair. We should try to deflect with our hands. So these are some of the minimum things what we have to do in an assaultive situation. Then what is the role of psychotherapy in a psychiatric emergency situation? See, psychotherapy may not have much role in a psychiatric emergency situation, but still we can do little bit psychotherapy, the so-called brief psychotherapy in a psychiatric emergency setting, especially to treat some acute conditions or immediate problem. Suppose the patient is trusting the doctor, the patient can understand what the doctor is trying to say. If there is a trusting, mutual trusting relationship has developed between the patient and the doctor. If the patient has got a psychological mindedness, if the person is not, if the person is able to understand the connection between their problem and the psychological situation, then we can have little bit brief situation-oriented problem-based psychotherapy we can do in that situation. We can spend some time with the patient to make them understand what is their problem and what are the factors, psychological factors that has led the person to come to the casualty like that. So when we are talking to a patient, that itself, when a patient comes to a psychiatric emergency setting, when we are talking to the patient, when we are giving our patient, listening to the patient and trying to understand the patient, gathering information, that itself is equal to a short-term psychotherapy, brief psychotherapy. So always try to spend some time with the patient, be empathetic, calm, but at the same time, in a psychiatric emergency, the most important problem that we will face is violence and agitation. So how we can manage that violent situation, that always we have to know and we have to manage accordingly. So in conclusion, there is increasing incidence of alcohol and other substance of abuse in our country. You know that when you have come to our psychiatric hospital, you might have seen a lot of patients coming with an MDMA, isn't it? And cannabis, cocaine, lot of people nowadays are coming. So the number of people coming to a casualty with all these substances increasing enormously. So that is, of course, a psychiatric emergency situation. We have to deal that appropriately. So it is necessary for all health staff to be familiar with the common psychiatric emergencies, especially suicide attempts, violent behavior, and other psychiatric emergencies. Then only we can improve the level of care which we can offer to these people. So here, within this short period of time, I try to give you an overview about what are the various psychiatric emergencies, and as a mental health professional, being part of the team of the mental health professional, as a psychological nurse, psychiatric nurse, what you can do in that situation. I try to give you an understanding about the situation. Again, thank you for the patient listening, and thank you the organizers also for giving me an opportunity to deliver this lecture. Thank you.
It's now time to discuss. Delegates, please clarify your doubts. Now, I invite Professor Isha is to present a memorial to Dr. P.H. Suresh Kumar as a token of our gratitude. Lisa February. Dr. Paul J. Alappa completed his MBBS and MD in internal medicine from Calicut Medical College. He completed his DF neurology training at Sri Chitra Institute for Medical Science and Technology. Dr. Paul has been fellowship training in international neurology. I proudly welcome Dr. Paul J. Alappa to talk on emergency management of stroke.
Zoom. Online phone.
Here the lyrics of that you will keep silent.
Please see that. Browser എടുത്താല് ഓണായി. Zoom ID. Hello. Other 863. Which one? After country. ഓൺലൈൻ ഉണ്ട് ആള്.
And I did
86 number 86 38 5 35 5 35 7 8. Wait, I'm sorry.
Recording in progress.
Let me get the whole
audio.
volume notes are.
Audio.
അതിന്റെ മൈക്കൊന്നും കിട്ടി.
Apologies for the delay. We were setting up a Zoom in the laptop for others to see. So today the topic for my presentation is emergency management in acute stroke. The previous topic was they were talking about violent patients who were running, etc. This is exactly the opposite when you see in the emergency room. These patients will be usually quiet. These patients will not be able to speak. These patients will not be able to run. Was disabled for ready.
Okay. Sir, I'm not going to
ഇതൊന്നും മാറ്റാൻ പറ്റില്ല. ഈ
അത് ചെയ്യണം.
അവിടേക്ക് കാണുന്നില്ലല്ലോ.
ഇതിലേക്ക് വരാനില്ല.
കേസർ കാണുന്നു. അത് കുറച്ചിറങ്ങി ഇത് എവിടേക്കാ ഇത് താഴേക്കായിട്ട്
അല്ല അത് പ്ലേ ചെയ്താൽ ഇത് പോകും. ആ സാധനം പോകും. പ്ലേ ചെയ്താൽ മതി.
ഇല്ല അത് അവിടെ ഇരിക്കുന്നത്.
അപ്പോ
ഇത് ഇവിടുന്ന് മാറ്റാൻ പറ്റില്ല.
ഇത് മൂവ് ചെയ്യാൻ പറ്റുന്നുണ്ടോ മൗസ് കൊണ്ട്?
ഇപ്പൊ ഇത് മൂവ് ചെയ്യുന്നില്ല. ഈ സാധനം ഇവിടേക്ക് ഇതിവിടെ സ്റ്റക്ക് ആയിക്കൊണ്ടിരിക്കുക.
ടാസ്ക് പറയും
അത് പോകുന്നില്ല.
പോയിക്കോളൂ ഇത് പോകുന്നില്ല കുഴപ്പമില്ല സാർ.
ഇല്ല, അത് പുള്ളിയോട്
ഇതിന്റെ ഇടയിൽ എഴുത്ത് വരും എഴുത്ത് വരും
കുഴപ്പമില്ല. Sorry, you will see something on the screen all throughout. I think there's some problem with the technical IT aspect. So in stroke, there are two types of strokes. നിങ്ങൾ ഈ അഡ്മിനിസ്ട്രേറ്റീവ് പ്രിവിലേജസ് മാറ്റണം. അതുകൊണ്ടാണ് ഇത് ആൾക്കാരെ വരുമ്പോൾ അത് മൂവ് ചെയ്യാൻ പറ്റുന്നില്ല. ഇത് പോകുന്നില്ല. നിങ്ങൾ ഇത് വെക്കുമ്പോഴാണ് എക്സ്റ്റെൻഡ് എക്സ്ട്രാ അങ്ങനെ ആക്കിയ റെഡിയാവും. ഇടയ്ക്ക് സ്റ്റക്ക് ആവുന്നുണ്ട്. ഇവിടെ ഇങ്ങനെ ഓരോന്ന് വരുമ്പോഴേ മെസ്സേജസ് വരുമ്പോൾ
അത് അവിടെ നിന്ന് പോയിക്കോളും.
ഇല്ല, അത് ഇടയ്ക്ക് വരുമ്പോ സ്റ്റക്ക് ആവുന്നുണ്ട്. Okay, so a stroke can be said as a brain attack, like how we say it is a heart attack. For in the brain, we can call it a brain attack because it is almost the same thing, because it is the vessels in the brain that is getting blocked. And for short, a definition of stroke is a disturbance in the blood supply to the brain. That is a blood supply in the brain. It can be the brain, the blood vessel can clot or the blood vessel can rupture. So when the blood vessel has a thrombus in it, you call it an ischemic stroke. So you develop something like this, where there is a hypodensity in this CT, which is like an infarct, which is called an infarct. And this is the animation of the same, where a thrombus develops in this, and it develops into a parenchymal infarct here. In this, actually, even when we say it's a disturbance in the blood supply in the brain, we are actually not seeing the blood vessels in this scan. So most of the time in stroke also, when we are seeing the scan, we are not seeing exactly what is happening to the blood vessel. We are actually seeing the postmortem of the disease, that is the damaged tissue. And that is how we diagnose this stroke. That is in the earlier times. Now there are more advanced imaging. And this is how, when we see the white, that is a hyperdensity in the CT. This is what we call a bleed. And this happens because of a rupture of a blood vessel. It can be different types of rupture. So this brain attack can be of two types, that ischemic and hemorrhagic. So ischemic when the blood vessel is blocked, and hemorrhagic when it ruptures. So this is just so you can see a video of how the stroke occurs. This was the second video, sorry. Stop ചെയ്തോട്ടെ ഷെയറിംഗ് വന്നിട്ടാണ് എല്ലാം പ്രശ്നം ഉണ്ടാക്കിയത്. സ്റ്റോപ്പ് ചെയ്യട്ടെ. എന്നാൽ ഇവിടെ ആറ്റ്ലീസ്റ്റ് പ്രസന്റേഷൻ നടക്കും. ഏതാണ്ട് പറ്റില്ല, അല്ലെങ്കിൽ മാപ്പ് ചെയ്യണില്ല.
അത് കുഴപ്പമില്ല.
So this is what I said earlier, a thrombotic occlusion. So ischemic stroke can be thrombotic when a clot develops in situ, that is in the blood vessel, leading to the death and necrosis of the blood which should have gone here. The second mechanism of an ischemic stroke is when an embolus travels from the heart to the intracranial circulation, and this embolus lodges into a blood vessel and causes ischemia. Now, this is of an hemorrhagic stroke of the blood vessels of the brain. The hemorrhagic stroke can occur in two ways. That is a parenchymal bleed, which I had shown earlier, when a blood vessel, without any apparent problem in the blood vessel, we do not see any problem, and it just ruptures like this, which causes a parenchymal hemorrhage most of the time. Like a hypertension is a predominant cause for this. Another one which we see of a rupture is what we call the classical subarachnoid hemorrhage. That is when we actually have a problem which we see in the blood vessel, which you will see now. That is a balloon-like dilatation of a weak spot. This one is when a subarachnoid hemorrhage ruptures. So this causes, because this blood vessels in the sulcus, it causes a SAH, and the sulcus and the brain membranes, it occurs in the subarachnoid space. So this is another type of bleed. All these are strokes, and it can lead to strokes. The most common stroke, which we say, is always the ischemic stroke, which I told first, when there's a thrombotic occlusion. 80 to 85% of the strokes are ischemic, and 15 to 20% of the strokes are hemorrhagic. And out of that, 5%, less than 5% is subarachnoid. So coming to it, this is just a summary of the different types of stroke. Now coming to the topic proper about emergency stroke management, this occurs in 3 ways. That is in pre-hospital care, emergency department care, and ICU care. Pre-hospital care is when the stroke management which occurs, any emergency like in an MI or in a cardiac arrest, you have some care which is given before reaching the hospital. Then the care which occurs in the emergency department. After the emergency department, the post-treatment or the post-emergency care in the ICU. So we will deal this one by one. In stroke, compared to cardiac illnesses, the pre-hospital care is actually minimal because there is no first aid in stroke as per se. The important thing is to make the patient come to the hospital fast and to recognize the signs and symptoms of stroke. Most people will not be able to recognize. That is, we have the acronym Be Fast. That is, the new acronym is Be Fast. The old acronym was FAST, where face, arm, speech, and time. B is for balance and E is for eyes. So let us listen to how, when someone calls us, how we should understand that it is a stroke and how we should deal with the patient.
Yes, doctor here. Hello, doctor. I'm Satish. And I'm better than Actually, boredom ഉണ്ട് സാർ പക്ഷെ മുഖം ഒരു വശത്തേക്ക് കോടിയിട്ട് പോലെ അച്ഛന് കൈയും കാലും വിളക്കാൻ പറ്റുന്നു വലതു കൈ ഉയർത്താൻ സാധിക്കുന്നില്ല സതീഷ് ഇത് സ്ട്രോക്ക് ആണ് പക്ഷാഘാതം ഭയപ്പെടേണ്ട എത്രയും പെട്ടെന്ന് ഹോസ്പിറ്റലിൽ എത്തിക്കും ഒരു നിമിഷം വൈകിക്കൂടാ ഫാസ്റ്റ് ഫാസ്റ്റ് അതെ ഫാസ്റ്റ്.
But that is the only thing which we have to know about the pre-hospital care. That is how to recognize a stroke. Most people as doctors and nurses also even actually fail to recognize a stroke out of the hospital. Inside the hospital, it is easier to recognize. And so this is how you recognize.
Yes, my face deviation. മുഖം ഒരു വശത്തേക്ക് കൂടും. A arm drift. കൈ പെട്ടെന്ന് കുഴഞ്ഞു പോകും. Yes, അതായത് speech. സംസാരത്തിന് അവ്യക്തത വരും. നാവ് കുഴഞ്ഞതുപോലെ. ഈ എന്നാൽ ടൈം. അതാണ് പ്രധാനം. നേരത്തെ പറഞ്ഞ ലക്ഷണങ്ങൾ കണ്ടാൽ രോഗിയെ ഒരു നിമിഷം പോലും വൈകാതെ അടുത്തുള്ള വിദഗ്ധ ചികിത്സാ സൗകര്യമുള്ള ആശുപത്രിയിൽ എത്തിക്കുക.
Most important thing is time. Immediately when you recognize it, immediately you have to take it to a hospital where there's treatment for stroke available. So you should not waste time thinking about other things. So immediately you like this, when you have, it's a time to call emergency. So immediately the ambulance comes and you immediately shift the patient. So even without this, nowadays with the new age apps, we have also developed an app, Lifeline by ASTER MIMS, where if you download the app, there is a help button here. Immediately on pressing the help button, within 1 to 2 minutes, you will get a call back and an ambulance will come to our listing. So this app is also available actually in the Play Store and in Apple Store. And if you download it, so newer technologies also should be embraced for bringing the patient faster, because time is the maximum important in stroke. Nothing else matters, actually, not your clinical skill or anything. The time and where you go depends. So the question actually what occurs is, you have identified a stroke. Where should you take the patient? So he should be taken to the nearest place where intravenous thrombolysis, that is one of the treatments for stroke, is available, than to a place which is far away. Like there may be a big center which is farther away. But if you have a place where this treatment is available in your nearby, that is the best place to go, because time is important. And also you have to try to identify a large artery stroke. And after that, you can transfer to a higher center. So what is a large artery stroke? So that is a difference we have to make in strokes. Not all strokes are same. you have the large arteries, which is this, the internal carotid, the middle cerebral, anterior cerebral, and from these many small arteries go. These are the small arteries. If it's a large artery stroke, that means the patient has a high chance of mortality and morbidity. That can be easily assessed in the early period of stroke by many questionnaires and many examination findings. So that also, if you can understand, you can know that after this thrombolysis, there is other treatments like thrombectomy, where you take out the clot from the large artery. So that also has to be identified in the initial phase simply, and world over, it is identified by paramedics and nurses by usually questionnaires like the RACE questionnaire. So differentiate that it is a small vessel, because if it's a small vessel stroke, the patient is going to survive. He is going to improve subsequently in the coming months. But when it's a large vessel and you may not treat the patient properly, he's over the next 24 to 48 hours, he will deteriorate and maybe die or have a severe disability lifelong. So this is what I told earlier, the RACE questionnaire, you can refer it. This is for the rapid arterial occlusion evaluation. And if the score is more than 4, usually there is 80% chance it's a large artery occlusion. So, so that is about pre-hospital care, which is very minimal. This is only you have to know how to recognize all these, to which hospital to take. There is no first. So the point I like to make is there is no first aid in stroke. Like when you have to do a cardiac massage, etc. There is no other first aid. The immediate thing is to bring the patient to the hospital. Now, emergency department care. So that is the most important thing in stroke, and how to make it fast. So even if you say it is emergency department care, the whole philosophy, it should be to bypass the emergency department, or at least if you're going into the emergency, shorten the ED stay. Stroke, unlike other illness, initially you may not have a very big problem for the patient. The patient may have a mild weakness. It subsequently deteriorates. We have lots of stories in our practice. Patient had come okay. Patient had come walking to the hospital. Then the patient had deteriorated. Patient had developed hemiparesis. These all happens because you are not having a code stroke protocol. So the first thing you have to do is a code stroke protocol, because then only you can mobilize patients from the emergency department fast. Because the emergency department works, initial paradigms are working for cardiac illnesses or other trauma illnesses. It does not work for code. You do not have to do a lot of the evaluation and lot of the things which you do for a normal patient. You have to do everything fast and get the patient, because everything happens in the radiology suite or in the CT console when a code stroke. So what is this code stroke? It is used to prioritize the hyperacute assessment and care of a patient presenting with symptoms and signs of stroke. And any medical professional, not a doctor, even the paramedic who's receiving, the triage officer who's receiving, if the patient is suspected of the stroke, he can call a stroke code, and that will be instituted. And the time frame for calling, there is a time frame. Usually it is the window period or the golden hours of stroke for IV thrombolysis is 4.5 hours. And for mechanical thrombectomy, which is an endovascular thing, where you do it within 6 hours, and in selected cases for mechanical thrombectomy, you do within 24 hours. And the location where we do all this is the emergency department and the imaging suite, or the CT or the MRI machine. So what are the advantages? When you call a stroke code, you have an announcement over the public address system. Everyone is aware there's a code stroke in the hospital. There is a page or a call which goes automatically to the neurologist. So the neurologist will come without you calling him. The radiologist will be aware. The imaging console, they may be having a patient. They will finish it fast and wait for the patient to come. There will be no block. But otherwise, what happens is you make a phone call to the imaging console, and then the imaging console will say they have a patient. Wait, then you wait for the phone call back. And by the time you miss the time, the pharmacist with the IV thrombolytic drug, which is either tenecteplase or alteplase, will come automatically when the stroke code. The cath lab where the mechanical thrombectomy is done is alerted automatically. The social worker comes to deal with the financial issues and the social issues for the patient. So and that is the stroke physician immediately arrives, rapid assessment. You shift the patient within 10 minutes to imaging, and technician makes the CT room free. The pharmacist arrives. These are all the advantages if you institute a stroke code. Why we have to institute this, I don't know if in hospitals, but ideally when you are thrombolizing in any hospital, you have to have international benchmarks of a door to CT time of less than 20 minutes. Door to needle, now it is 60 minutes, it is set. But nowadays, all international hospitals strive for less than 45 minutes. And there are hospitals which do within less than 15 minutes. So only if you do this stroke code and do all this fast, you will be able to reach this time. Otherwise, one phone call, waiting for the CT, doing this, interpreting, it will take almost 1 to 2 hours, and you are out of the window period. So the faster you do, better it is. So that is a stroke code. So ideally, the time allowed in an emergency department should only be 10 minutes. Within 10 minutes, what you can do, you should do. And then you shift the patient to the CT. If you can directly shift to the CT, that is also good, because while waiting for the CT or in the CT console, you can do all these things. The only blood investigation which is needed before you are thrombolizing, because we all do for thrombolysis and thrombectomy, is a fingerstick glucose. You have to rule out hypoglycemia, because hypoglycemia can be a stroke mimic. If the blood sugar is less than 72, you do not thrombolyze the patient. You correct the blood sugar and look for improvement. Then blood pressure. That is the only other important evaluation you do. You do a blood pressure. That can also be done during shift to CT. NIHS scoring, that everyone should be frequent, because we need to document the deficit. That is for both for medical legal and for understanding the disease, how the patient is improved. And NIHS is the National Institute of Health scoring system, which all nurses who is in the ED or dealing with stroke care should be fluent in about. So that has to be done, and it should, or usually if you do it slowly, it takes 10-15 minutes, but this has to be done under less than 5 minutes. And you put an IV cannula. That is the most important thing which we have to do in the system, because you use contrast for the CT angio. You do not waste time dressing, changing the dress of the patient. Do not waste time doing an ECG. Those are not needed. And because these all will take, and patient should never be unattended. If a patient is attended and unattended, that means your stroke code is slow, because this all happens in seconds to minutes, whatever is going on. So you cannot leave the patient unattended. So this is what I had said earlier. Every nurse, I feel, should have this certificate. Whoever is interested in stroke should. It's a free website which is globally recognized. When you have to do it every year to get updated. There are various standards, and if you have this in your CV also, it is good. You know that you are serious about stroke. What further can we do? You patient preparation, everything can be during the transport. When you're pushing the trolley, directly you can transport to the CT lab. You do not actually have to collect even blood from the patient if you feel that it is becoming so, because all the blood investigation are anyway going to take time to come. So not compulsory to catheterize or rice tube, put the rice tube. Why I say all this is because initially when this drug had come, people were afraid of thrombolysis. If you're pricking the patient, will it cause any other bleeding from the site? If you are catheterizing, will it cause bleeding? If you're putting rice tube here, so do everything before. But now the consensus has arrived that you do not have to do all this unless it is necessary. And even if you do it after, it does not make a difference. It depends on the quality of how you catheterize and insert. If you do it very smoothly and with adequate lubrication, even the rice tube, it is not difficult. It is not going to cause that much of a bleeding. Even if you do it prior, when you're giving the drug, immediately you're giving the drug, that also can cause the bleeding. Second is delaying the collection of blood. IV venous puncture is not going to cause any, because most of these patients immediately you take to cath lab and do a large arterial puncture also. So these are things which you can do actually. Previously it was said, so, and a team approach is needed. You have to have a clearly defined roles. Who is going to do what? Even though you have clearly defined roles, everyone should be able to do every work. Like a doctor should be able to push the trolley also. And you should also be able to score the NIHS. You should also be able to do the GRBS. Many things, everyone can fill in for the roles also, because not all the time everyone will be there. It is just like how you are resuscitating a code blue, and you process in parallel rather than sequentially. Everything should be done simultaneously. You do not wait for phone calls to shift the patient to anywhere. You have to take the decision. So this is how a stroke code could be treated. If you have seen Formula 1, you see the car comes in 9 seconds, he's out of the pit lane. That is, you see so many people doing things simultaneously. So this is called the pit crew approach in stroke management, where you do everything fast and the time is the maximum important. You do all this so that if you delay the treatment, the risk of bleed for the patient is more, and the risk and the benefit for the patient is less. So you're losing neurons every minute you delay. So if you have decided to thrombolize, you should go ahead. So just summarizing, a simplistic approach is stroke is one of the few diseases, even now it is a clinical diagnosis, because you are doing a CT and in the CT, you are not going to see any stroke. You are just ruling out a bleed. So to tell it is a stroke, the doctor has to tell it is a stroke. That is by that word we go forward in this treatment. This treatment with implications of bleed and death is only went ahead with the word of a doctor. No other test is there immediately to identify, because most of the time you do not do an MRI. You rule out a hypoglycemia by GRBS. You rule out the CTS, rule out bleed, ensure that the BP is less than 180. The relatives have to consent. Then you just have to decide which drug. So it is that simple when you thrombolize. But we always And now there are no contraindications. Initially in 1996, when the initial trials had come out, there were a lot of contraindications. Now, mostly everything you can thrombolize, except if you have an intracranial bleed, or you have a past history of intracranial bleed or a very recent surgery, that is 7 days. 21 days and all is now out. And why still, despite this simplistic approach, it is so complicated, so many guidelines come out, and it is all complicated. The fundamental difference why in an MI it is easier to manage in a stroke is because in MI it requires only a very simple investigation called the ECG, which is very cheap and you can get a lot of information. While in a stroke, the only investigation is a CT. So you need a hospital where there is CT, you have to shift to the CT. So the investigation is a difference, and you are not seeing anything on the CT in a stroke. The CT is normal when you have a stroke in the initial time. So that is a difficulty for people to manage, for people to conceptualize in the brain. Why the bystanders will say, sir, he has a very large stroke. We will say, then sir, how is the CT? So CT is normal. Then we have to give this drug. So how you can understand, for a common person itself, it is difficult to understand that CT is normal, but patient has problem. Then you are asking him to give a very expensive drug with lot of implication, chance of bleed, etc. So these are the roadblocks which we have when we have a stroke. And the presentation in a heart attack is very dramatic with chest pain, angina. While in a stroke, the patient will always be quiet. He will be having aphasia. He may not be speaking. So you have to go. He will not call out for help. The doctor has to go and find it out. While a heart attack patient will immediately call the doctor, I'm having chest pain. So those are the differences why we always have problems in management of stroke, in conceptualizing stroke in the brain for doctors, nurses, and even for lay people. So another thing which I would like to stress in emergency stroke management is the absence of vascular imaging. As I said, the CT will be normal, but a lot of the strokes, if you don't do the vascular imaging, you will have there are a lot of problems, because the vascular imaging is where actually the stroke happens and you can visualize the vessels. This is not done in most, that is a CT angio or an MR angio. For most strokes all over India, mostly you do the CT or the MRI brain. You do not do the CT angio or MR angio, but the disease actually occurs in the blood vessels of the brain and you are not doing it. So you have to study this. Everyone has to insist, even if your patient or your relatives go to a hospital, is this done? Because if this shows an occlusion, that has to be removed very fast. So if you do more and more of this, you will see abnormalities. You will not see any abnormalities in the emergency period when you do this. So the importance of doing vascular imaging in every patient with stroke has to be stressed. This happened because in the initial time, there was no vascular imaging. The technology was poor. So that has continued even now. Now technology has improved, and you have to embrace these technologies to see vascular imaging. Now coming to the treatment of stroke. So there are only 2 approved treatments for the emergency revascularization for acute stroke. One is intravenous thrombolysis, where we give a thrombolytic drug which will bust the clot or the clot buster. And then is the mechanical thrombectomy, which is an interventional neurology procedure where you puncture the femoral artery, go to the brain vessels endovascularly, and remove the clot by mechanical means. So that is the only 2 treatments. And this has a golden hour or a window where you do. Because a lot of patients come after this and ask what you can do. You cannot do this after the time has come, or if there is no benefit for the patient, because most of the time the brain tissue will be infarcted. The brain is unique in the human body in having the cells which are fixed, and whichever is damaged, if you cut out your liver, the liver will regenerate. If you have a wound in your arm, the cells will regenerate. Or most of the cells in the human body has the capacity for regeneration, except the brain. The cells you are born with, you die with. And most of the time, so whatever damage has occurred, it is permanent. And how the patient improves subsequently in a stroke is by brain plasticity. When other cells do the functions of these cells, which may not be as optimal as the previous, and that is how the patient improves. But if the cell number is less, you will not be able to improve, because there is a critical volume for the brain plasticity to happen. So now coming to, these are the histories you have to take. Even when you're doing a stroke code, this is what you have to take. You have to, it is compared to other histories, the exact time when stroke symptoms began, because this is deciding the treatment for the patient. You have to ask any recent bleeding, surgery, myocardial infarction, trauma, because this also is deciding. You don't have to ask any other history. It has to be pointed. I told you have to finish within 10 minutes. past medical history, hypertension, diabetes. Important to ask any nurse or anyone, because the doctor may miss. Ask if patient is taking any blood thinners, any drugs with like antiplatelets, etc., because that will have a implication on the dose and what treatment which you are going to give, because you are giving. So these are the initial important histories you have to take. If you don't take all other history, it is okay. This is important. Examination, I said the NIHS is enough. Look if there is a seizure, because a seizure can mimic a stroke. And look if there is any symptoms suggestive of bleed, like headache. Stroke usually never presents with headache, a ischemic stroke when you're thrombolytic. This all I'm telling about ischemic stroke, not hemorrhagic. So it will never present with headache, ischemic stroke. So no symptoms of subarachnoid. So you ask all that. And this is the drug which we give, IV recombinant tissue plasminogen activator. It's a fibrinolytic drug, and it used to remove the clot. You can administer it. Best treatment is within 3 hours. Till 4.5 hours, there is benefit. And then it works by dissolving the clot. And most people miss this. Out of 100 strokes, maybe 1 to 4 percent of the strokes are already receiving this treatment. So because they don't arrive at the hospital in time, they do not identify. That is why the fast is important. You have to identify the stroke. Most people will not know how to identify the stroke. And the only image, CT imaging, you have to take. If the CT is not showing a bleed, you have to thrombolyze, and it is within 20 minutes of arrival. If you're taking the CT after 1 hour and thrombolizing, you should not thrombolyze in that hospital. So why are you giving this drug? So some people ask, the patient has not improved. So the improvement is not immediately. The improvement is these patients have improved function at 3 months. That is what the study has shown. Some patients will improve immediately, but that is very rare. But a patient who has been thrombolized is more likely to walk at 3 months than a patient who has not been thrombolized. So that is the most important. And what are the risks we should tell? When you give this drug, there's a risk of bleeding into the brain and death. That is very low usually. It is 1 to 4%. And it is you, and that is especially when you give in old age and when there is more severe stroke or when the glucose is high. So this is how the stroke treatment goes. So you have an infarcted tissue. You do not want this infarct to progress again. That is why we are giving it. So here you have the clot which we had seen earlier. You give the drug and this clot lyses and you reperfuse the brain. Whatever was there in the penumbra is the area that can be saved, will be reversed, the ischemic circulation. So we will just come to a few cases and then decide. This is a case of a 76-year-old lady. She had multiple comorbidities, angiodysplasia, this thing. So she was having a severe, we scored the NIHS, 21 is a large NIHS, presented in the window period. Patient on antiplatelet in 2 hours. Severe right hemiparesis, great hemiparesis. So you see an MRI was taken. This is how you see an MRI appearance of a stroke. White lesions on the diffusion sequence, black on the ADC. And you can see nowadays with advanced imaging, you can also see the clot. The black color here you see is the clot in the blood vessels. And you see an angiogram which I had pointed to earlier, you have to take. So in this, there is a block here in the left middle cerebral artery. So you give the IV thrombolysis, and then after that you take an angiogram. And you see the angiogram has shown this block is the patient has reperfused, and this patient made a recovery because within 2 hours patient had come, we have given the drug, the vessel opened and it improved. So coming to the second treatment, which is, I told there are only 2 treatments available. One is, the other is mechanical thrombectomy. Now mechanical thrombectomy is not used for all strokes. It is only used when there's a large vessel occlusion. Out of 100 strokes, 20 strokes will have large vessel occlusion. Large vessel occlusion is when the middle cerebral artery, the anterior cerebral artery, the ICA, basilar, vertebral is occluded, not these small vessels. Because those small vessels are actually 0.1 mm. You do not have technology or vessels in which 0.1 mm the wire or this thing can go. But these vessels are 2.5 mm. So our catheters are at least 1 mm, 2 mm. So more than that, you cannot go. So in this, there is also the concept of bridging thrombectomy. Some patients will come within 4.5 hours. So which treatment to give? IV thrombolysis or mechanical thrombectomy? There are 2 treatments. So the current guideline is you have to give both. You first give IV thrombolysis, then immediately shift the patient to cath lab and do the DSA. If the vessel is open, you do not have to recanalize the vessel because it is already open. You do not have to do thrombectomy. But almost 90% of the vessels, studies have shown, will not open. The large vessels will not open with thrombolysis. That is why you do bridging thrombectomy. The thrombolysis is a bridge to thrombectomy. The clot will be more soft. It will be easier taken out when you are doing these techniques. So for thrombectomy, I'll just briefly say the two techniques. One is a stent retriever technique and aspiration technique, because everyone will have a want to know what happens actually in the cath lab. So that is why I thought I would include this. Stent retriever is when we deploy a stent-like device, which is connected to a wire, you enmesh the clot and pull it. Aspiration is simple. You keep a tube and you suck out the clot by suction. So these are the two techniques available to take out the clot. So this is an aspiration technique, which you will see. So this is the brain. You see the vessels of the brain. There's a clot. This is the middle cerebral artery. So patient enters the cath lab. This is the femoral artery. You puncture it, insert a wire. You insert a wire through the aorta. You insert a tube through the aorta. You use multiple catheters so that the power is there to reach up till the brain. And you go through the carotid, the left carotid artery. And somehow you manage to reach through these twists and turns to this location where this clot is with multiple wires and catheters. And you reach the clot here. See? So this is the middle cerebral artery. So here you are just reaching it. You reach, then you put even more tube. Now this tube is which we use to suck. We remove all the other. You connect. This is the suction apparatus. Just like how you are suctioning some thrombus and sputum. You have a suction apparatus. It's a more advanced one. You insert and you put pressure on it, and then the clot is sucked. You put pressure, increase pressure because too much pressure also can damage. So it has to be this. So, and finally the clot is ingested, and then it drops down here, the clot. So this is how, and the reperfusion is achieved. The blood flow can come. So this is what is the aspiration technique. This is the stent retriever, which I told earlier. The clot similarly is in the left middle cerebral artery. This is the stent retriever, which we use connected to a wire. And here we are using to deploy. Here the stent retriever has arrived and you deploy the stent. So now what happens is the clot enmeshes into the stent retriever. You have to wait some 1 to 2 minutes and then you pull it out and the clot comes along with it. The clot is stuck inside the stent retriever and you pull out the clot. So these are the two techniques. This is what we do in the cath lab when we go for this thing. So I just, a sample case. This patient came with a large stroke, grade 1 power, global aphasia. This patient, if you don't do anything, will die or have lifelong disability. So you take a plain CT as per our protocol, which I told earlier. You see a hyperdense MCA sign. This is a white, so you know there's a largest occlusion. There is something called aspect scoring that the radiologist will do. You have to know that there is not too much damage. If there is already too much damage, we do not proceed with the procedure, because if the damage is high, there is no point in doing the procedure. You do an intravenous thrombolysis. Then the concept of bridging thrombectomy. After thrombolysis, immediately you see there's a large occlusion. There's no vessel in this side. There's no middle cerebral artery, no internal carotid artery. So there's a block here. So you immediately take to the cath lab. You, like the previous case, you put a catheter here, a tube. You're injecting contrast material. You see that the contrast is not going up. I don't know if it is that clear. It is not going up. Up till here only it is somewhere it is going. Then you use the stent retriever. You can see it's a bit difficult to make out. Actually, the stent retriever is here. And the same video which I had shown earlier, you are pulling it out. Here you can see the stent retrievers. Sorry, here. And the stent retriever is pulled out. Here you can see it is pulled out. And finally, you see the post-angio. This is the post-angio. Initially, look, this side of the brain starts filling up. This is the clot which we obtained inside the stent retriever. So there was a block here and the block is removed. If you don't do this, the patient is never going to improve. And after some one day, if you try doing this, the patient would have already infarcted. So you have to do it as soon as possible. So this is the patient. This patient would have died or would have had a large disability. Next, after 24 to 48 hours, this patient is walking, talking, and even telling his PIN code and very coherent. Otherwise, he would have died or had a lifelong disability if you have not done this procedure. This is another patient. Look, you can even do in 12 hours. This I told earlier. This is an MRI which shows the infarcts. And this is a perfusion scan. How much blood supply is entering the brain, we look. If it is blue, that means there's no blood supply. It is green and red, there's good blood supply. Here you see this much area, there's no blood supply. This much area is the already irreversibly damaged area. There is a mismatch between these two areas. So this is what is the penumbra. The area which is this minus this. The penumbra is the area which you can save by doing a procedure or opening the vessel. So this patient also, we see there was a MCA occlusion. occlusion of the right MCA, and you did the same procedure which I demonstrated earlier. The vessel is opened, and after the thrombectomy also in this patient, we, for academic purposes, we repeated the MRI and see which was blue here, it has turned red. We have taken, this is the pre-images where it was all blue, and now after thrombectomy, it has become red. So that is the benefit. And I think coming to the few cases, now after thrombectomy, our neuro intervention has gone into this thing, or when stroke has gone into more this thing, you have a CT angio. Here you see the stenosis. So in cardiac, you know there is stenting. In neuro, it is not that much because stenting, it is costlier and has more adverse effects. So, but it has now, the technology has so much improved that you have the severe stenosis here in the CT angio. We do a DSA. The DSA shows the severe stenosis. This patient has come with stroke, and we do this 3D mapping in the DSA machine. You see the stroke, you measure the measurements, and you put a, just like in a cardiac case or when you are doing angioplasty, here you use a balloon to dilate it. After the dilatation, you see the vessel has opened, and then you put a stent. And here, this is the stent which is put. You can see the vessel is almost back to normal. This is the stent. Stent is difficult to see. I have a different image. This is what was pre, this is post. So this is the stent. If you can see it, there is a stent in the brain. So these are things which is so advanced now, and with help of technology, we are able to treat more and more patients with stroke. And that is what has happened, actually, the evolution of stroke treatment. Because when I was studying my MBBS, this was when patients used to come, we used to just make the patient lie down, tell about physiotherapy, start on aspirin, and the patient may improve, may not improve. That has evolved to giving thrombolytic drugs, where we are giving drugs to bust the clot. And that has evolved to taking out the clot from the bronch. And now, even with our evolution has come, it has become intracranial stenting. Just like in any heart attack, the brain attacks, that is why we call it a brain attack. And we are improving to this area, not for all patients, but in selected patients. Thank you. And these are the clots which we routinely take on a daily basis from all our patients. These are clots inside the blood vessels of the brain, which we have sucked out or aspirated out or using a stent retriever. So this happens on a day-to-day basis, but the problem is this is not percolated, or it does not reach to many deserving stroke patients due to a wide variety of issues or roadblocks, which we have to strive to remove. Thank you.
It's time to answer the doubts. Any doubts from the into uncertainty. After that, then we start our workstation, and along with that, poster presentation will be conducted. Thank you. Audience, please be silent. And we will be starting the next session. Hope that you all will cooperate. Dr. Keshav Emma completed his MD Pediatrics from Madurai Business College. He did a fellowship in pediatric oncology and bone marrow transplant from Apollo Cancer Hospital, Chennai. He is trained in treating children with blood disorder, childhood cancer, and has experience with over 250 pediatric bone marrow transplants. He has taken various national and international conferences. I welcome Dr. Keshav Emma to discuss the oncology emergencies.
Front action.
Dear delegates, please be silent. Session will start soon.
Good afternoon. Moving on to the, I think the last session prior lunch, I would like to make it very short. So I'll be talking about oncological emergencies. I'm a pediatric hemato-oncologist and transplant physician in ASTER MIMS, Calicut. So I'll be talking about some of the emergencies we see in childhood cancers. We know that childhood malignancies are highly curable. And it is very rare also. Less than 5% of all the malignancies occur in children. And the cure rate is very high, over 70%. Most important thing is early diagnosis is important for their survival. Many children can present with emergencies, oncological emergencies, where we need to identify them and treat them promptly at the initial diagnosis, as the overall outcomes is excellent. And these emergencies can occur either before diagnosis or during the treatment. It can occur in both the situations. If not recognized, it can be life-threatening. So with this background, I will go on to my topic. So what are all the common pediatric oncological emergencies? It can be because of the disease per se. The disease can cause some emergency, or it can be treatment related because of the chemotherapy which we are giving. What are all the disease related? We have something called as an anterior mediastinal mass. Some of the childhood malignancies present as a mass in the chest, an anterior mediastinal mass. Some brain tumors present with raised intracranial pressure. Some mass in the spinal cord can cause a spinal cord compression. It can cause permanent hemiparesis or hemiplegia or quadriparesis. Because of high count, we can have complications of leukostasis. Because of the rapid tumor lysis and tumor burden, we can have tumor lysis syndrome. We can also have disseminated intravascular coagulation. So these are the emergencies which we commonly see because of the disease per se. I will be speaking about only a few of them. And because of treatment related, the most important thing is febrile neutropenia, fever and neutropenia in a patient undergoing chemotherapy. This is very important, especially in nursing perspective. We can have other chemo-related complications like pancreatitis, typhlitis. Most important thing is chemotherapy extravasation. So that is vesicant infiltration, especially when we give chemo. If it extravasates inadvertently, we can sometimes lose the limb of the patient. So that is very important. Sometimes you can develop seizures because of the disease per se or because of chemotherapy and any allergic reactions to any medications. Moving on to the first topic, anterior mediastinal mass. So generally, children can present with respiratory distress. They can be in two different spectrums. One end, you can have children which have only mild cough, persistent cough, will be seen by a pediatrician maintaining normal saturation. On the other hand, you can have a child with severe breathing difficulty, low saturation. So they can present with this. They can have a drop in saturation. Some of these patients, because of the huge mass in the anterior mediastinum, it can compress other vessels, especially the superior vena cava can get compressed, trachea can get compressed, all the major vessels can get compressed. So what are the common malignancies which present as an anterior mediastinal mass? We have the Burkitt's lymphoma, acute lymphoblastic leukemia or lymphoma, Hodgkin's lymphoma, neuroblastoma, germ cell tumors. These are some of the tumors which presents as an anterior mediastinal mass. The solid tumors, especially neuroblastoma, germ cell tumors, and Hodgkin's, they present very small, very gently. They have a gradual onset of presentation. But some like our Burkitt's lymphoma, acute lymphoblastic leukemia, bar lymphoma, present as an emergency. So what happens when the entire upper extremities or the upper venous system gets compressed? You will have collaterals developing. So they can have facial edema, they can have swelling, plethora, venous engorgement can be present over the face, neck, upper extremities. When trachea get compressed, they can have their own presentation, cough, hoarseness of voice, orthopnea. Sometimes they can present with severe shock. We have seen one child who presented with a cardiac arrest. One child in MIMS who presented with cardiac arrest, retrospectively identified to have an anterior mediastinal mass. So they can present with subtle signs or they can be severe, life-threatening also. We can see two X-ray pictures. You can see the first X-ray picture of a patient who presented with almost in a fatal condition. He had facial swelling, plethora, severe respiratory distress. You notice in the X-ray, he has got a pleural effusion with an anterior mediastinal mass. So it was a T lymphoblastic lymphoma. We did a pleural tap. From there, you can get the flow cytometric analysis, and then you start the treatment. Second thing, another X-ray of a patient, which is in an anterior mediastinal mass. We can see the mediastinal mass here, but it is a slow growing mediastinal mass for a Hodgkin's lymphoma. This is the pleural effusion. You can see the costophrenic and cardiophrenic angle gets obliterated. So anterior mediastinal mass, how do we approach? So whenever you suspect a child with an anterior mediastinal mass or a superior vena cava syndrome, you take a chest X-ray. Of course, from the nursing point of view, you look into the saturation. These children, when they are in the propped up position, they may maintain saturation. The moment they lie down supine, they will become hypoxic. So that is very important. You look for orthopnea. When they lie down, is there any desaturation? Is there any tracheal compression on the chest X-ray? And if feasible, CT, but generally it is not feasible. So most important thing is if there's a mass present, can we biopsy the mass by a local anesthesia? Mostly children will not cooperate for a local anesthesia. They all will need an IV sedation. So is it feasible? Because the moment you give an IV sedation, the respiratory mechanics will start failing, and they will become more worsening. Most of these lymphoblastic lymphomas, Burkitt's lymphoma, especially with the anterior mediastinal mass, generally presents in the adolescent age group. Generally, so we have to convince the child that under local we will try to take the biopsy. But there are some non-invasive methods by which we can identify some of these. For example, a blood cancer, acute lymphoblastic leukemia, or a lymphoblastic lymphoma present as an anterior mediastinal mass. But the peripheral blood will show a lot of blasts if they have a high white count. From there, we can do flow cytometry. You need not do biopsy. Some tumors, like our germ cell tumors, they will have enzymes elevated, like our beta HCG and alpha fetoprotein. Enzymes will be elevated. So for which we don't need a mediastinal mass. Some of these children with a mediastinal mass can also have lymphadenopathy, lymph nodes present in the neck. We can take a biopsy from those lymph nodes. So non-invasive methods, if feasible, we can take the tissue diagnosis. And most important thing is, we need to look for airway breathing circulation. Keep the child in the propped up position or in position of comfort. Avoid supine position because it can cause desaturation. From the nursing perspective, put cannula in the lower limbs. Avoid cannulation in the upper limb because already the superior vena cava will be obstructed. Anesthetic risk is possible. It can worsen the respiratory status. Biopsy or non-biopsy. Most important thing is whenever they present with respiratory distress, immediately after the biopsy, we start the chemotherapy. Early initiation of steroids is very important in this situation. Otherwise, it will become life-threatening. Most of the oncological cancers, or most of the malignancies, we wait till the final histopathology report comes to initiate treatment. But in these situations, we start the treatment early, immediately after the biopsy, even before the final report comes. And most important thing is, all these patients with anterior mediastinal mass, they present with a high white cell count. They will have features of tumor lysis syndrome. So we need to give them adequate hydration and ensuring that there is no cardiovascular compromise. Going on to the second topic, we have something called hyperleukocytosis and leukostasis. This is another life-threatening emergency. It occurs in hematological malignancies like blood cancers, acute lymphoblastic leukemia and acute myeloid leukemia. More common in acute myeloid leukemia because the blasts in AML are more larger, more sticky than ALL blasts. They will have lot of metabolic abnormalities because of the high white count. Moreover, because of the leukostasis, they can go and affect individual vessels. They can affect the pulmonary circulation. They can affect the brain. It can cause a stroke in the brain. So mortality rate is very, very high. Though the literature says it is 20 to 40%, personally, I have seen mortality rate over 60% in these patients. General definition is when the WBC count is more than 1 lakh, we call it as hyperleukocytosis. And in ALL, sometimes even with 5 lakh count, you may not have a hyperleukocytosis. Whereas in acute myeloid leukemia, because of the nature of the blasts, even at a lower count, you can have a hyperleukocytosis. So the count alone is not a definitive criteria. How do these children present with? They can either present with a kidney injury affecting the renal microvasculature. They can have affecting the lungs where they present with dyspnea and desaturation. Tachypnea will be presenting. Neurological symptoms. Some children with a high WBC count suspecting blood cancer will just come with tinnitus. Just tinnitus may be their presentation. That is also an oncological emergency. A blood cancer, suspected blood cancer, high white count with tinnitus. That is an emergency. Because these children, we need to do urgent leukapheresis, has to be done for these children. So there is a lot of grading symptoms, grading for the hyperleukocytosis in leukemics. So we have some grade 0, grade 1, grade 2, grade 3 based on their severity. When they present with so severe symptoms, they can have sudden myocardial infarction, including death. Some of these blood cancers like chronic myeloid leukemia, when they present with hyperleukocytosis, especially in the blast crisis, all these microvasculature in the retina, in the eyes will get occluded. So as a result of which, they can have severe visual symptoms also. So most important thing is, especially in patients with a high white count, this occurs in hematological malignancy, which is blood cancer. So by the peripheral blood, we can easily take the flow cytometry and confirm the diagnosis. We have to monitor for symptoms of leukostasis even before they appear, grade them, start adequate hydration, prompt initiation of chemotherapy, especially low dose steroids. When we give intense chemotherapy right at the beginning, what happens is the tumor cells rapidly bursts out. So whatever is the intracellular compartment can get shifted to the extracellular compartment, which can cause kidney damage. So all these things have to be monitored. And in this, whenever this high white count is present, suppose a patient is coming with a hemoglobin of 6 grams, WBC count of let's say 3,85,000, platelet count of 20,000, we should be judicious in giving blood transfusion. Because why? The viscosity will increase when you give PRBs. So the judicious use of blood transfusion in this situation is warranted unless otherwise the patient is already in cardiac failure. Normally HB is 6 grams, we have to transfuse, but not in this situation. We need to give platelet transfusion for these patients because not only that, because of hyperviscosity, they have increased risk of thrombosis formation. These blast cells can also cause bleeding. So we give platelets, we give FFP. One particular cancer I would like to mention here is acute promyelocytic leukemia, APML. It's a type of acute myeloid leukemia where survival rate is more than 90%. AML survival is 40 to 50%, but one subtype of AML, which is AML M3, survival is more than 90%, provided they survive the first 96 hours. First 5 days they have to survive because they present with disseminated intravascular coagulation. We have to monitor CBC, platelet count, PT, APTT, INR, fibrinogen every 8th hourly, and prompt initiation of ATRA-based therapy. So AML generally require high-dose chemotherapy, with the only exception of AML M3, where we give tablets, ATRA, arsenic trioxide, all trans-retinoic acid. So these are the two medicines which we give. And initial 96 hours, if they pass through, they have a long survival because survival is more than 90%. Okay, and this is what is some of the basic things in hyperleukocytosis. Do judicious transfusion, start leukapheresis at the earliest, monitor for neurological worsening or pulmonary worsening, early initiation of low-dose chemotherapy, adequate hydration, TLS functions has to be monitored. So as I mentioned, adequate hydration is needed, urine alkalinization plus or minus, prompt management of tumor lysis syndrome, leukapheresis, and hydroxyurea. Hydroxyurea is another beautiful drug. What it does is it suppresses the bone marrow production. So the excess production of white cell count and the blast cells will be temporarily suppressed by hydroxyurea. Tumor lysis syndrome. So what is tumor lysis syndrome? It is one of the commonest oncological malignancy, especially more common in hematological malignancy. Tumor lysis syndrome occurs even before you start chemotherapy. And why? Because tumors is rapidly growing cell. When they lyse, the intracellular component will be shifted to the extracellular space. As a result of which, whatever is inside the cell, uric acid will be elevated, potassium will be elevated, phosphorus will be elevated. All these three are intracellular component. When this intracellular component gets out into the space, we'll have complications. This can damage the renal tubules. It can cause acute kidney injury. So there are some tumors which has got a high proliferative rate. That is, they rapidly divide, like Burkitt's lymphoma, T lymphoblastic lymphoma. So when they have a bulky disease, lymphadenopathy, huge liver and huge spleen, whenever a patient presents with a huge hepatosplenomegaly and high WBC count, they not only have complications of leukostasis, they can have complications of tumor lysis syndrome also. So we do some basic blood tests, complete blood count, look into the WBC count, what is the levels, platelet count. If it is less than 20,000, we give platelet transfusion to prevent bleeding. We look into the renal function test because some patients may present with a kidney injury, elevated urea, creatinine. We look for the electrolytes, sodium, potassium, calcium, phosphorus, all these have to be looked into. We look into the uric acid. Uric acid is an intracellular component, which is, if released in the circulation, can cause kidney injury, and LDH. These are all indications of increased tumor lysis. So all these parameters have to be monitored. What is the pathophysiology? As I already mentioned, the cancer cells, we have the nucleus inside the cell, the DNA, which breaks down to hypoxanthine, xanthan, uric acid. So this uric acid is damaged to the kidney. So how do you prevent this? We have medicines. We have allopurinol and we have rasburicase. So these are the two medicines which blocks this pathway. So the cell lysis gives rise to nucleic acid, and we have the medicine allopurinol and rasburicase, which will block this conversion. As a result of which, either the formation of uric acid will be reduced, or whatever is formed will get converted to a more soluble product and gets excreted in urine. So that is very important. And as already you know, potassium in excess is always damages, because hyperkalemia can damage the heart, which you have learned. We have to look for EEGs. It can cause arrhythmias, and all these things can happen. Hyperphosphatemia can cause kidney injury. All these things to put together can cause acute kidney injury. So we have some criteria for diagnosis. We have laboratory criteria and the clinical criteria. The most important thing is, whenever there is an increase in the serum creatinine more than 2.5 milligram per deciliter, increase in potassium over 6 millimoles per liter, or a decrease in calcium, or development of any life-threatening arrhythmias, then we have to suspect tumor lysis syndrome. And we have the Cairo-Bishop grading of tumor lysis syndrome, where they have graded them from 0 to grade 5, where grade 5 is death. So you can see the creatinine levels. Grade 0 is less than 1.5 times the upper limit of normal. And as you go successive grading, the levels keep increasing. Same thing for cardiac arrhythmias. The severe form will have including death, hypotension, congestive heart failure, and all those things. So most important thing is we have to grade the TLS. TLS can occur even before starting chemotherapy, and it can occur 72 hours prior, as well as still 7 days till the onset of the first chemotherapy when the tumor burden is very high. This is a flow chart where we need to, most important thing is whenever a patient comes at diagnosis, we do some basic blood tests, RFT, electrolytes, LDH, uric acid, potassium. Is there evidence of TLS? Yes or no? So that's what they have mentioned. No TLS at diagnosis. Assess the cancer size. Is it a very small cancer, or is it a medium-sized cancer, or is it a large mass, bulky tumors, huge mediastinal mass, but no TLS at diagnosis? We have to be judicious. Suppose you have a huge mediastinal mass, no TLS at diagnosis, but a large cancer mass. We have to see whether are they potential candidates to give all the intense chemotherapy upfront. If you give all the chemotherapy, for example, ALL has got 4 drugs we have to give in the first month. Vincristine, doxorubicin, steroid, pegasparginase, 4 main drugs. When they have a high tumor lysis, high bulky disease, we initially start with steroid alone for the first 1 week, ensure that the tumor mass burden is reduced, the TLS risk is reduced, then we add on other chemotherapy. On the other spectrum, if it is the same large, it's a leukemia, but less risk of TLS, not a bulky disease, and WBC count is not that very high, when we can expect the tumor lysis won't be that much, we give all the 3 drugs from the day 1. So that's how we stratify them. And already mentioned, we need to give allopurinol or rasburicase. We have to give adequate hydration at 100 to 125 ml per meter square per hour. Strict intake output has to be monitored. Nursing plays a very important role in this situation. Monitoring electrolytes every 12th hourly, including potassium, uric acid, calcium, sodium, urea, creatinine. All these have to be monitored because there may be a reason where many patients may need dialysis upfront in these situations. Because, as I already mentioned, childhood cancer is highly curable. Burkitt's lymphoma survival is 90%. If they survive the initial 72 hours, they live a long life. So this is very important, a most important oncological malignancy. So how do you manage these TLS? Adequate hydration, as I already mentioned, 100 to 125 ml per meter square per hour. Nowadays, routine alkalization is not needed, and we need to maintain a strict urine output. If there is a positive balance, we consider adding low dose furosemide. And for uric acid excretion, we look at the levels of uric acid. Less than 7 gram per deciliter, we give allopurinol. If it is more, we give rasburicase. So rasburicase is one enzyme we can give once a day, 0.2 mg per kg per day. That can be given. That is one thing. And most important thing is, after we give rasburicase, suppose the consultant is asking to take a repeat uric acid values, the sample should be sent in an ice pack, because rasburicase is an enzyme. You take the blood sample from the patient. You have given the medicine called rasburicase. After 8 hours or 4 hours, consultant says repeat uric acid. You take the blood sample, put it in the ice pack. Why? Because rasburicase, being an enzyme, will continuously keep acting. If you put in an ice pack, the enzyme levels will be inhibited. So you will get a correct value. If you send in the normal temperature, the levels of uric acid will be falsely low. So that is one important point in this. And electrolyte abnormalities is very important, because if potassium is high, you have to avoid potassium, both oral as well as IV fluids. Parents will ask, can we give banana? Can we give Elanir? We tend to avoid in the first 1 week all the potassium containing feeds and fluids. And K binders can be given. We have to stabilize the heart. Calcium gluconate has to be administered. We can give insulin dextrose infusion for these patients. Livol and salbutamol nebulization. Basically, all these things will shift the potassium from the blood into the cells. So that's how insulin, salbutamol all works. If it is not getting controlled, we need to involve the nephrology team for dialysis. And dialysis in this situation is not that easy as we think, because these children will have high white count. They have increased bleeding tendency, disseminated intravascular coagulation. Platelet count will be low. To put a central line for dialysis catheter, all these things have to be managed, because the patient will be coagulopathic as well as bleeding. Both components will be there. So it's not as easy as we think. And some patients can present with low calcium, hypocalcemia. It can be symptomatic or asymptomatic. Asymptomatic can present either with, they can present with seizures, where we have to give calcium gluconate. And whenever there is hyperkalemia, we have to give calcium to stabilize the heart, because hyperkalemia can cause arrhythmias. That is very important. So coming on to the last and the most common topic, which is seen in the, after we initiate the treatment, is febrile neutropenia. So what is neutropenia? It is when the absolute neutrophil count is less than 1500 cells per microliter. And febrile neutropenia, when you have a temperature, a single temperature of over 101.3 or a sustained temperature for an hour more than 100.4 with a low neutrophil count. It is a commonest oncological malignancy. Most common cause is bacteria, followed by fungus, rarely a viral infection. They can be, fever alone is not a sign for a febrile neutropenia, because when their immunity is suppressed because of chemotherapy, they will not mount a febrile response. They will just have tiredness, abdominal pain, or maybe a jaw pain. No, these are all subtle signs that the child is having a malignant, having an infection. So they can present very early or they can present very late. Sometimes when patients come from the community, had developed fever at home, but they reach the hospital after 8 to 10 hours, they can just present with tachycardia. Patient will have a baseline, a 2-year-old child whom a staff is seeing daily in the ward. The baseline pulse rate is 120 per minute. Suddenly the pulse rate is 160 per minute. That is unexplained tachycardia without any focus. We have to take blood cultures, start antibiotic immediately, because that is an oncological emergency. We should not wait till the patient develops hypotension. So that is the most important thing. Always we know ABC, airway, breathing, circulation. Look into all these parameters. Look in the pulse rate, respiratory rate, saturation, blood pressure, consciousness. All these neutropenic patients, mind you, till they die, they will have normal consciousness. I'm not joking. Their consciousness will be maintained till they go into grade 4 hypotension. So we should not get misleaded. Child will be playing in the mobile phone, but the child will be having shock. So we should not get misled by the fact that child is okay, doing fine. Most important thing is check the vitals. Check the vitals yourself. Don't let it ask anybody else to check the vitals. Feel for the pulse volume. You have to feel for the pulse volume. Palpate the radial pulse. Palpate the dorsalis pedis. There is something called central pulse and peripheral pulse. Peripheral pulse, dorsalis pedis. Please palpate them. Learn how to palpate dorsalis pedis in every shift. Why? Because initial sign of shock, dorsalis pedis will become feeble. Your brachial pulse will be good. Your radial pulse will be good. That will mislead you. So most important thing is you need to know your patient. Second thing is, where is the focus of infection? This is, we need to do the physical examination. From nursing angle, I'm saying. You have to look into the ear, nose, mouth, oral cavity, pharynx, venous site. IV site we need to look in, both central venous axis as well as a peripheral venous site. That can be a sign of infection. Maybe the patient would have had a bone marrow aspiration yesterday. There will be tenderness in that side. Patient would have got admitted for bone marrow aspiration, got discharged, presented 24 hours later with fever. We have to look into the bone marrow focus. That can be a source of infection. We have to take cultures and start antibiotic immediately. Perianal region, most important thing, because source of bacteria is present there. Look into the nails. So head to foot, all the openings have to be looked into. Most important thing is, we need to, whenever a patient comes, we need to assess them within the first 15-20 minutes, take blood cultures, CBC, start the first dose antibiotic within the first 15 to 30 minutes of the patient when he reaches the emergency. Any delay will be life-threatening. We have to cover gram-negative coverage is very important. We generally give an anti-pseudomonal agent. It is a hospital, it is institution-wise policy. It varies between institution to institution. We can start a piperazine tazobactam with amikacin or a cefoperazone sulbactam with an amikacin, plus or minus an MRSA cover when the patient presents even in a severe distressed fashion, or if there is line phlebitis and all. Even a minimal signs and symptoms of sepsis should be treated aggressively. Abdomen pain only patient is presenting with, low count, no fever. That is also an emergency. We have to admit, take blood culture, start antibiotic. This is very important. It's a medical emergency. The initial ABC should be done in 1 minute. Primary assessment and investigations, where is the focus, should be done within 5 minutes. First dose antibiotic you give within 15 minutes. If there is any shock, we have to treat them immediately. Like for example, a non-neutropenic child, for example, a non-oncological child can present with dehydration, vomiting, and shock. We can give lot of fluid bolus, 20 ml per kg over 20 minutes, 20 ml, 20 ml. We can give 60 ml per kg within 1 hour. But for oncological patients, they will not be able to tolerate such high fluid overload. After 10 ml per kg, we start early initiation of inotropes is very important in this situation. I already mentioned signs of inflammation will be minimal. Rubor, pallor, dolor, calor, all will be very minimal, especially when they have no counts. Pain is usually preserved. Any localized pain, just treat them immediately. Always unexplained tachycardia, slight abdomen discomfort. Child is not looking well. Take blood culture, start the antibiotics with a low count. And patient has come with febrile neutropenia, you are assessing them. Patient is stabilized, but you have to reassess in every shift, daily assessment. Look for new symptoms. You have sent blood cultures on the first day. Don't wait till the final printed culture report comes. You have to call the microbiology. Ask every day, is there any growth? Because if there's a resistant bacteria, we need to upscale antibiotics immediately. So daily physical examination is needed. Previous culture reports has to be reviewed, because these patients will get multiple courses of chemotherapy. Like for example, AML will have 4 high dose chemotherapy. During the first dose chemotherapy, they have developed a resistant bacteria. The same bacteria can come during the second chemotherapy. So based on that, we have to initially itself do the upscale the antibiotics according to the previous culture sensitivity report. Always look into the vascular catheter site, if any redness is present or not, because they are all sorts of infections. If needed, take additional blood cultures. Not improving in 24 hours, repeat blood cultures, upscale antibiotics. And any imaging, if suspected, please do at the earliest. An X-ray chest will not pick up any patch or consolidation, especially in a neutropenic patient. It will be identified on a CT chest. So most important thing is health education. Education to the parents, education to the family members. Any subtle signs, bring the child to hospital immediately. From nursing aspect, we have to tell them to have a proper mouth care, perineal care, neutropenic diet. Most important thing is central line care. Central line care is a key where we can reduce the hospital acquired infection in these patients. Thank you.
Thank you, sir, for sharing in-depth knowledge and experience in hemato-oncological emergencies. Any queries from the audience? Now I invite Associate Professor, ACM, to present an anecdote. Dr. Keshav Brahma as a token of our gratitude. Thank you, sir. Thank you, ma'am. So we can start this workstation now.
Many studies have identified father's attitude as the strongest indicator of whether her partner will breastfeed or not. Then statement of the problem, a study to assess the knowledge, attitude and perception regarding breastfeeding among partners of pregnant women attending outpatient department of selected hospitals, Calicut. Then objectives of the study, assess the level of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women. Then find out relationship between knowledge and attitude, knowledge and perception, attitude and perception regarding breastfeeding among partners of pregnant women. Then find out association of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women with the selected socio-demographic variables. Then hypothesis, S1, there will be significant relationship between knowledge and attitude regarding breastfeeding among partners of pregnant women. H2, there will be significant relationship between knowledge and perception regarding breastfeeding among partners of pregnant women. Then H3, there will be significant relationship between attitude and perception regarding breastfeeding among partners of pregnant women. Then H4, there will be significant association of knowledge of partner of pregnant woman regarding breastfeeding with the selected socio-demographic variables. And H5, there will be significant association of attitude of partner of pregnant woman regarding breastfeeding with the socio-demographic variables. And H6, there will be significant association of perception of partner of pregnant woman regarding breastfeeding with the selected socio-demographic variables. This is the theoretical framework of the study taken from Rosenstock's health belief model. And review of literature, areas of literature review are father's knowledge, attitude and perception regarding breastfeeding, mother's knowledge, attitude and perception regarding breastfeeding, and parents' knowledge, attitude and perception regarding breastfeeding. Sources of literature review are Google Scholar, PubMed and Medline. And about methodology of the study, quantitative research approach is used with the descriptive research design. And this is the schematic representation of the study. And variables used in this study are knowledge, attitude, and perception. Setting of the study is OPDs of ASTER MIMS Hospital, Calicut, and population partners of pregnant women. Sample are partners of pregnant women visiting OPDs of ASTER MIMS Hospital, Calicut. Then purposive sampling technique is used, and sample size is 200. Then inclusion criteria, partners of pregnant women who are willing to participate in the study, able to write and read Malayalam. Then exclusion criteria, partners of pregnant women who have cognitive or psychological problems, have any abnormal children, are not present at the time of visit. Then description of the tool, there are 4 tools used in this study. First tool is socio-demography performer, which contain 9 items, and structured knowledge questionnaire, which contain 25 items, and Iowa infant feeding attitude scale, which contains 17 items, and scale to assess perception regarding breastfeeding, which contain 9 items. Then data collection process, first we obtain permission from the authority concerned and sample meeting inclusion criteria were selected. Then patient information sheet was given to selected subjects and obtained informed consent. Then collected the data using specific tools. Then methods of data analysis, descriptive and inferential statistics are used. Then analysis and interpretation of the data. Section 1, frequency and percentage distribution of socio-demographic variables. Section 2 is assessment of level of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women. Then section 3 is relationship between knowledge and attitude, knowledge and perception, attitude and perception regarding breastfeeding among partners of pregnant women. Then section 4 is association of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women with the selected socio-demographic variables. Then section 4, then this is a sample characteristics. According to this table, majority of the sample belongs to 26 to 30 years of age, and majority are higher secondary and above education status, and majority are belongs to nuclear family, and majority have family monthly income more than 30,000. Then majority of the sample are from rural area, and majority are partners of primi gravida, and majority have received prior information regarding breastfeeding. Then distribution of sample based on religion. Here the majority of the sample is belongs to Muslim category, and majority of the sample are doing private job. Then assessment of level of knowledge, attitude and perception regarding breastfeeding. Graph shows distribution of sample based on knowledge regarding breastfeeding. Here the majority of the sample have good knowledge regarding breastfeeding, and distribution of sample based on attitude regarding breastfeeding. Here more than half of the sample have positive attitude towards breastfeeding. Then distribution of sample based on perception regarding breastfeeding. Majority of the sample have good perception towards breastfeeding. Then relationship between knowledge and attitude, knowledge and perception, attitude and perception regarding breastfeeding among partners of pregnant women. The relationship between knowledge and attitude regarding breastfeeding among partners of pregnant women. The p-value is more than 0.05. So there is no relationship between knowledge and attitude. So the research hypothesis is rejected and null hypothesis is accepted. Then relationship between knowledge and perception regarding breastfeeding among partners of pregnant women. The p-value is less than 0.05. So there is relationship between knowledge and attitude. Research hypothesis is accepted and null hypothesis is rejected. Then relationship between attitude and perception regarding breastfeeding among partners of pregnant women. There is no relationship between perception and attitude. So there is research hypothesis is rejected and null hypothesis is accepted. Then association of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women with the selected socio-demographic variables. Here the p-value of age, education and occupation are less than 0.05. So there is association between knowledge and these variables. Then association of attitude regarding breastfeeding with the selected socio-demographic variable. There is no association between attitude and these selected socio-demographic variables. Then association of perception regarding breastfeeding with the selected socio-demographic variables. The p-value of age and occupation are less than 0.05. So there is association between perception and these two variables. Then discussion is organized under the following sections. First section is socio-demographic characteristics of partners of pregnant women. Then level of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women. Then relationship between knowledge and attitude, knowledge and perception, attitude and perception regarding breastfeeding among partners of pregnant women. Then association of knowledge, attitude and perception regarding breastfeeding among partners of pregnant women with the selected socio-demographic variables. Then nursing implication in nursing practice, nurses play an important role in initiation of breastfeeding. The support of breastfeeding by partner is very important in initiation of early breastfeeding. So nurse can provide optimum information regarding the importance of breastfeeding and thereby change the attitude and perception regarding breastfeeding among people. Then nursing education. Nursing curriculum can be modified to include educational training on breastfeeding practices for nursing students. Then in nursing administration, the nurse administrators can organize men-centric parental education to promote breastfeeding practices. Then nursing research, the study will be a valuable reference material for further researches. The methodology and findings of the study help the nurse researchers to explore further knowledge on breastfeeding. Then recommendations of the study, a comparative study can be done between knowledge and attitude, attitude and perception regarding breastfeeding among partners of antenatal mothers and postnatal mothers. A similar study can be applied for father of children who have nutritional problems. A similar study can be conducted with a large sample size. The same study can be conducted by providing a structured teaching program for partners of pregnant women. Then limitations of the study was confined only to a single setting. The study was limited to only partners of pregnant women who accompany them in OPDs. These all are the references of the study. Thank you. I think the support of the partners will help the mothers to feed the baby, and this support will help them during that critical situation. I think some teaching training program given to the partners will help to change their attitude, knowledge, and perception regarding breastfeeding.
Nurses role in lactation and breastfeeding. Lactation specialists like that, some role is there in abroad countries and all. So they are giving specialists here, training for the nurses, and they are known as lactation specialists. So that will help inside the nurse administrators role. We can recommend on such a program. So specific role of nurses, I don't know whether hospitals will implement such a role. Nursing role, there is one post is like that. Lactation specialist nurses.
Thank you.
Next, I invite Ms. Bobby to present his side.
Good afternoon, all. Today I am presenting my paper presentation. My problem statement. A comparative study to assess the effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees of selected university, Mangalore. The woman is one of the greatest creation by God. Menstruation is the most crucial stage of woman's growth cycle. When she reaches her perfection and transforms both instinctively and physically, this marks the start of her change from a young woman to a woman with beautiful intellect and physique.
Dear delegates, now we have completed the first counter workstation. You can move to the next station. Group 1 can move to station 2, 2 to station 3, 3 to 4, 4 to 5, and 5 to 1. We can start the session.
Good afternoon all. Today I am presenting my paper. Problem statement, a comparative study to assess the effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees of selected University, Mangalore. Woman is one of the greatest creation by God. Menstruation is the most crucial stage of woman's growth cycle when she reaches her perfection and transfers both intellectually and physically. This marks this start to her change from a young woman to woman with a beautiful intellect and physics. This time is very crucial in her profession to become a mother. Menstruation may be irregular or irregular due to a variety of factors, including dysmenorrhea or painful menstruation, which is a prevalent condition among women in their reproductive years. Physical and mental difficulties she is experiencing during menstruation include pain, discomfort, vomiting, dizziness, mood swings, and so on. Need for the study. Menstruation is like a close friend that accompanies a woman every month. Menstruation can be an unpleasant and may lead to problems named as menstrual disorders. According to WHO, approximately about 18 million women aged 30 to 35 years experiences menstrual disorders. If menstruation is irregular, it causes a lot of discomfort that disturbs normal life of the woman and needs treatment for it. The treatment also affect more alternative is chair aerobic and core strengthening exercise. So I feel it is necessary to find the effect of those exercise on dysmenorrhea. The study objectives were first one, to assess the level of pain during menstruation among employees. Second one, to assess the effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees. Third one, to compare the effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees. Fourth one, find out the association between pre-test pain score during menstruation with the selected socio-demographic variables. Operational definition, effectiveness. In this study, it refers to difference between pre-test and post-test scores of working women with dysmenorrhea or painful menstruation receiving chair aerobic and core strengthening exercise. Chair aerobic exercise in this study, it refers to exercise such as knee lift, lunges, punches, crispos, and spine twists. Each subject has to complete 4 days in a week and continue for 4 weeks. It should be done in before and after menstruation. During menstruation, we have to avoid. And core strengthening exercise in this study, it refers to exercise as pelvic bridging, basic plank, cat and camel, spine twist, and Superman. Each subject has to complete 4 days in a week and continue for 4 weeks before and after menstruation. Dysmenorrhea. In this study, it refers to working women suffering with difficulty in menstruation with a severity of pain more than or equal to 5, assessed with the working ability, location, intensity, day dysmenorrhea scale, that is valid scale. Employees. In this study, it refers to women within the age group of 20 to 49 years who working in the selected University, Mangalore, and suffering with the dysmenorrhea. Assumptions. The study assumes that dysmenorrhea is common among working women and allopathic treatment may cause adverse effect. Exercise does not have any side effects. Delimitation. The present study delimited in the employees of NPO University at Mangalore with age group of 20 to 49 years. The present study delimited in the two core strengthening exercise and chair aerobic exercise. Hypothesis. The following hypotheses formulated for the study were tested at 0.05 level of significance. H1, there will be a significant difference in severity of pain during menstruation after chair aerobic exercise among employees. H2, there will be a significant difference in severity of pain during after core strengthening exercise among employees. H3, there will be a significant difference between post pain score of chair aerobic exercise and post pain score of core strengthening exercise on pain during menstruation among employees. H4, there will be a significant association between pre-test pain score with a selected socio-demographic variable. Review of literature. In this study, I have divided my review of literature under section A, literature related to prevalence of dysmenorrhea among employees, among women, and section B, literature related to exercise on dysmenorrhea among women. Section C, studies related to effectiveness of chair aerobic exercise and core strengthening exercise. Conceptual framework, I have used emoji king goal attainment theory for framing the conceptual. And methodology and research approach, I was used as quantitative research approach. Research design was quasi-experimental, pre-test, post-test control group design. The setting was endpoint deemed to be university, and target population were employees between the age group of 20 to 49 years, and sample size were 30. In each group, I have taken 30 samples, and sampling technique, purposely sampling techniques I have used. The study design for intervention group 1, I have done for 3 groups, intervention group 1, intervention group 2, and control group I have done pre-test. And for intervention group 1, I have given intervention chair aerobic exercise. Intervention group 2, I have given core strengthening exercise. Then for 3 groups, I have done post-test. Then variables under the study, independent variable, core strengthening exercise and chair aerobic exercise. Dependent variable, pain during menstruation, and demographic variable, age, type of family, marital status, education status, profession or occupation, year of experience, duration of menstruation in a month, previous knowledge of exercises. And tool, I have 2 tools, section A, demographic performance, section B, valid dysmenorrhea score, that is working ability, location, intensity, days. In content validity, the tool was found to be adequate and appropriate following the review of literatures and pre-testing. The investigator pre-tested the instrument such as valid scale on 6 employees after receiving formal administrative approval. The tool was just judged to be clear, practical, and free to ambiguity. And the tool reliability, the stability of the tool was assessed using test-retest method. The R value was 0.93. Hence, the tool was found to be statistically reliable. In result, I have characterized. I have done the result under first one, section A. Section A, description of demographic variables of employees who are working in selected university, Mangaluru. Section B, effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees. Section 4, compare the effectiveness of chair aerobic exercise and core strengthening exercise on dysmenorrhea among employees. Section 4, association of pre-test pain score with the selected socio-demographic variable. In table 1, distribution of socio-demographic variable in terms of frequency and percentage in 3 groups, intervention group 1, intervention group 2, and control group. Majority of samples belongs to age group of 20 to 25, and in the type of family, majority of samples from the 3 groups were belongs to nuclear family, and the majority of samples from the 3 groups are having the marital status was single, and education status of intervention group 1, intervention group 2, and control group were majority of participants were graduated. And regarding the occupation, majority of sample from intervention group 1, that is 40% were staff nurses, and 26.7% samples from intervention group 2 were cleaning staffs and staff nurses respectively, and 36.7% samples were from control group were office staff. Then year of experience, and 63.3% sample from intervention group 2, intervention group 1, 60 sample from intervention group 2, 66.7% sample from control group were having 1 to 5 years of working experience, and 56.7%, 73.3%, and 60% samples from intervention group 1, intervention group 2, and control group were having 5 to 7 days of duration of menstruation in a month. And majority of samples from the 3 groups were having any previous knowledge on exercises. And table 2, is pre-test assessment of pain. And intervention group 1, intervention group 2, and control group were having, majority of samples were having moderate pain, that is 56.7% and 60% in each intervention group 2 and control group. And post-test assessment of pain, 43.3% of samples from intervention group having moderate pain, and 50% of samples from intervention group having mild and moderate pain respectively, and 50% of samples having moderate pain in control group. Distribution of pre-test and post-test pain score. in intervention group 1. In pre-test pain score of intervention group 1, mean pain score was 1.43 and mean post pain score was 1.2, and there is no significant difference in the pain score after intervention 1. Hence, H01 is accepted and H1 rejected. And distribution of pre-test and post-test pain score of intervention group 2. After the intervention core strengthening exercise, there is a significant pain difference in pre-test and post-test. So hence p-value shows 0.01. Hence it is less than 0.05. There is a significant change in the pain after core strengthening exercise. Hence H2 accepted and H02 rejected. And comparison of post-test pain score of intervention group 1 and intervention group 2, there is a significant pain difference in the intervention group 1 and intervention group 2. Hence, there is H3 accepted and H03 rejected. And then move on to association between pre-test and post-test pain score. And there is no association between, there is an association between age, marital status, year of experience, duration of menstrual cycle, and between the pre-pain pain score. Then discussion here, it is significantly very important to have a core strengthening exercise to reduce dysmenorrhea, because according to WHO, approximately about 80 million women aged 30 to 35 years experience menstrual cycle, menstrual disorders, and core strengthening exercises are useful technique with no side effects. It reduces pain during dysmenorrhea, pain during menstruation, and exercise training can be included in theory, practical aspect of curriculum. Proper exercise training classes can be given to nurses and for their personal and professional benefit. Thank you. Valid scale I have used. It's a standard scale. I will assess working ability of the woman during the menstrual days and location where they are having pain. Maybe in the abdomen, maybe in the legs, both the site they have to mention, and the intensity of the pain and how many days they have pain. If 3 days, 4 days, or continuous 7 days they have pain, like that. It's a standardized sampling. I have geographically I have divided the samples, because otherwise sampling contamination will become. So I have used in NPO University I have selected. The dental college I have taken for intervention group 1, and medical college I have taken for intervention group 2, and nursing college I have taken for control group. Then purposive sampling techniques I have used. Same tool I have used after completing the menstruation, because after completing the menstruation only I can give this tool, because the tool they are asking the days of pain, how many days they having pain. So they have to complete their menstrual cycle, then I can approach for post-test. Yes, ma'am. So how much time? 4 weeks I have taken. 4 weeks. Per person. Yes. So like that, how long? Because 3 group I have done simultaneously. I have done for 3 groups. But the date, menstrual date is different for different persons, so it is delayed.
I want to tell you something. Today is a council meeting. What happened is the Kerala University of Science about menstrual leave. Minister of Higher Education, Government of Kerala has mentioned 2% of leave for menstrual pain, but university has not accepted it. Committee has been formed. I went for a and medical and health science institute people, they have constituted a committee to find out whether this has to be given. And if it is given, you know that when you are taking medical leave, you have to compensate. Then you have to compensate. So those who wanted to take leave, remember that once you take the leave, because Indian Election Council says the person that is, you have to take it up before the examination. So the committee is formed now. Today, let's take leave, all the leaves and a few teachers. And the paper is children and maternity also has been signed. 6 months, biology starts to give 2 months, 60 days of maternity leave, which has to be made again. They have to make it up. According to Nursing Council, if a person is taking more than 13 days, they have to repeat the course. Then if you are giving 60 days of leave, what will happen? 1 year will go. If it is a different course, maybe 2 years will go. So this decision was there, and I don't think that we will be able to take all those things. 6 months is allowed by the Kerala University of Sciences for the training of PhDs. But for you, it is not there. That's what I want to do. Leave it to them, you can't do it, they're going to do that. So what are we doing this?
That's what I have.
Translation, please change. 15 minutes over. Move to the next station.
Good afternoon. Myself Neenu, Senior Lecturer, MIMS College of Nursing. I am present here to present my scientific paper. So, title of my study: Prevalence of Symptoms of Depression among Elderly residing in Thiruvananthapuram Corporation. Background of study: world's population is aging rapidly. Between 2015 to 2050, the proportion of the world's older adult is estimated to almost double from about 12% to 22%, according to WHO. According to the census report of 2011, Kerala is the state with the highest percentage of old age, that is 12.6%, whereas in India it is 8.6%. Need and significance of the study: aging is a universal process associated with deteriorating health status. With the passage of time, certain changes take place in the organism, leading to morbidities, disabilities, and even death. Depression shall become the second largest illness in terms of morbidity in the world. Statement of the problem: a study to assess the prevalence of symptoms of depression among elderly residing in selected wards in Thiruvananthapuram Corporation. Objectives of the study: primary objective, to estimate the prevalence of symptoms of depression among elderly residing in selected wards in Thiruvananthapuram Corporation. Secondary object, to determine the association between symptoms of depression and the socio-demographic variables of elderly residing in selected wards in Thiruvananthapuram Corporation. Assumption: depression may be high among elderly. Review of literature discussed under: review of literature related to old age, review of literature related to depression, review of literature related to depression among elderly. Research methodology: research approach, quantitative research approach, research design, cross-sectional research design. And the study setting: selected wards in Thiruvananthapuram Corporation. Population: elderly of 60 years and above who are residing in the selected wards in Thiruvananthapuram Corporation. Sampling technique: multi-stage cluster sampling technique. Sample size estimation: n is equal to 4 pq by d square. Sample size fixed in this study was 160. Inclusion criteria: elderly residing in Thiruvananthapuram Corporation who belongs to 60 years and more and are willing to participate in the study. Exclusion criteria: elderly, those who are not able to communicate; elderly, those who are living in the old age homes. Tool 1, structured interview schedule, socio-demographic data and clinical data. Tool 2, geriatric depression scale, GDS, and technique semi-structured interview. Data analysis and interpretation done. Section 1, socio-demographic data. Section 2, clinical data. Section 3, prevalence of symptoms of depression among elderly, and section 4, association between symptoms of depression and the selected socio-demographic variables of elderly. Results show that session 1, socio-demographic data, out of the 160 participants, 55% of them belong to the age group of 60 to 69 years. Among the participants, 61.3% were females and 38.8% were males. Out of 160 participants, 24.4% participants had high school education. Majority of participants, 43.1% retired from their work, but 0.6% will still working after their retirement. About 35% participants were unemployed and majority participants were unmarried, that is 56.3%, and 37.5% were widow or widower. About 53.8% participant belongs to Hindu religion. Most of the participants belongs to nuclear family. Among the participants, 63.1% of were residing in urban region. Majority of participants were with monthly income ranging from 10,000 to 25,000. About 31.9% participants were living in with their children and 29.4% living with their spouse. Among participants, 20% had habit of smoking. About 30.6% participants had strong social support and 30% participants had poor social support. Clinical data, section 2, that is about 91.9 participants were suffering from any of the chronic disease. Most of them have visual impairment, that is 99.4%. More than half of them have musculoskeletal diseases, that is 67.7%, and hypertension, 62.4%. About 51.9% participants have diabetes mellitus and 31.5% participants have respiratory disease. Section 3, prevalence of symptoms of depression among elderly. More than half of the participants, that is 55%, had symptoms of severe depression. About 27.5% participants were with the symptoms of mild depression. Only 17.5% were normal. Association between symptoms of depression among elderly and the selected socio-demographic data. I got association between depression and the current occupational status and place of living and the living pattern, and in case of elderly living with children and other relatives, and symptoms of depression and habits, especially the alcoholism. Association between symptoms of depression and elderly and clinical data. Elderly who have musculoskeletal disorders, respiratory disorders, and mental and neurological problems have symptoms of depression. Since P value is less than 0.05, so there is statistically significant association between symptoms of depression and these chronic diseases. Discussion. A study conducted in South Indian community revealed that physical illness and poverty were significantly correlated with geriatric depression and support the present study findings. In the current study, chronic disease such as musculoskeletal disorders, respiratory disorders, and mental and neurological problems have significant association with the symptoms of depression. A median prevalence rate of depression among the elderly Indian population was determined to be 21% in a study conducted by Ankur Batra in Karnataka. In the current study, 55% of participants have symptoms of severe depression and 27.5% of them have symptoms of mild depression, and rest of them were normal. Limitations of the study: only 160 participants were studied. Study was confined to Thiruvananthapuram Corporation only. Number of male participants were less as compared to females. Participants who cannot communicate were excluded from the study. Recommendations: counselor should be appointed in every elderly clinic for the welfare of the elderly. Implement cost-effective model treatment which can be easily used in primary care settings for effective treatment in elderly depression. Conduct periodic screening and camps for early identification and prevention of depressive disorder. Conduct health education session for caretakers of elderly and educate the workers at grassroots level, ASHA worker, JPH and Anganwadi workers about the physical and mental health issues of elderly. Thank you. Yes, sir. I got the relation with especially with their living pattern, especially with the children and daughter-in-law, otherwise other relatives. They are suffering from more problems from them, and Because of that, they are suffering from depression and other diseases, chronic diseases such as musculoskeletal diseases, visual impairment. This will also a reason for depression. GDS, geriatric depression scale. Yes. Females. Females.
Instead of writing these results, repercussions, it is the discussion happens.
Thank you.
Good afternoon to all. Today I am going to present my scientific paper. The title of the study, compare the severity of menopausal symptoms, coping strategies and quality of life among women during various postmenopausal periods. And menopause is a physiological cessation of menstrual cycle associated with advancing age in any woman. However, it is considered as an unwelcome phenomenon among many women. Most of the women were too tired by physical problems. Medical treatment were given only to subside the symptoms. And most of the women were disturbed with the psychological problems too, like depression, anxiety about the health, stress, blaming self, and suicidal ideation. But none of the treatment was given for the psychological problems. Both these physiological and psychological problems affect the quality of their life. So thus it is reasonable to investigate whether there is any association between the period of menopause and severity of symptoms, coping strategies, and quality of life. The objectives of the studies are: assess the severity of menopausal symptoms among postmenopausal women, assess the coping strategies among postmenopausal women, assess the quality of life among postmenopausal women, and compare the severity of menopausal symptoms, coping strategies, and quality of life during various postmenopausal periods. Find the relationship between severity of menopausal symptoms and quality of life during various postmenopausal periods. Find the relationship between coping strategies and quality of life during various postmenopausal periods. And last, find the association between quality of life and socio-demographic variables among postmenopausal women. And the assumption was, women in earlier postmenopausal period have poor quality of life. The conceptual framework is based on Nola J. Penderson Health Promotion Model. And the review of literature. In the present study, literature review is presented under menopausal problems among women and coping strategies of menopausal women, quality of life among menopausal women. And the methodology of the research approach was quantitative survey research approach, and descriptive research design was the research design. And the variables, the selected variables are menopausal problems, coping strategies, and quality of life. And socio-demographic variables are age at menopause, education, occupation, income per month, marital status, parity, food habit, lifestyle diseases, and duration since menopause. And setting of the study, selected Panchayat at Talasheri, population post-menopausal women, sample menopausal women who are residing in selected Panchayat at Talasheri. And the sample size was 150, sampling technique, purposive sampling technique. Inclusion criteria, women who have cessation in regular menstrual bleeding for the last 1 year, who are willing to participate in study. And the exclusion criteria are women with surgical menopause, women on treatment for menopausal symptoms, and illiterately disabled. Tool and technique. Section 1, tool was, researcher was developed a structured interview schedule consist of 10 items. And section 2, that is tool 2, researcher developed a 4-point Likert scale to assess severity of menopausal symptoms. It included 4 components and contained 20 questions. And tool 3, researcher has developed a 4-point Likert scale to assess the coping strategies of menopausal women. Tool consists of 2 components and 15 questions. And tool 4, modified WHO breath scales to assess quality of life. 5-point self-rating consists of 4 domains and 26 questions. And the content validity was done by seven experts from the obstetrical and gynecological department. And reliability of the tool was calculated by using Pearson formula, was found to be 0.86 for the tool to assess the severity of menopausal symptoms and 0.76 to 76 for the tool to assess coping strategies of menopausal women. And the reliability of the modified WHO breath scale was calculated by Cronbach alpha method, and it was found to be 0.94. And data collection process. After permission obtained from the Pinarayi Panchayat and Ernakulam Panchayat, the study was conducted from February 2, 2020 to 29 February 2020. And post-menopausal women at 6 months, 1 year, and 1.5 years were identified by purposive sampling. After obtaining consent from each subject, data was collected by interview schedule and rating scale. And data analysis, descriptive statistics, frequency and percentage, inferential statistics, chi-square test, correlation, and ANOVA was used. First one, section 1, distribution of sample based on socio-demographic variable. And the table shows that majority of the sample who belong above 45 years of age, and frequency of percentage distribution of sample based on socio-demographic variable. And frequency and percentage distribution of sample based on socio-demographic variable, income per month, and lifestyle diseases. And the figure shows the percentage distribution of sample based on food habit, and frequency and percentage distribution of sample based on socio-demographic variable, marital status, parity, and duration since menopause. And this table shows that majority of the women who belongs to 1.5 year of since menopause, and 55 number women who belongs to 1 year of since menopause, and 31 belongs to 6 months. And the next section, distribution of sample based on severity of menopausal symptoms, coping strategies, and quality of life among sample. And third section was the compare the severity of menopausal symptoms, coping strategies, and quality of life among women in various post-menopausal period. And the fourth section, relationship between severity of menopausal symptoms, coping strategies, and quality of life among sample. And the last section, that is the section 5, association between the quality of life and socio-demographic variable among the sample. And the data presented in the last table, that is the section 5, shows that there is a significant association between the quality of life and duration since menopause, and there is no significant association between the quality of life and other selected socio-demographic variables such as age at menopause, education, occupation, income per month, marital status, parity, food habit, and lifestyle diseases. And about the discussion, the findings of the survey conducted in 2007 found that 8% women have already attained menopause between 35 and 39 years, and normal menopause starts between at the age of 45 to 55 with a mean age of around 51 years worldwide. And the study which revealed the most frequency during the late period of menopausal symptoms are physiological, somatic, vasomotor, and sexual discomfort, and the psychological comprising sleep disturbances, anxiety and depression, irritability, feeling of panic and forgetfulness, somatic comprising ache and pains and joints, dizziness, palpitation, frequent severe headache, increased frequency of urination, vasomotor comprising night sweat and hot flushes, and sexual discomfort comprising difficulties with intercourse and vaginal dryness. And almost similar findings was found in the study shows that majority of the women at 6 months, 1 year, and 1.5 years of post-menopausal period were using average coping strategies, and majority of the women at 6 months of post-menopausal period were having good quality of life, and majority of the women at 1 year and 1.5 years of post-menopausal period were having average quality of life. And this study focused on the comparison of the severity of menopausal symptoms, coping strategies, and quality of life among women in various postmenopausal periods. The study findings showed that there are statistically significant difference in severity of menopausal symptoms, statistically significant difference in coping strategies, and statistically significant difference in quality of life among sample at 6 months, 1 year, and 1.5 years of postmenopausal period. The nursing implications, nursing practice. Being a primary care provider, nurse can play a vital role in the management of menopausal problems. The nurse need to become knowledgeable about individualization of menopausal problems among their clients. And about the nursing education, nursing curriculum should give emphasis to prepare the students to assist the client and community in developing self-care potential. The curriculum should include more topics regarding menopause, and students should be encouraged to give health education to women regarding physiological transition during menopause and prepare the woman to accept the menopausal changes and to adjust with these problems. And about the nursing research, most of the studies about menopausal problems are done by researchers in the Western countries. In our country, very few studies were carried out to assess the severity of menopausal symptoms, coping strategies, and quality of life among women during various postmenopausal periods. And about the nursing administration, nurse as an administrator can influence the quality of life care in clinical settings, community settings, nursing homes, Kudumbasri units by planning a woman's health clinic and supervising care in different levels. And the limitation of the study was identified as menopausal problems of women are only one reported problems of the subject. Generalization of the findings is limited due to small size and purposive sampling technique. More than one sample was taken at a time of the study. It is limited only selected to part of the population. The study period is limited for 1 month. And the recommendations are: another study can be conducted on a large sample using convenient sampling technique. A comparative study regarding menopausal problems can be conducted among hormone replacement users and non-users. A standardized health assessment tool can be developed to elicit menopausal problems among women. A comparative study regarding quality of life can be conducted among premenopausal and postmenopausal women. And the conclusion: there was a significant difference in severity of menopausal symptoms, coping strategies, quality of life among sample at 6 months, 1 year, and 1.5 years of postmenopausal period. There are significant relationship between severity of menopausal symptoms and quality of life, and there was no statistically significant relationship between coping strategies and quality of life. And there was a significant association between quality of life and duration since menopause. Thank you. NSP 4 PQ by D square.
So you have a sample size calculation.
Yes.
Okay, so based on that, you have
yes, 150 sample.
Okay, so then in your recommendation, you have why continuing.
Sir, actually the group was the sample was grouped into 3. The women who are attained menopause after 6 months, and after 1 year, and after 1.5 years. So actually the group was not included as actual numbers, because the only 6 month attained menopause women are 31. So according to that wise, I most interested to select the purposive sampling technique. According to such a purpose, we can select the numbers in that 3 group. So that was the purposive sampling technique was used. 2.
So how did you track this?
Okay, with the help of ASHA workers and the Kudumbasri Anganwadi workers, they will approach the list of or the data regarding the menopausal women, or those all are the age between the 50 or 45 to 15 years, and they gave me a list of these women, and I directly approach that women in that residing area and select them. ANOVA
ANOVA is using the comparison between these variant groups. Mainly 3 groups. So ANOVA is using. Thank you.
Next.
Good afternoon all. My problem statement is quasi-experimental study to assess the effectiveness of tell, show, do technique, knowledge and practice regarding oral hygiene among intellectually disabled children at selected special schools of Valsad district, Gujarat. In child is a state of physical, mental, intellectual, and social, emotional well-being, and not merely absence of disease or infirmity. The help children in family, environment, and community that provide when the opportunity to reach their fullest development potential. Children cannot achieve optimal health alone. They are dependent upon the adults in their family, community to provide with the environment in they are learn, grow successfully. Healthy children are also successful learners. Need of this study, according to the Center of United States, prevalence of intellectual disability lower among young children than older 0.73 among children 3 to 7 years, 1.43%, 8 to 12 years, 1.40 among 13 to 17 years. In India, out of 1 million population, mental retarded in India, 2070, out of these 24.5 students, individual with a disability comparison, 10% of total population in developing countries and 12% in developing countries. Objectives of the study: to assess the existing level of knowledge and practice regarding oral hygiene among intellectually disabled children in both experiment and control group. To assess the effectiveness of tell, show, do technique and knowledge and regarding oral hygiene in experimental group. To correlate the level of knowledge with the practice regarding oral hygiene among intellectually disabled children of experimental group and control group. To find the association of knowledge and practice oral hygiene individually disabled children with their selected demographic variables of experimental and control group. Hypothesis. Hypothesis 1, there will be a significant difference between pre-test and post-test. The level of knowledge and practice on oral hygiene among intellectually disabled children of experimental at a level of P less than equal to 0.05. Hypothesis 2, there will be a significant relationship between level of knowledge and practice among intellectually disabled children of experimental group. There will be a significant real association of oral hygiene among intellectually disabled children with their selected demographic variables experimental at level of P less than equal to 0.05. Assumption. Intellectually disabled children have inadequate knowledge and practice about oral hygiene. Tell, show, do technique on healthy habits enhance the knowledge and practice of children regarding oral hygiene. Limits of samples. The study has not used random sampling method. Tell, show, do technique not used in deaf and dumb and blind children. The conceptual framework used is modified new Bettyman model. Review of literature related to intellectually disabled children. Review of literature related to oral hygiene. Review of literature related to importance of oral hygiene in intellectually disabled children. Review of literature related to knowledge and practice of oral hygiene. Review of literature related to tell, show, do technique on oral hygiene. Methodology, research approach, evaluative research design, quasi-experimental research design. Non-randomized control group design, control group pre-test and post-test, experimental group pre-test, tell, show, do technique and post-test. Target population research design, target population individually disabled children in special education school in Valsad district. Accessible population individually disabled children in Valsalia special school education. Sample technique convenient sampling. Sample size is 30 experimental and 30 control. Tool and data collection, structured interview schedule, knowledge assessment and observational checklist for practice. Pre-test knowledge and practice experimental control group. Intervention, tell, show, do techniques, only experimental group. Post-test knowledge and practice experimental and control group. Variables under study, independent variable in the study where structured teacher program, tell, show, do technique. Dependent variable is knowledge and practice regarding oral hygiene. Population, target population, intellectually disabled in a special education school in Valsad district, and accessible population, intellectually disabled in Valsalia school, special education school. Sample in study of sample, children in Valsalia 30 plus 30, 60 samples is selected. Sample technique, non-probability convenient sampling technique. Sample size is 16. Sample selection criteria, inclusion criteria, 6 to 12 years of school age children of special education, special school, children whose individual capacity 50 to 60, in children who those who were present at the time of data collection, children those who are not willing to participate. Exclusion criteria, children those who are absent on the day of teaching program, students who are not willing to participate, children who cannot understand or have a sensory problem, children have above the 13 years and below 3 years. Data collection instrument, selected demographic variables such as age, sex, education, religion, and area of residence, and type of socio-economic status. And part 2, there are 12 questionnaires based on their knowledge. Checklist and for practice 40 steps of oral hygiene procedure assessed by observational checklist. Plan of data analysis. Section 1, socio-economic distribution of sample in experiment and control group. Distribution of pre-test level of knowledge regarding hygiene in experiment and control group. Distribution of post-test level of knowledge regarding oral hygiene in experiment and control group. Section 4, distribution of pre-test level of regarding oral hygiene experiment and control group. Section 5, distribution of post-test and practice regarding oral hygiene experiment and control group. Section 6, comparison of pre-test and post-test level knowledge regarding oral hygiene in experiment and control group. Comparison of pre-test and post-test level of practice regarding oral hygiene in experiment and control. Section 8, comparison of post-test knowledge in control and experiment group. Section 9, comparison of post-test practice in control and experiment group. Section 10, correlation between practice regarding oral hygiene experiment and control. Section 11, association of pre-test knowledge and practice regarding oral hygiene with a demographic variable in experiment and control group. In demographic variable age in years, 6 to 8 years, there are 24% in experimental group and 70% in control group. 9 to 10 years, there is 33%, and 11 to 10 years are almost 43% in experimental group, and control group are 40%. In male and female, in control group are 43% and experimental group are 47%. In education, they have children have 100% in school going, and there are 100% in control group. Religion, there are 100% in experiment and control group. In those area of residence, there are for 37% in urban area, 47% in urban area. Rural and for 63% in experimental group in rural area, 53% in rural in control group. Type of family. The standard deviation is 0.85%. The mean percentage of pre-posters is group is 1.4 and 0.8 in control group. The correlation between knowledge and practice regarding oral hygiene in control group 0.36 and 0.42. The child has a moderate level of correlation. Experimental group have strong
correlation. Comparison of posters knowledge and control group, the 60 samples as the t-test is 12.91. Conclusion: the conclusion of the study is individually regarding the oral hygiene and health show to take this effective experimental and knowledge and practice is gross increased. Implication result of studies, implication in nursing and practice, administration and nursing research.
What is your impression? So you have conducted this study. So tell me what do you want to say about this?
In the studies, the in pre-test the children have less practice on oral hygiene. After the post-test, the child has improved their oral hygiene and techniques are learned, and their initiative for oral hygiene daily for practice.
Next.
Thank you. Next, I invite Ms. Julia for
Good afternoon all. Today I am here for my scientific paper presentation. Title of my study, Risk Factors of Low Birth Weight Babies, a Case Control Study. Introduction. Human birth is the most miraculous, transformational and mysterious event of life. Newborns are the most vulnerable group in getting adjusted to new environment. Low birth weight babies need special care after birth, such as help with breathing, staying warm, protection against infection, and getting enough nutrition. Need and significance of the study. Low birth weight is either the result of preterm birth or due to resident growth, fetal growth. Many factors affect the duration of gestation and the fetal growth and thus the birth weight. Several studies recommended that all the pregnant women must be seen on a monthly basis for early detection and treatment of risk factors. According to statistics of Government Medical College Hospital, Kannur, the percentage of babies, 10% of babies are born during the year 2021 were low birth weight babies. Statement of the problem. Identify the risk factors of low birth weight babies among postnatal mothers in central hospitals in Kannur district, a case control study. Objectives of the study. Identify the risk factors of low birth weight babies among postnatal mothers. Determine the strength of association between low birth weight and risk factors among postnatal mothers. Assumptions. Various socio-personal, maternal and obstetric variables influence the growth and development of the growing fetus. Low birth weight is a major cause of infant morbidity and mortality. Hypothesis. The following hypothesis formulated for the study and were tested at 0.05 level of significance. H1. There is a significant association between low birth weight and socio-personal variables. H2. There is a significant association between low birth weight and obstetric variables. H3. There is a significant association between low birth weight and clinical variables. H4. There is a significant association between low birth weight and practice during pregnancy. H5. There is a significant association between low birth weight and obstetric history. H6. There is a significant association between low birth weight and factors complicating pregnancy. H7. There is a significant association between low birth weight and medical history. H8. There is a significant association between low birth weight and surgical history. Conceptual framework is by Knowledge Pender's health promotion model. Review of literature consists of 4 sessions. Prevalence and risk factors of low birth weight babies, care of low birth weight babies, outcomes of low birth weight babies, and prevention of low birth weight babies. Regarding the methodology, research approach, a quantitative non-experimental research approach, research design, analytical observational study with an unmatched case control design. Variables, socio-personal, obstetric, clinical variables, practice during pregnancy, obstetric history, factors complicating pregnancy, medical and surgical history. Setting up the study, the postnatal wards of hospitals in Kannur district, that is Government Medical College Hospital Kannur, Cooperative Hospital Payyanur, E.K. Nayar Memorial Government Women and Child Hospital Mangatapparamba.
Population include postnatal mothers, sample 310 mothers, that is 155 cases and 155 controls. Sampling technique is consecutive sampling technique. Tools and methods of data collection, interview schedule, rating scale, and checklist. Content validity. To ensure the validity of the tool was submitted to 7 experts in the Department of OBG and Obstetricians. The suggestions from the experts are incorporated into the tool and the tool was modified. Pre-testing of the tool. That pre-testing is validated tool was done in 2 samples to identify the clarity of items, feasibility, ambiguity, and the time required to answer the questionnaire. Pilot studies conducted among 32 postnatal mothers at Government Medical College Hospital, Kannur. Analysis and interpretations. It consists of 4 sessions: socio-personal, obstetric, and clinical variables, distribution of risk factors of low birth weight babies, hypothesis testing, strength of association between low birth weight and risk factors. Regarding the distribution of socio-personal variables, majority of the sample belongs to 18 to 35 years in both groups, and majority of the samples were Hindus, and among cases, 82% of belongs to rural area, and among controls, 78% belongs to urban area. Then regarding the clinical variables, in that 56.8% had height less than 150 centimeter, that is among cases, and 61.6% had weight is less than 50 kg. Then distribution of postnatal mothers based on practice during pregnancy among cases. In that, majority of the samples, they are not taken adequate rest and sleep during pregnancy, not perform daily exercises, and had strenuous physical activities during pregnancy, and they are not taken adequate diet including fruits and vegetables, and they are taken eat processed or junk foods, and they are on treatment or any other medications. Then distribution of mothers based upon the obstetric history. In that, among cases, 25.6% had a previous history of low birth weight baby, 24.8% had a family history of low birth weight baby, and they are taken treatment for infertility, spontaneous abortion, induced abortion, IUD, and birth spacing less than 2 years. The next is the factors complicating pregnancy. In that, among cases, most of the sample have history of UTI, gestational hypertension, gestational GDM, anemia, placenta previa, cervical incompetence, polyhydramnios, and IUGR. Then regarding the medical history, 8.8% had history of hypothyroidism and 15.2% had history of asthma among case group. Then regarding the surgical history, only 8% had undergone previous LSES. Then next session is hypothesis testing. In that H10, there is no significant association between low birth weight and socio-personal variables. H1, there is a significant association between low birth weight and socio-personal variables. In that, the factors such as religion, residence, educational status, economic status, crowding index, and travel during pregnancy were associated with the low birth weight. The next is H20. There is no significant association between low birth weight and obstetric variables. H2, there is a significant association between low birth weight and obstetric variables. In that, history of consanguineous marriage, gravida, number of living children, regular, they are not taking adequate iron, folic acid, and calcium tablets. Then complications during current pregnancy and mode of delivery were found to be risk factors for low birth weight baby. Then H30, there is no significant association between low birth weight and clinical variables. H3, there is a significant association between low birth weight and clinical variables. In that, height, weight, and BMI were found to be risk factors for low birth weight. H40, there is no significant association between low birth weight and practice during pregnancy. H4, there is a significant association between low birth weight and practice during pregnancy. Then H50, there is no significant association between low birth weight and obstetric history. H5, there is a significant association between low birth weight and obstetric history. And H60, there is no significant association between low birth weight and factors complicating pregnancy. H6, there is a significant association between low birth weight and factors complicating pregnancy. In that, history of UTI, hypertension, GDM, anemia, placenta previa, cervical incompetence, polyhydramnios, and IUGR were found to be risk factors for low birth weight. H70, there is no significant association between low birth weight and medical history. H7, there is a significant association between low birth weight and medical history. In that, hypothyroidism and asthma is found to be risk factors for low birth weight. H80, there is no significant association between low birth weight and surgical history. H8, there is a significant association between low birth weight and surgical history. There is no significant association between low birth weight and surgical history. Then section 4 is the strength of association between low birth weight and factors. These are the odds ratio values. And in the present study, the following factors are found to be risk factors for low birth weight. That is
inadequate rest and sleep during pregnancy, strenuous physical activities, eat processed or junk foods, medication or treatment taken, then passive smoking, exposure to environmental pollutants, screen time more than 2 hours per day, UTI, anemia, GDM, placenta previa, cervical incompetence, polyhydramnios, IUGR, hypothyroidism were strongly associated with the low birth weight. Then discussion, summary and conclusion. In that, the present study is in congruent with the case control study to assess the factors associated with the low birth weight babies conducted in Eastern Nepal. In that, low birth weight babies who were educated up to SSC or more. Then these are the identified risk factors for low birth weight babies. Then nursing implications in nursing practice, nursing education, administration, and nursing research. The limitations are data collection period was extended, sample size was reduced from 310 to 250, and data collection period was exceeds more than 30 minutes. These are my references. Thank you. Crowding index means total number of living rooms divided by total number of co-residents in a family. How much it is crowded. Controls, that is the mother who given birth to a live term newborn baby with more than 2.5 kg. Yes. Nursing implications in nursing practice, the nurses should have an adequate knowledge regarding the risk factors of low birth weight and how to prevent it and how to take care of a low birth weight baby. And regarding the nursing education, the nurse educators are provided guidance and provide encouragement for the nursing students to care for a low birth weight baby. And regarding the nursing administration, the administrators are also provided guidance for the nurse educators and staff nurses to how to take care of the low birth weight babies. Risk factors, that is, I referred several research previous literature, and from that I am selected the factors. Yes. Thank you.
Thank you, Ms. Surya, for the presentation. Next, I invite Ms. Swati Vishwanathan for presenting the study.
Stop.
So first to have the workstation completed, then we can do the second round. So all R21 can assemble workstation 1, R22 in workstation 2, R23 in station 3, R24 in station 4, and last station R25. Delegates, please assemble the corresponding stations. Others, please be seated.
Good evening, everybody. Myself Swati Vishwanathan, Assistant Professor, Department of Microbiology, MIMS College of Allied Health Sciences. My topic is Outbreak of Elisabethinia meningoseptica in a quaternary care hospital, North Kerala, India. Identification of its source and control measures. There occurred an outbreak of Elisabethinia meningoseptica in the NICU of ASTER MIMS, Calicut. Elisabethinia meningoseptica is a gram-negative bacteria which was first reported by Elizabeth Oakley. So the objectives of my studies are to isolate this organism from the clinical specimen, to identify the source of the outbreak, to identify the control measures, and finally to identify whether the control measures is proper or not. So coming to the habitat of the organism, it is a pathogen which is found in hospital patients. It is widely distributed in nature and it is found mainly in hospital wash basins. Infections associated with that, it is mainly infective to immunocompromised individuals, and also it causes neonatal meningitis, and the major issue is it is a multi-drug organism. Coming to the materials and method of study, first one, the materials carried out for the identification of the organism from the clinical specimen, that is, different clinical specimens like blood, respiratory samples, CSF, etc. were collected from the patients, and it was inoculated onto McConkie agar and blood agar. And further colony was identified by White-2 system. Coming to the second method carried out for the tracing of the source of outbreak, different samples from the infective areas was collected, that is swabs from wash basin, from the hands of medical staffs, patient care equipments, and different water samples were collected, and it was inoculated onto McConkie agar and R2A agar. So, and the final method which was employed is method carried out for destroying this organism. For that, the organism was treated with chemical method, UV method, heat treatment. That is in clinical method. The chemical method, the organism was treated with different chemicals like chlorine, fluoxetine, etc. In case of UV treatment, the organism was exposed to UV radiations for different time period, and finally in heat treatment, the organism was treated in different temperature for different time period. Coming to the results of the study, a total of 17 cases of Elisabethinia meningoseptica was reported from our hospital NICU, and out of that, 14 was from NICU and rest 3 was from MICU. The isolates were mainly from blood, respiratory samples, etc. To identify the source of the outbreak, different environmental samples were collected, and the organism was only isolated from the tap water. Hence, we concluded that this organism is from water. So to know the exact reason of the outbreak, different water samples was collected, that is water samples from the overhead water tank of the hospital, the water samples from the external source, and the water samples from the tap was collected, and it was cultured. And the only area from which we isolated is from tap water. Hence, we concluded that the overhead water tank was devoid of the organism and the tap water is present is containing the organism. We concluded that some colonization has occurred inside the pipeline. Hence, biofilm formation is found in the pipeline. Hence, next step was carried out was the steps to destroy the organism. For that, the organism was treated with different temperature and in different UV radiations. The organism was killed when kept at 55 degrees Celsius for 10 minutes, and it was killed when treated with UV radiation. And also we identified that chemical method have no role in controlling this organism. So the first picture shows that the persistence of colony when kept at 44 degrees Celsius, and the second picture shows the complete clearance of the colony when kept at 55 degrees Celsius. The first image shows the persistence of the colony when exposed to 5 minutes in UV radiation, and second one, complete clearance of colony is seen when exposed to UV radiation for 10 minutes. Hence, these two criteria was employed in controlling the outbreak. The corrections which were employed in NICU include the pipeline to NICU and the taps were changed with UV filter fixed inside. Hot water was supplied in the pipelines. The old split roof ceiling was changed with free ceiling, and NICU was painted and well polished. While checking the antibiotic patterns, we observed that the strains which we isolated in our ICU is a multi-drug resistant organism, and also it is resistant to colistin. So the remedial measures taken was the importance of hand hygiene between the contact with different babies were re-emphasized. Suction containers and tubes were changed and disinfected more regularly, at least once daily. The culture samples taken after renovation show negative results, and also no case of Elisabethinia meningoseptica was reported in our ICU till date. in NICU. And also in last years, in 2001, we had few cases in our pediatric ICU, and the same remedial measures was implemented in the pediatric ICU. So we concluded that the remedial measures which we employed is in the exact manner. Coming to the discussion, similar outbreak was reported by Brody et al. They suggest that it affects the premature infants. In our study also, it was like that. Study conducted by D. Petema isolated the samples from the blood. In our study also, respiratory samples and blood samples was employed. Chiu et al. Reported that 15 immune compromised patients from Taiwan in clinical isolate, this organism was isolated and it was a multi-drug organism. Coming to the conclusion of the study, Elisabethinia meningoseptica is found in hospital environment. It has been associated with nosocomial infection related to contaminated medical devices. It mainly affects immunocompromised individuals. It causes meningitis in neonates. Its unusual resistance pattern coupled with inherited resistance with colistin makes this organism difficult to diagnose and treat. Isolation of this organism in water has significant finding that they have been reported in surviving in chlorination water. It can cause biofilm in pipelines. Disinfecting the sinks using hot water for hand washing in critical care areas may help in preventing this organism. Bacteremia and pneumonia are the common manifestations shown by the neonates. Infections usually affect premature infants and often occur as an outbreak. Prematurity is the primary risk factors in Elisabethinia meningoseptica infection. Proper identification of this organism and control measures have a great medical importance. Active infection control measures like regularly inspecting the hospital water tanks, water surveillances, and supply of hot water might require in controlling these challenging organisms. These are some of my references. Thank you.
Recently, standard guidelines globally accepted.
Yeah, standard guidelines means isolation of the organism from the clinical sample is by routine microbiological analysis, that is sample collection from the patients, mainly from neonates in our ICU and ICU, and it was cultured onto Mekonghi and blood agar, routine culture. Since it is a non-fermenting organism, the identification was done by Viter II compact system. So actually we did the correction method. Correction method was the main area where we employed. And since we had a last case in PICU, that is pediatric ICU, similar case was reported. And the same correction method was employed in that ICU also. So we proved that the correction method which is implemented in NICU is completely acceptable. So we suggest that these methods should be employed in all ICUs where immunocompromised patients are inhabiting, maybe in pediatric ICU, NICU, or in transplantation. The hot water should be supplied to pipeline with UV filter fixed inside. So in our hospital, this settings is followed.
So correction method you have from business or
no, we department did by research.
So you can summarize.
Yeah. So the main risk is that usually we did chlorination for destroying all the organisms. So this organism is overcome that chlorination. So no chemical is acceptable in this organism. So hot water and UV filter is the only remedial measures, so that every hospital should implement this method to, as a remedial measures. Different strategies was employed. Chemicals routinely destroying different strategies was employed. That's chemical methods. We treated this organism with different chemicals like fluorine, chlorhexidine. We came to know that no actions for that. Followed by the UV radiation. UV radiation was effective even 10 minutes. And also we treated this organism in different temperatures, from lower temperature to higher temperature. So the cutoff we observed is at 56 degrees Celsius. So that minimum temperature in which the organism is dead is employed in the ice.
Have you realized any side effects or because this correction method is really difficult with some microorganisms?
Yeah.
So not about whether it will harm.
No, sir. The remedial measures is simply treating with hot water. The pipeline was supplied with hot water, no harmful effect, and also the water tank is fitted with UV filter. So no harmful method is employed in that. If it is a chemical method, we might be thinking of it, but since chemical is not effective, we don't bother in that case. Thank you, sir.
Thank you, Ms. Swati. Next item, this is Ms. Focus.
Good afternoon to all. Myself, Rinjana, lecturer, MIMS College of Nursing. My research title is Effectiveness of Flipped Class Method on Learning Outcome of fourth year BSc Nursing students for selected topics of obstetric and gynecological nursing. The research guided by Professor Isha, MIMS College of Nursing. Introduction. Teaching is regarded as both art or science. As an art, it lays stress on imaginative and artistic ability of the teacher in creating a worthwhile situation in the classroom to enable students to learn. As a science, it sheds light on the logical, mechanical, or procedural steps to follow to attain an effective achievement of goals. Differential educationists hold different ideas regarding the concept of teaching. Then, need and significance of the study. Health professional education is expected to produce graduates who are proficient in core competencies and have the ability to provide safe, high quality, and patient-centered care. However, many employers find that recent nursing graduates are not competent enough at performing basic clinical tasks. Thus, new approaches and educational models must be developed to allow nurses to respond rapidly to change in the medical field. New innovation teaching strategies are critical to integrate into nursing education. Then the objectives of the study. First one, assess the level of knowledge of students on selected topic of obstetric and gynecological nursing before and after the introduction of flipped class method. Second one, determine the effectiveness of flipped class method on learning outcome of fourth year BSc nursing students. Then third one, find out the association between the level of knowledge and selected socio-demographic variables. Then the hypothesis. Hypothesis 1, there will be a significant difference in the pre and post intervention level of knowledge of experimental group. Hypothesis 2, there will be a significant difference in the level of knowledge of experimental and control group after the intervention. Hypothesis 3, there will be a significant association between the level of knowledge and selected socio-demographical variable. This is the conceptual framework based on the Ludwig von general system theory. Then the review of literature. The review of related literature for the present study is organized under the following heading. Literature related to the effectiveness of flipped class in non-medical education. Then the literature related to effectiveness of flipped class in medical education. Then move to the methodology. Quantitative quotient experiment research approach is used. Then non-randomized pre-test post-test control group design is used. This is the schematic design of the study. Then move to the schematic representation of the study. The setting of the study include National Hospital College of Nursing and Red Crescent College of Nursing, Kozhikode. The populations are fourth year BSc nursing students and samples are who meet inclusion criteria, and the sample size is 100, and the sample technique is purposive sample techniques, and the variables, independent variables are flipped class method, and dependent variables are level of knowledge on selected topics of from obstetric and gynecological nursing. Then the tools, there are two tools are used. First one is the socio-demographical proforma, and second one is the structured knowledge questionnaire, and data are collected. Then first applied pre-test. The same two tools are applied. Then applied intervention, flipped class method applied to the experimental group. Then conduct post-test. The same structured knowledge questionnaire is applied. Then analysis done by descriptive and inferential statistics. Let's move to the methodology. In this calculation is used by substituting the values in the formula. The calculated sample was 97.502 and rounded as 100. The sample criteria, inclusion criteria includes students who are willing to participate in the study. Then the exclusion criteria includes students who are not present on the day of data collection. Then description of the tool. Tool 1, socio-demographical proforma. That includes 7 items. Then tool 2, structured knowledge questionnaire. The content validity index of the tool 2 is 0.937 and the reliability of the tool 2 is 0.774. Then the data collection process. The sample meeting inclusion criteria are selected. Then take informed consent. Then that pretest on first day. Then provide intervention flipped class method on experimental group and conduct post-test on after 2 weeks. This is the result. First section, sample characteristics. That will be in age, 52% of experimental group and control group belongs to 21 years. Then in gender, 96% of experimental group and 86% of control group belongs to female. Then in religion, 58% of experiment group belongs to Hindu religion and 40% of control group belongs to Christian religion. In marital status, 100% of experiment group and 96% of control group are single. Then in type of family, 18% of experiment group and 88% of control group belongs to nuclear family. Then the place of residence, 50% of students in experimental group stay in college hostel and 46% of control group students stay in own house. Then monthly income, 34% of experimental group and 36% of control group have monthly family income of rupees less than 10,000. Then section 2, assessment of pre-test and post-test level of knowledge of fourth year BSc nursing students on selected topic of obstetric and gynecological nursing. In that, the figure explains a distribution of sample based on the level of knowledge before and after the interventions. In 54% of experiment group and control group have had average level of knowledge, and 46% of experiment group and control group had poor knowledge before intervention. Then after intervention, 100% of experiment group have had good level of knowledge, and after intervention, 96% of control group student had average level of knowledge, and only 4% of student had poor knowledge. Then section 3, effectiveness of flip class method on level of knowledge of fourth year basic nursing students on selected topic of obstetric and gynecological nursing. In first one, to identify significance difference in mean pre-test and post-test score of level of knowledge of fourth year basic nursing students in experimental group for selected topics of obstetric and gynecological nursing. In that, p-value is 18.97 and the p-value is 0.00. So there is a significant difference in the mean pre-test and post-test score of experimental group after receiving the intervention. So null hypothesis rejected and research hypothesis accepted. Then it has the significance of difference in the mean post-test score of level of knowledge on selected topics from obstetric and gynecological nursing between experimental and control group. There is p-value is 31.24 and the p-value is 0.00. Hence, there is significant difference in the mean post-test score of level of knowledge of experimental and control group regarding the selected topic of obstetric and gynecological nursing. So the null hypothesis rejected and research hypothesis accepted. Next, section 3, association between the level of knowledge on selected topic of obstetrical and gynecological nursing and selected socio-demographical variable of fourth year BS nursing students. In that the table shows that there is no significant association between knowledge level of nursing students with the demographical variable. So null hypothesis accepted. Then move to the discussion. The discussion is organized under the following section: sample characteristics and effectiveness of flip class method. There is a similar findings, another study to conduct to compare the effect of traditional lecture and flip class on nursing students, critical thinking deposition among 85 students in Iran, which showed that most of the students were female, 83.5%, and most of the students are single, 19.6%. Then move to the nursing implication. In nursing practice, nursing profession require lifelong learning. Nurse can utilize flip class method, update their knowledge with less interference with the patient care activities. Then nursing education, nurse instructor can be used flip class method for teaching nursing subjects. Then nurse administration can arrange educational program for nurses by using flip class method. Then nursing research, evidence-based practice, and body of knowledge for future nursing research. Then move to the discussion. Limitation of study include the study was confined only for few settings. Then study was limited to fourth year BS nursing students. The study was conducted only a short duration of period of time. Then recommendation includes similar study can be replicated on a large sample and in other settings. Then also similar study can be conducted by using true experimental design. Then comparative study can be conducted between flip class method and traditional teaching. In conclusion, the study revealed that flip class method enhanced the learning outcome of students and effective in teaching nursing subjects. These are the reference. Thank you.
We have studied, practice study the
MIMS College of Nursing, National Hospital College of Nursing, and Red Crescent College of Nursing, and it is settings.
very different between students. Maybe is there any difference in their learning style?
National Hospital College of Nursing students are considered as an experimental group, and Red Crescent College of Nursing students considered as a control group. But in pre-test, the score are similar. The 54% of the experiment group and control group have average knowledge, and 46% of students in experiment group and control group also have poor knowledge. After the intervention, the experiment group, 100% of the students have had good knowledge, and in control group only 96% of the students had average knowledge and 6% had poor knowledge. Flip class room is a new methodology, new method of teaching, in which firstly a prepared short video, 20 minutes video sent to the students. They can see and study in home. Then after 3 days, they conducted discussion and presentation in classroom. How to? In structured knowledge questionnaire, the maximum score is 30 and minimum score is 0. Then categorized into 0 to 9 is the poor knowledge, and 10 to 20 is the average knowledge, and 21 to 30 is the good knowledge. Yes, ma'am. No, ma'am, prepare by myself. Thank you, sir. Next
Good afternoon, everyone. Our research study was conducted by Ms. Govika Krishna, Harsha C, and myself, Nidisha Shaji, under the guidance of Mrs. Reba Mary Abraham. Problem statement is study to assess the knowledge regarding shaken baby syndrome among caregivers of children under 2 years of age in selected hospital Connecticut with a view to develop pamphlet. Introduction. Abusive head trauma is a head or neck injury from physical child abuse. Another term for this condition is shaken baby syndrome. Abusive head trauma typically involves injury to the intracranial contents or skull of an infant or child younger than 5 years old as a result of violent shaking or blood impact. The outcome ranges from complete recovery to significant brain damage and death. Educating caregivers will be beneficial in decreasing rate of this condition. Objectives: to assess the knowledge regarding shaken baby syndrome among caregivers of children under 2 years of age, to find out association between knowledge regarding shaken baby syndrome among caregivers of children under 2 years of age with the selected demographic variable, to develop a pamphlet regarding shaken baby syndrome. Operational definitions: knowledge. It refers to correct responses of caregivers to the items on shaken baby syndrome, measured by structured knowledge questionnaire and expressed in terms of knowledge score. Shaken baby syndrome. It refers to a non-intentional injury caused by vigorously shaking an infant, often in hunger, to get a child to stop crying or weaning of infant. Caregivers of children. It refers to father, mother, or who looked after the children under age of 2. Hypothesis: there is a significant association between knowledge regarding shaken baby syndrome and demographic variables. Literature review. Author: Mrs. Ursula McIntyre, Kinga Taylor, Monica Panisek, Martina Ledwin. Sample: parents, medical staff, and medical students in the Medical University of Silesia, Poland. Result: the result shows that according to 90% of interviews, shaking a baby may be dangerous, but 43% have never heard about SBS. 88% of respondents stated that SBS is a form of violence. 60% medical staff members did not know how long it takes for the consequence of shaken baby syndrome to be revealed. Methodology: research approach, quantitative research approach, research design, non-experimental descriptive design, population caregivers of children under 2 years of age, sample size 60, sample technique, purposes, sampling technique. Criteria: inclusion criteria: caregivers who are able to read Malayalam, caregivers who are willing to participate in this study, both males and females. Exclusion criteria: caregivers who are not present during the time of data collection, caregivers below the age of 18 years. Conceptual framework based on the knowledge of India's health promotion model. Description of the tool. Tool 1, self-defined demographic questionnaire for obtaining socio-demographic data of caregivers. Consists of age, religion, education, type of family, occupation, place of residence, monthly income, relationship with the child, age of the child. Description of the tool. Tool 2, self-designed knowledge questionnaire to assess the knowledge regarding shaken baby syndrome among caregivers of children under 2 years of age. Data collection process. First, IC clearance and administrative permission obtained. Sample meeting inclusion criteria selected. Inform the consent is obtained from caregivers of children under 2 years of age. Administration of tool 1 and 2. Provide information pamphlet regarding shaken baby syndrome. Result: 71.6% were in the age group of 18 to 29 years. 38.3% of caregivers was Muslims. 51.6% were belongs to other education status majority. 53.3% of caregivers were belong to nuclear family. 56.6% of caregivers were homemakers. 40% are residing at urban area. 33.3% are from rural area. 40% of caregivers have monthly income between 20,000 to 30,000 rupees. Majority 71.6% of the caregivers were mothers. 46.6% of the children belongs to the age group between 0.6 months. Result: the first objective of the study was to assess knowledge regarding shaken baby syndrome among caregivers of children 2 years of age. This was identified by using 15 knowledge questions. Analysis of the data revealed that around 60% of the caregivers had average knowledge on shaken baby syndrome. 38.3% had poor knowledge. Remaining 1.66% had good knowledge. The second objective of the study was to find out association between knowledge regarding shaken baby syndrome with selected demographic variable. Analysis revealed that there was a significant association between knowledge regarding shaken baby syndrome with selected demographic variable such as education status and monthly income. Hence, the hypothesis H1 is accepted 5% level of significance. Discussion. Present study. The present study shows that 60% of the caregivers of children under 2 years of age had average knowledge on shaken baby syndrome, and 38.3% had poor knowledge, and the remaining 1.66% had good knowledge. The analysis revealed that there is a significant association between knowledge regarding shaken baby syndrome with the selected demographic variables such as education status and monthly income. Hence, the hypothesis H1 is accepted 5% level of significance. Supporting study. The study is to assess the knowledge on shaken baby syndrome among caregivers of the children, young child in MCH Center, Tirupati. The study result shows that 45% of caregivers had inadequate knowledge regarding shaken baby syndrome, 26% had moderate knowledge, and 29% had adequate knowledge. Limitations. Generalization of the finding is limited to a small sample size. The study was confined only to a single setting. Recommendation. Similar study can be conducted on large sample, thereby finding can be generalized. Similar study can be conducted by using quasi-experiment research design. Nursing implication. Nursing practice. The health education is the best method to improve the knowledge of caregivers regarding SPS. Nursing administration, health education program can be planned by the administration for the caregivers of children under 2 years of age. Nursing educator can plan and organize staff development program for nurses working in the pediatric department by concentrating nurses' role in providing health education regarding SPS. Nursing research and extensive research need to be conducted to assess knowledge regarding shaken baby syndrome. Nurses should take initiative in collaborating multi-center research in these areas. Conclusion. The conclusion drawn from the study is that most of the caregivers had average knowledge regarding shaken baby syndrome. There is a significant association between knowledge regarding shaken baby syndrome with the selected demographic variables such as education status and monthly income. Hence, the hypothesis H1 was accepted at 5% level of significance. So, the caregivers need a health education regarding shaken baby syndrome that enhances their knowledge and helps to decrease the incidence of SBS. Reference. Thank you. By using purposive sampling technique.
What is the name of sampling purposes and
Purposive sampling based on the purpose is selected. Based on the purpose of the research is selected.
Thank you, Dr. Nisha. Next, I invite Ms.
Good afternoon to one and all present here. Myself, Sneha Vinny, and my co-research mates are Ms. Varsha P. and Ria Vijay, and we conducted a study under the guidance of Ms. Anagha, Senior Lecturer, Department of Obstetrics and Gynecology. Title of the study: a study to assess the renal dietary and fluid adherence among patients undergoing hemodialysis with a view to develop an informational pamphlet. Introduction: chronic renal failure is typically caused by certain medical conditions including diabetes, high BP, and long-term inflammation of the kidney. CRF requires careful lifelong management and can progress to end-stage kidney disease, which requires dialysis and transplant. Patients with CRF needs to modify their lifestyle, chiefly focusing on diet and fluid intake, as the prognosis of these patients largely depends on adherence to the recommended nutritional regimen. Non-adherence to the suggested diet and fluid regimen leads to rapid worsening of the condition. Objectives: first objective, assess the renal dietary and fluid adherence among patients undergoing hemodialysis. Second objective, find out the association between the renal dietary and fluid adherence with selected demographic variables. Third objective, develop an informational pamphlet on renal dietary and fluid adherence among patients undergoing hemodialysis. Hypothesis: H1, there is a significant association between the renal dietary and fluid adherence with selected demographic variables among patients undergoing hemodialysis. H0, there is no significant association between the renal dietary and fluid adherence among patients undergoing hemodialysis with selected demographic variables. Review of literature. We separated two sections. First is literature related to prevalence of chronic renal failure. Under that, we selected Borov KK, conducted a cross-section study to assess awareness, prevalence, and risk factors for CKD among hypertensive and diabetic patients on regular follow-up by using knowledge questionnaire. The results showed that low level of patient awareness of both chronic kidney disease and its risk factors among patients with both hypertension and diabetes mellitus. Second section is literature related to renal dietary adherence among patients undergoing hemodialysis. Uruhem et al. Conducted a study to assess whether skipping hemodialysis treatment and failure to adhere in dietary prescription injure patients on hemodialysis. The findings showed that the patients who use illicit drugs or tobacco were at risk for skipping hemodialysis treatments. Markers of poor dietary adherence and skipping treatments were strongly associated with the risk of death. Methodology: research approach is quantitative research approach. Research design is non-experimental descriptive design. Variables are independent variable. Informational pamphlet containing information regarding renal dietary and fluid pattern. Dependent variable: renal dietary and fluid adherence. Settings of the study: hemodialysis unit of ASTER MIMS Hospital, Calicut. Sample sizes: 60 patients who are diagnosed with CRF and undergoing hemodialysis from ASTER MIMS Hospital, Calicut. Sampling technique is purposive sampling. Inclusion criteria: patients who are diagnosed with CRF and undergoing hemodialysis. Second, patients who are willing to participate in the study. Tools and techniques: Part 1, semi-structured questionnaire on clinical and socio-demographic proforma. Part 2, semi-structured questionnaire on knowledge of renal dietary and fluid adherence among patients undergoing hemodialysis. Pilot study was conducted at ASTER MIMS Hospital on 21/10/2021 using 6 samples, and responses were analyzed. Based on the responses of the subjects, the tool used in the study was clear and unambiguous, and the study was found to be feasible. Ethical clearance was obtained from Institutional Ethical Committee of MIMS College of Nursing, Pudukode. Permission was taken from ASTER MIMS Hospital, Calicut. Consent was taken from the participants. Results: Section 1, description of demographic characteristics. Among 60 subjects, 78.3% were in the age between 51 to 75 years, and others 13.3% were between 25 to 50 years, and only 8.4% were above 76 years. Most of the subjects, 61.6% were males and 38.4% are females. Most of the subjects, 70% were belongs to Hindu religion and others were belongs to Muslim and Christian religion. Majority of the subjects, 36.6% were having degree qualification. Among 60 subjects, 75% were belongs to APL and others belong to BPL. Most of the subjects, 95% were belongs to nuclear family and 5% belongs to joint family. Majority of the subjects, 88.3% were married, 8.3% were unmarried, and 3.4% were widowed. 20% of the subjects are having government job. 25% of subjects were homemakers. 3.3% of subjects were self-employed. Majority of the subjects, 59.4% were residing at area and for urban area, and 41.6% were residing at urban area, and others were rural area. Section distribution of hemodialysis patients according to their renal, dietary, and fluid adherence. Most of the samples, that is 70%, had average, and 30% of samples had good adherence to renal, dietary, and fluid pattern. Testing of the hypothesis: there is no significant association between renal, dietary, and fluid adherence among patients undergoing hemodialysis with selected demographic variables. Discussion of the study. Present study shows that the majority, that is 70% of the patients undergoing hemodialysis have average adherence towards their renal, dietary, and fluid pattern, and only 30% patients have good adherence. Supporting study: a study conducted in selected hospitals of Bangalore to assess the renal, dietary, and fluid adherence among patients undergoing hemodialysis. Research shows that overall 52% of people have good adherence, and 13% of them were having poor or fair adherence to dietary regimen and adherence to dietary constituents. The study has nursing implications on nursing practice, nursing education, nursing administration, and nursing education. Limitations of the study: the researcher met difficulty during the data collection, that is, the most of the samples were very sad to express their opinion due to chronic ill health. Conclusion: the conclusion drawn from the study is that majority of the patients undergoing hemodialysis have an average adherence towards their renal, dietary, and fluid pattern, and some of them have good adherence irrespective of their socio-demographic variables. The findings of the study shows that 70% of the patients having average and 30% of the patients having good adherence. These are the references of the study. Thank you. Yes, ma'am. After assessing the knowledge, we provided there with informational pamphlet containing information regarding the renal, dietary, and fluid pattern. 2 weeks. 2 weeks. Data collection in 2 weeks, and in between 1 month it is completed. 2 months completed. 2 months. Independent variables means which is not dependent, and dependent variables means which is dependent on the interventions that we provided, which is changed according to their intervention. Thank you, ma'am.
Thank you, Mr. Ayabani. Next, I invite Ms. Varshavi for presenting the paper. Audience, please be silent.
Good evening to all. Myself, Varsha, from 16th batch of BSc Nursing. My guide, Mrs. Sona Casey, Senior Lecturer, Department of Obstetrics and Gynecology. The title of study: Title of the study: a study to assess the knowledge and attitude on organ donation among people seeking healthcare at selected hospital, Calicut. About the introduction: organ donation and transplantation is the treatment of choice for end-stage organ disease, as it provides a better quality of life and long-term survival of the recipient. Every 6,000 patients expire while waiting for an organ donation. This is due to the scarcity of transplantation organ worldwide. One of the major issues contributing to the scarcity of organ is because of public attributes such as myths, religious misconceptions, and misunderstood degrees. Knowledge and attitude plays a significant role in rates of organ donation. Healthcare professionals need to take an active role in clarifying any myths and doubts of people regarding organ donation, which cannot be accomplished through electronic media alone. Next, about the objectives. First one, to identify the knowledge regarding organ donation among people seeking healthcare. The second one, to identify the attitude regarding organ donation among people seeking healthcare. The third one, to identify the relation between knowledge and attitude regarding organ donation among people seeking healthcare. The fourth one, find the association between knowledge regarding organ donation among people seeking healthcare and selected variables. The last objective, find the association between attitude regarding organ donation, people seeking healthcare, and selected variables. Next, about the hypothesis. The hypothesis 1, there is a significant correlation between knowledge and attitude regarding organ donation among people seeking healthcare. Hypothesis 2, there is a significant association between knowledge regarding organ donation among people seeking healthcare and selected variables. Hypothesis 3, there is a significant association between attitude regarding organ donation among people seeking healthcare and selected variables. About the literature review. Review of literature is one of the most important steps in the research process. It is an account of what is already known about a particular phenomenon. It not only provides a basis for further investigation, but also enables the investigator to greater understanding of the research problem and its major aspects. It also helps the investigator to evaluate different approaches to the problem. The literature review is described under the following categories. First one, prevalence of organ donation. Next, knowledge regarding organ donation. And the third, attitude regarding organ donation. Prevalence of organ donation. A community-based cross-sectional study was conducted from 2050 to 2060 to assess the level of knowledge and attitude regarding organ donation in general population of Karachi, Pakistan. The result shows that 25.8% of general population have inadequate knowledge regarding organ donation, and 43.8% of respondents were oblivious to the allowance of organ donation in their religion. Knowledge regarding organ donation. A community-based cross-sectional study was conducted on knowledge, attitude, and practice regarding organ donation among adult population of urban Puducherry, South India. The result shows that less than 1/3 of the studied population had adequate knowledge regarding organ donation, even though more than half of them had positive attitude towards organ donation. Only 6 individuals registered for organ donation. Attitude regarding organ donation. A cross-sectional study was conducted on attitude and awareness towards organ donation in population of Tertiary Healthcare Center, Ahmedabad, city of Gujarat, India. The results show that around 78 participants felt that they would donate organs to persons irrespective of their religion. About 81% of aware people were of the opinion that consent for organ donation after death should be by family members. None of the interviewed participants had a donor card. Next, about the methodology. Research design was descriptive research design. Settings of the study was MIMS Hospital, Calicut. Sampling technique was convenient sampling. Sample size 60% in MIMS Hospital. The population was patients seeking healthcare in ASTER MIMS Hospital, Calicut. The independent variable is knowledge, and demographic variable was age, gender, occupation, etc. The major findings of the study: 48% of people had average knowledge on organ donation. 43% of patients had good knowledge on organ donation. The mean score of knowledge regarding organ donation is 10.53. The chi-square value obtained between knowledge on organ donation and religion of patients seeking healthcare was 14.22. Other relevant findings of the study: 38.3% of people seeking healthcare belong to the age group of 31 to 43 years. 51.6% people seeking healthcare are males. More than half of the people seeking healthcare were belongs to Hindu religion. 35% of people seeking healthcare were educated up to high school level. Majority of people seeking healthcare were belongs to APL. More than half of the people seeking healthcare belong to nuclear family. Most of the people seeking healthcare are married. 36.6% of people seeking healthcare were homemakers. 73.3% of people seeking healthcare were lived in rural area. About the discussion implications, the first objective of the study was to identify the knowledge regarding organ donation among people seeking healthcare. The study results showed that 48% of patients had average knowledge and 43% of patients had good knowledge about organ donation. The second objective of the study was to recognize the attitude towards organ donation among people seeking healthcare. The present study revealed that 93.33% patients had positive attitude and none of them had negative attitude towards organ donation. Only 6.67% of patients had neutral attitude towards organ donation. The third objective of the study was to identify the relation between knowledge and attitude regarding organ donation among people seeking healthcare. The present study revealed that a small positive correlation between attitude scores and knowledge scores on organ donation among people seeking healthcare. The fourth and fifth objective of the study was to find the association between knowledge regarding organ donation among people seeking healthcare with selected demographic variables and to find the association between attitude regarding organ donation among people seeking healthcare with selected demographic variables respectively. A significant association was found between knowledge on organ donation and also found an association with the religion, but could not get any significant association between knowledge on organ donation and selected demographic variables like gender, educational status, socioeconomic status, type of family, marital status, occupation, and area of residence. About the limitation, the assessed data in the study has barrier that it was based on particular demographic group, that is people seeking healthcare in MIMS Calicut. About the conclusion, the researchers conducted a study to assess the knowledge and attitude on organ donation on patients seeking healthcare at MIMS Hospital, Calicut. Even though most of the patients had a positive attitude towards organ donation, their knowledge on the subjects remains primitive. Healthcare professionals are the primary source of knowledge to the particular demographic group. Hence, it is the essential that each healthcare professionals shall be well informed about the organ donation and its impact on the well-being of society. It is concluded that the demographic group selected for the particular study have a positive attitude towards the organ donation. The lack of knowledge on organ donation hang back them from the same. So, the reference. Thank you. Kidney. Thanks.
Thank you, Varsha. Next, we have two online data presentations.
No, please.
Ms. Alina for presenting the study through online mode.
Alina, online screen share ചെയ്യും. ഇത് നമ്മൾ ഷെയർ ചെയ്യണം.
Good afternoon.
ആ കുട്ടിയാണ് തുടങ്ങിയോ വീഡിയോ ഓൺ ചെയ്യുന്നതിന് മുന്നേ
Good afternoon, ma'am.
Good afternoon.
Myself, Alina. My co-researchers are Alfie Binny and Alisha Pool, and we were done the research study under the guidance of Ms. Ishayas, Professor of MIMS College of Nursing.
Alina, can you share your screen?
Yes, sir.
Now we can change the sessions.
Ma'am, would you please share the PPT, ma'am?
Okay, we will share it now.
അടുത്ത വിപിടി അങ്ങനെയാണ് ഞാൻ ചെയ്യാം എത്തിയോ അടുത്തതും അങ്ങനെയാ ഞാൻ അടുത്തത് അയച്ചു തരാം എന്തായിരുന്നു ഡീനോ DN ആ കിട്ടി കിട്ടി വന്നോ ഗ്രൂപ്പ് 2 എന്ന് പറഞ്ഞിട്ട് സാധനം എന്തായിരുന്നു അത് ഗ്രൂപ്പ് 2 ആണ് പ്രസന്റേഷൻ ഗ്രൂപ്പ് 2 അലീന എക്സാം കഴിഞ്ഞ ദിവസം തുടങ്ങാൻ പറയാം അല്ലേ
Ma'am, shall I start?
Such a presentation.
Yes, sir.
Okay, you can start.
Okay, sir. Myself, Alina, and I'm here to my research presentation. And we done the research study under the guidance of Ms. Ishayas, Professor of MIMS College of Nursing. And the statement of the problem is a study to assess the effectiveness of nurse-led pre-chemotherapy education intervention on knowledge and anxiety among patients undergoing chemotherapy in selected hospital Kozhikode. And next, the introduction. Cancer is a disease caused by an uncontrolled division of abnormal cells in a part of the body. There are different methods of treatment depending on organ type and stage of cancer and condition of patient. Chemotherapy is a kind of treatment that uses drugs to attack cancer cells. These drugs may rarely be intended to have a local effect. According to American Cancer Society, the most common side effects include nausea, vomiting, hair loss, fatigue, increased chance of bruising and bleeding, anemia, and infection. Next, the need and significance of the study. Cancer patients are having poor level of knowledge regarding their disease condition and treatment modalities. Patients require adequate knowledge regarding chemotherapy, its side effects and management. Well-informed patients are more satisfied with care, have a better sense of control of their situation and report quality of life. Decreased level of knowledge in patients will increase the anxiety and stress. It will worsen their condition. Oncology patients who experience less anxiety are better able to manage side effects of chemotherapy. Decreased anxiety can improve the psychological outcomes of patients toward chemotherapy treatment and can increase the quality of life. Investigators on experience in clinical sector revealed that there are many cancer patients who are overwhelmed with anxiety and have poor level of knowledge. In the view of the above mentioned information, the researchers felt the need to conduct a study on effectiveness of nurse-led pre-chemotherapy educational intervention on level of knowledge and level of anxiety in patients undergoing chemotherapy. Next is the objectives of the study. First objective, to assess the level of knowledge on chemotherapy among patients undergoing chemotherapy before and after the intervention. Second one, to assess the level of anxiety regarding chemotherapy among patients undergoing chemotherapy before and after the intervention. Third one, determine the effectiveness of nurse-led pre-chemotherapy educational intervention on level of knowledge of patients scheduled for chemotherapy. Fourth one is to determine the effectiveness of nurse-led pre-chemotherapy educational intervention on level of anxiety of patients undergoing chemotherapy. And fifth one, find out the relationship between the level of knowledge and level of anxiety among patients undergoing chemotherapy. Sixth one, find out the association between the level of knowledge and selected demographic and clinical variables. Hypothesis H1, there will be a significant difference in the level of knowledge of patients undergoing chemotherapy before and after the pre-chemotherapy educational intervention. H2, there will be a significant difference in the level of anxiety of patients scheduled for chemotherapy before and after the pre-chemotherapy educational intervention. H3, there will be a significant correlation between the level of knowledge and level of anxiety of patients scheduled for chemotherapy. H4, there will be a significant association between the level of knowledge and selected demographic and clinical variables of patients undergoing chemotherapy. H5, there will be a significant association between the level of anxiety and selected demographic and clinical variables of patients scheduled for chemotherapy. Next, the conceptual framework used for the study is it was based on Imogen King's goal attainment theory, and King used a system approach in the development of her dynamic interacting system framework and in her subsequent goal attainment theory. And this was the conceptual framework. And next, the review of literature. The review of literature is grouped under the following: literature related to assessment of level of knowledge of cancer patients on chemotherapy, literature related to assessment of level of anxiety of cancer patients on chemotherapy, literature related to the effectiveness of educational intervention on level of knowledge of cancer on chemotherapy, and last, the literature related to the effectiveness of educational intervention on level of anxiety on cancer patients on chemotherapy. Next, the methodology used for the study includes The research approach is quantitative research approach, and research design is quasi-experimental research design with one group Peters Foster's design, and the population was patients undergoing chemotherapy. The sample, the patients undergoing chemotherapy for the first time and attending the oncology hospital. Sampling technique was convenient sampling technique, and the sample size was 30. Next, it is the criteria for sample selection. Sir, can you please change the slide? Criteria for sample selection. The inclusion criteria include patients who are going to receive chemotherapy for the first time and who are within the age group of 20 to 70 years and who are willing to participate in the study and who are able to follow the instructions. And the patients who have a cognitive impairment were excluded from the criteria. And next, it was a description of the tool. There were 4 tools: tool 1, social personal clinical performer, and tool 2, hospital education scale, tool 3, self-structure knowledge questionnaire, and tool 4, self-instructional booklet. And this was a schematic representation of the study. And the data collection process include, next slide. After getting approval from the ISA, permission was obtained from the oncology department of ASTER MIMS Hospital, Kozhikode. After explaining the purpose of the study, informed consent was taken from the subjects. The data was collected by using the above mentioned tools. Pre-chemotherapy educational intervention based on self-instructional booklet was given to the group, and posters was conducted 2 weeks after the educational intervention, and the data were collected, organized, and tabulated for the analysis. And the results include, first, regarding the socio-demographic variable, out of the 30 sample, 50% belong to the age of 60 to 69 years, and 23.3% belong to the age of 50 to 59 years. And regarding the educational status, 36.6% of the sample has secondary education, and 23.3% has primary and high secondary education. Then regarding the religion, among the sample, 80% are and 13.3% are Muslims, and 6.6% are Christians. Then regarding the marital status, 86.6% of the subjects are married, 10% of the subjects are unmarried, and 3.3% are widows. Next, to the type of the family, most of the people belongs to the nuclear family. Next, it was a place of residence. 50% of the samples are from rural area, and 43.3% are from the urban area. And next, the monthly income. 20% of the sample has monthly income less than 5,000, between rupees 5,000 to 10,000, and between rupees 50,000 to 20,000, and above rupees 25,000 respectively. And then the clinical variables. 20% of the sample has stage 1 cancer, and 26.6% of the sample has stage 2 and 4 cancer respectively. Next, the duration of the disease. 66.6% have a disease duration of say 5 to 6 months. Next, it was comorbidities. 53.3% have no comorbidities. Next, regarding the level of knowledge among patients undergoing chemotherapy, 70% of the sample has average knowledge, 20% of them had poor level of knowledge, and 10% have good level of knowledge before the intervention, and 56.6% has average, and 43.3% has good level of knowledge after the intervention. Then regarding the level of anxiety of patients undergoing chemotherapy, 66.6% of the sample have moderate level of anxiety, 20% of them have severe level of anxiety, and 13.3% have mild level of anxiety before the intervention. And after the intervention, 53.3% have moderate, and 46.6% of the sample have mild level of anxiety after the intervention. Next, regarding the effectiveness of nurse-led pre-chemotherapy educational intervention on level of knowledge on patients undergoing chemotherapy. There is a significant difference in the level of knowledge of patients scheduled for chemotherapy before and after the pre-chemotherapy education. Next, regarding the effectiveness of nurse-led pre-chemotherapy educational intervention on level of anxiety of patients undergoing. Next, it is the relationship. There is moderately positive correlation between the level of knowledge and level of anxiety of patients undergoing chemotherapy. Next is the association between the level of knowledge and level of anxiety. There was no significant association between the level of knowledge and level of anxiety between the selected demographic variables and clinical variables. Next, regarding the discussion, the discussion was done under the following headings: level of knowledge of chemotherapy among patients undergoing chemotherapy before and after the intervention, level of anxiety regarding chemotherapy among patients, and effectiveness of nurse-led pre-chemotherapy intervention on level of knowledge and level of anxiety. Next, regarding the nursing implications, in nursing practice, it was helpful for the practical nurses in assessing the knowledge and managing anxiety of patients with types of cancers scheduled for chemotherapy. And in nursing educators, it is helps nurse educators utilize the findings of the while teaching students regarding the problem of cancer patients scheduled for chemotherapy. And in nursing administration, the present study can be influential for nurse managers to plan educational programs for nurses working in oncology wards on patient education to improve their knowledge and decrease the anxiety of cancer patients. And in nursing research, the study contributes to the body of knowledge for future researchers, and it motivates other investigators to conduct a further study. And the limitations of the study include generalization of the study is limited to small sample size. Devisation was not done to non-available samples and selected only one hospital for the study, and the duration of the study was less. And regarding the conclusion, nurses are often the first members of the healthcare team to be in contact with the patient. The nurses have a great role in assessing the knowledge and managing the anxiety of the patients. The study reveals that the nurse-led pre-chemotherapy education intervention was an effective method for the patients scheduled for chemotherapy, which improved the knowledge and decreased the level of anxiety. These are some of the references used in the study, and thank you.
Yeah, how did you assess the anxiety?
Anxiety was assessed by using a standard tool, HARDS, Hospital Anxiety and Depression Scale. Okay, thank you.
Next, I invite Professor Jaya to the paper presentation through online mode.
Ma'am, good evening.
Good evening. Sharing.
We are sharing the PPT, ma'am. Please wait.
Okay, ma'am. Am I audible to everyone?
Yes, ma'am, you are audible. You can start.
Okay. A very warm good evening to everyone who gather here. Really, I'm appreciating this conference, first of all, from my side. I am Professor Jayavanitha, Principal from Kriti Institute of Nursing and Paramedical Sciences, Robertsganj in Uttar Pradesh. Today, I'm going to present about one of my research articles, that is a digital burnout among nursing faculties, descriptive research. The next slide, please. See, this is according to the International Classification of Diseases version 11. Burnout is now a well-established syndrome in the occupational context and is characterized by three key aspects. That is a mental fatigue, like a feeling of energy depletion or exhaustion, and depersonalization. It's like a work-related symptoms and impaired job performance. So digital burnout, it's like a feeling of anxiety, exhaustion, and apathy. It's caused by spending too much time on digital services. Nowadays, it's a growing problem also. A study, they have survived in American office workers, nearly 1,057. In that group, 87%, they spend an average of 7 hours per day starting at screens. So according to the WHO, in 2019, they have recognized Burnout, this is like an occupational phenomenon that can influence the health status. Okay, so this is the second slide. The initiation of the COVID-19 related lockdown, the global statistics, it's indicate that people, they are spending much increased time on their digital activities only. 57% they are watching streaming web series and some reality shows, and 39% they are in streaming music, and 35% they are using for their gaming purpose, and 47% they are using for the social media, and 46% they are using messenger, and 14% podcasts, and 15% they are uploading their videos. So this is the global statistics. And next slide, please. And by seeing the global statistics, and they have come to that conclusion, 76% people are using a smartphone, and 47% are using a laptop, and desktop 32%, and 22% tablet, and then 34% smart TV, and for streaming devices, and 17% for gaming console, and 11% for smart speakers, and 6.3 on smart watches. And now 6.3, we may not know that in the future it may be changed to 63%. Like that, our technology is going very fast. The next slide, please. Next slide. Okay, so this paper I have investigated the digital burnout levels in nursing faculties. So for this, I have used the descriptive design, and my setting was among 100 nursing faculties at the selected nursing college. This previous slide. Am I audible?
Yes, please proceed.
Okay. So here with the convenient sampling technique I have followed, and the methods I have used, some of the descriptive characteristics questionnaire and the digital burnout scale I have used. The next slide, please. Okay, so here with some of the determining characters like a demographic variables, I have found nearly 8 demographic variables. Among that, this is the 4 main things it was really wondering about: the types of gadgets using often Android phone. Nearly 96% people are accepted at 96%. And then about how often do you check your phone? In that, about at a few times daily. A few times day, nearly half of the population they have answered. And then which social platform they have used mostly means this is the WhatsApp. And then how long do you have your phone or other gadgets with you means nearly 1 to 5 hours daily. The next slide, please. And after the demographic variables, I have used the digital burnout scale. This digital burnout scale is prepared by in 2020 in the name of Erten and Ozdemir. They prepared this scale. So in that I had 30 scale items. With that, some of the factors like 3 factors like a digital exhaustion and emotional exhaustion and aging. So the first 15, it's coming under the digital aging, and then the next 7, it's coming under the digital deprivation, and the last 8 factors of emotional exhaustions. With that, I have notified how many they have scored. The next slide, please. So the methods I have used like a descriptive characteristic questionnaire along with the digital burnout scale. So the data were analyzed using the number, percentage, and mean, like a minimum and maximum Along with that, one-way ANOVA, Spearman's correlation, I have checked, and then KMO and Bartlett's test. Everything I have done it in the SPSS. The first one is the ANOVA. Why I have checked this ANOVA means for differences among the means of the populations, like the amount of variation between the samples. So in this, statistically, it was significantly different from each other. So it was positive, like a significance in the rate of less than 0.001. Next slide, please. So ANOVA, I have used for to find out the amount of variation between the samples. And the next one is Spearman's correlations. I have checked. Why I have checked means this is to measure the strength of association between two variables. So here with in that 30 dBS score, I had a factors like a digital exhaustion, deprivation, and aging. So here with the digital exhaustion and deprivation, there is a correlation between these two factors. So that's why my statistical report was significant at the level of 0.01, and it was saying that the correlation coefficient was less than 0.05. So based on this data, we can say that there is a very strong relationship between these three factors. Next slide, please. And here with the KMO and Bartlett test, so that is the Kaiser-Meyer measures of sampling adequacy. So if the value is over 0.5, that is the significant level. So for me, I got a result of this, and at the same time, Bartlett's test, it was 0.05. This is also suggests there is a substantial correlation in the data variables. Next slide, please. Here with overall, the result of my study is the participants, they had a total of DBS score 74.18 plus or minus 20.12. So they had a mean DBS of digital aging, deprivation, and emotional exhaustion. That is a 39.17, 17.36, and 20.24 respectively. So participants who spend more than 5 hours a day online, they had a higher DBS scores than those who spend less than 5 hours a day online. And also the participants who were always stressed out had a higher DBS score than those who are sometimes or never stressed out. So that is also significantly showing that less than 0.05. Next slide, please. So with that conclusion, digital burnout means it's a result of the too much screen time causing constant workplace stress. And digital burnout, if you are taking this, refers to feeling of exhaustion, anxiety, apathy, depression. So this all will diminish interest in your job due to the constant use of digital services, devices. So when we are having a constant exposure to the digital devices for a prolonged period of time, it will give a result of feeling stress over your job, and your working conditions will be also spoiled. So nowadays, it's a digital intensity of the workers everywhere, not only nursing colleges, everywhere. It's rapidly increased. And during this pandemic resulting also, it significantly threatened to the employees' well-being as well as the productivity also. And the next slide, please. If you're taking that today's digital world, really it's a different generation's use of internet, because they are giving value to the digital only, not for the human being, of course. And overall, when they are taking their role, digital experiences, that is only playing a very important role in all our lives only. As we going forward in our lives, like working from home or shopping for groceries online and learning in front of our screen. So generation Z, now we are in generation Z. So this will increasingly taking their place. Do you know where? The driver's seat of society. That is the condition of the generation Z. So their influences means like they are the first generation of true digital natives. It's now radiating very faster outer than other generation of the youth. So this is all digitally based on, because they have never drawn the difference between what is the physical and what is the digital world. For them, whether it is a online or a offline, the critical element, if you are seeing that, they want to move both of them. So generation Z, they won't wait around for something to happen. They will build it. So that's why from my research study, the next challenge in education is teaching generation Z. Really, it's very tough, so that we have to go accordingly. So we have to change our, some of the diversional therapies we have to take. So of course, my forthcoming studies is that only. So really, thank you all for my today's session, for joining with us.
Madam, are you hearing us?
Yes, yes, sir. Yes, sir. I'm here, sir.
Madam, how many colleges you have selected for this study?
Ma'am, 70% of the faculties I have taken physically, and 30% I have sent the Google Forms, because as I was living in Uttar Pradesh, nearly 3 colleges only. In my place, only 3 nursing colleges. So 70% physically I have taken, and 30% I have taken via the Google Form only. Yes.
Madam, what was the response rate in Google Form?
Ma'am, I'm not getting your.
Madam, how much? What was the response rate in Google Form? You told 30% you have taken as online survey, ma'am.
Yes, ma'am. Yes, ma'am. Online survival.
How was their response to online questionnaire?
Means the percentage. I'm not getting your question. Sorry, ma'am. The percentage.
Yes.
Ma'am, the 70, the overall, the colleges where I have gone, which is nearly 84, and then remaining is like online. But physically, when I was offline, is the 84% participants I have covered.
Okay, okay. Thank you.
Thank you, ma'am. Thank you. Thank you so much.
Next, we have e-poster presentation. First participant, Mr. Umesh.
Hello, ma'am.
Your poster. Now your presentation.
So can I share the video?
We will share the poster from here.
It's coming. Host disabled participant screen sharing.
Okay, okay. We will share from here itself.
So I am not able to share my screen, sir.
No need to do anything. So the poster will be shared from here. Can you share now? Umesh.
Yes, sir. Thank you, sir. I can share now, sir. Thank you, sir.
Okay, we'll share it.
Hello. Good evening, everyone. Before I start my presentation, I would like to say thank you, organizing committee, for conducting a very systematic way, both online and offline, this conference, and selecting wonderful themes also. Once again, I thanks to organizing committee, to giving opportunity to present poster in online. Now I will start with my presentation, poster presentation. As we all are know,
Umesh, no need to present. Already we are seeing your poster, so we will ask few questions. You can answer to that.
hello.
Umesh, are you hearing?
Sir, I'm not able to hear properly, sir.
Okay, no need to present. We will ask few questions. You can answer. We will ask questions based on your poster. Is that
Okay,
clear?
sir. Oh, yes, sir. Okay, sir.
Okay. Just wait. Please explain your pediatric trials. Umesh?
Yes, sir.
Pediatric trials. Triage. Please explain that part.
Hello. Hello, sir.
Hi.
Sir, in this track, sir, if checking emergency sign is there, if yes means we have to emergency the treatment, or non-urgent cases or stabilized cases, sir. Check for the emergency sign. If no, check for the patient sign. If yes means rapid assessment and give treatment, and routine non-urgent cases and stabilize the case. Next, check for the patient sign. Check for the patient sign. If no any sign, go for the non-urgent cases and stabilize the case. And routine assessment, that is history, physical examination, lab test, differential diagnosis sign, go for the next step. And in these all steps, counseling is very important to roll in this process to convey the parents about the child emergency condition and the treatment.
Okay, explain the nurse's responsibilities.
Hello, pardon, sir.
Explain the nurse's responsibilities.
Yes, sir.
You have to explain only mitigation. Only explain mitigation.
So mitigation is, so it refers to measure the prevents and emergency and reduce the chance of emergency happening, sir. So we can prevent the emergencies.
Okay, it is understood. Okay, thank you so much.
Thank you, sir.
Next question.
Next, Ms. Nirmala D'Souza.
Hello, good evening, ma'am. Can you hear me?
Yes, yes.
Hello, good evening, sir. Good evening to all for giving me a chance to present the poster.
Madam, please explain the model in your
Pardon?
poster. Model of forensic medicine practice.
Pardon, sir?
Madam, please explain the model of forensic medicine practice
Yes,
that
sir.
you have given in your poster.
So this is a model of forensic nursing practice, which portrays a nursing professional whose nursing services background must incorporate forensic science and criminal justice principles. In this, we can see the center, the triangle, sir. In the triangle, we can find in center the justice and the flame which is enlightening to the new field. And the first the corner over here at the apex and find that they shares the mutual responsibilities with law enforcement and agencies. The next to the left at the base, we can find the society, how it has unique aggregate of the crimes and violence and the social constraints which are there. And at the other side, other corner, we can find the emerging discipline of forensic nurse. With this, we can come to know the roles, behaviors, and the role expectations. And at the overall, we can find the, sorry, one second, sir. And we can see that interlocking circle that emphasizes the multidisciplinary coordination and cooperation among sociology, criminology, education, culture, politics, and healthcare systems. Okay, enough.
So you can conclude your portion in two words. Conclusion.
Sir, can you please repeat, sir?
You can conclude your portion in a few words.
Yes, sir. Yes. Yes. So actually, nurses are providing care in the emergency, sir. The thing is, when the patient comes, that can be any emergency. It can be a cardiac emergency. It can be an accident and all. But the nurses are giving care. But when they're giving to a victim, the care is given to a victim which has come with the violence, assaults, or sexual assaults also. The thing is, the nurse is the first person to take care of the patient to give the emergency treatment. Now, during this, the nurse forgets to maintain the evidences during this time, because at that time, the first decision what she takes is more than the evidences to take care. She takes the things first to manage the life supporting. She'll be managing, sir. Main thing is she wants to take care of the life of the patients. At the same time, in forensic nursing is been taught, so the program has been involved, and including the INC has been now understood the importance of forensic nursing, and it is included into the syllabus of the new competency base in the 6th semester. So the thing is, yes, sir.
Okay, thank you.
Thank you, sir.
Thank you, Nirmala. Next, post director, Ms. Krishna Kalku.
Good evening, sir. Good evening, ma'am. Am I audible?
Yes.
Please allow me to share the slide screen. Please.
We are sharing.
Yes. Host disabled.
Please say that.
Okay, ma'am. Sure.
Now you can share, ma'am.
Yes, thank you, ma'am. Is it visible?
Yes.
So you have assessed the attitude of general population towards social media, mass media impact, isn't it?
Yes, ma'am.
You have assessed the attitude.
Yes, ma'am. Yes, ma'am.
How you have done this study? You have mentioned that it is through online. How you have assessed the access to online?
Ma'am, a tool was developed in a Google. Ma'am, am I audible?
Yes.
Yes, ma'am, a tool was developed that was circulated through Google Form. The tool included first demographic variables and then a Likert scale, 5-point Likert scale having 20 items. 10 were having positive and 10 were negative, with a total scoring of 100, and the attitude was divided as a positive, neutral, and negative. The positive scores were from 74 to 100. Then the neutral were from 47 to 73 score, and the negative ones were 20 to 46, and the result as shown in the pie chart, that the population out of 200 samples, 28 showed positive attitude, whereas 172 had a neutral attitude.
How you have selected the sample? Because the general population, no, then how you have selected the sample?
Yes, ma'am. Samples whenever I used to go to hospital during the clinical posting or anywhere, I used to take consent from the participant, and then I used to share that through WhatsApp, not like just sharing to everyone, but I used to take consent and then share with them to avoid the wastage of paper and pen. This was used.
Okay, whether all of them have responded and what was the response rate to online method?
Ma'am, pardon, please.
You have selected 200 participants, whether all of them have.
Yes, ma'am, all of them. Ma'am, all the participants, I have met them physically, but to avoid the pen and paper wastage, I have just shared it through the WhatsApp link.
Okay. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am, for the presentation. Dear delegates, our workstations are led by eminent faculty from MIMS College of Nursing and ASTER Hospital, Calicut. I invite Dr. Asmadali here to give the appreciation to our resources.
हाँ ये लोग को खाली क्वेश्चन से पूछता था ना
Those who have presented through online, we will be sending the certificates.
Thank you, ma'am. Congratulations to the winner. I invite Dr. Ratna Devi to present the certificate to the winners. Let's offline paper presentation. Ms. Swati Vishwanath. Offline poster presentation. Ms. Neha Joseph LP.
Anybody can come and collect on behalf of Seha.
Thank you, ma'am. We come to the end of the 2 days national conference. We are eager to listen from the participants regarding a valuable feedback. Anyone among the participants may please share your suggestions and feedback. Ms. Sandra from MIMS.
Sliding option. Sliding.
A very warm greeting to one of our gathered here, respected dignitaries, teachers, and all the participants. First, I'd like to appreciate the great efforts put forward by the MIMS College of Nursing for conducting the 11th Annual National Conference on Nursing Management of Clinical Emergencies. We are so privileged to attend such a program as we nurses are more accountable to come across with medical emergencies. It was an opportunity to add new lessons for our fourth year studies and also to brushing up the third year sessions, since we are current fourth year students who haven't appeared the third year university exams yet. Thanking the entire program coordinators under the guidance of Professor Dr. Asuma Devi, Dean of MIMS College of Nursing, Professor Dr. Shetila Ma'am, the Vice Principal, MIMS College of Nursing. Thank you, ma'am. It was an opportunity for us to also thank a thankful expectations who presented the different topics, all the experts, also for the warm welcome, heartful recognition, innovative effort, and the delicious food you say. Thank you.
Ms. Anna Salim from MIMS.
A very warm good evening to one and all gathered here. Me, myself, Hannah Salim from MIMS Nursing College, Vayar. I am privileged to be a partaker of this conference. I have been able to gain a lot from it. I am very grateful for the explanatory handouts that entail the details of the presented topics. This conference has combined almost all emergency management. Also, the interesting topic sessions, which we had not much exposure before, was the forensic nursing indications in emergencies. Every topic selected were very useful and interesting for us. And also, as this is a feedback session, I would like to have a sincere feedback about the faculties, staff, students. Everyone was very much comfortable to approach and also there to clear our doubts and also for the help and the guidance in this conference. The workstations along with the resource persons were very much interesting. And also they had a wide group sessions and also group participation was very much interesting for us. We also had the opportunities to do the CPR and etc. This gave us a good group discussion and group participation also. And we are very much thankful to MIMS College of Nursing for such a wonderful initiative taken to have the program a complete success and both offline and online. Also, the success of this program is the hard work of the organizing committee and the staff students of MIMS College of Nursing. I, on behalf of DMS Nursing College, thanking you all. Organizing chairperson Dr. Asma Devi Tia, Dean, Astaments Academy, and Principal of MIMS College of Nursing. Thank you, ma'am. Also, the organizing secretary Dr. Shechila CX, Professor, Vice Principal, MIMS College of Nursing. Thank you, ma'am. And also, we had a great coordinating from the faculties on the very first moment of the registration process till this moment. And as a feedback, we got a very good hospitality from Aston MIMS College of Nursing, and we had a very good memorable day. Also, I am very much thankful for this opportunity from our College of Nursing, and thanking you all for a memorable day.
Thank you. Anybody else? Anybody else for feedback? I invite Dr. Asma Devi Tia to give the appreciation for resource further from MIMS College of Nursing in one station. Professor Isha Professor Daisy F. Ms. Soundestry, Ms. Nigina, and Ms. Atulia. Thank you, ma'am. Thank you all. Now I invite Mr. Nasi M, HOD, Medical Surgical Nursing Department, MIMS College of Nursing, to read out the report of this national conference.
Very good evening to all of you. So I am here to brief the 2 days national conference report. So national conference with the nursing management of clinical emergencies was started on 16 at 8:30 a.m. and the registration of delegates was held from 8:30 a.m. to 9 a.m. and pre-test followed by pre-test at 8:45 a.m. The first session was led by the Brigadier Dr. Aruna Menon, Head of the Department, Senior Consultant, Center for Obstetrics and Gynecology, Mahindra Hospital. Madam has discussed about the various antenatal emergencies, including antepartum hemorrhage, ectopic pregnancy, hypertension in pregnancy. And the session explained need of alertness and anticipating clinical emergencies. Then she also mentioned quick assessment start with the identification of prognosticators, need of C through before going to DIs. She discussed early warning signs, shock index, role of therapy and use of success. Madam also explained emergency management of ectopic pregnancies, hypertensive emergencies in pregnancies, and seizure prophylaxis. Madam stressed takeaways triage, the concepts of triage, identification and anticipation, need of training staff to put protocols for the management of these kind of emergencies. Further than session, the next session was led by Dr. Amia Devi at 9:45 a.m. She is a senior specialist at obstetrics and gynae department, MIMS Calicut. Madam explained about shoulder dystocia risk factors, warning and alarming signs of pre-labor and different maneuvers used in the management of shoulder dystocia.
She also explained regarding clinical emergency of cord prolapse management. Further, we entered into the inaugural ceremony. The inaugural session of the conference started at 10:30 a.m. and was graced with the presence of Dr. Venugopalan PP, Director and Lead Consultant in Emergency Medicine, ASTER DM Healthcare. Then we have guests. Mr. Lukman Pulmada, Chief Operating Officer, ASTER MIMS Calicut. Dr. Salman Salahuddin, Senior Consultant Cardiologist, ASTER MIMS Hospital Calicut. And Ms. Sheila Matija, Regional CNO, MIMS Clusters. And the inaugural ceremony presided by Dr. Asma EDTM, and the inaugural ceremony, the welcome address was given by Dr. Sridhar CS, the Conference Secretary, National Nursing Conference 2020. Dr. Venugopalan PP sir has explained the milestones in the development of emergency medicine, illustrate the transformation of the emergency medicine from the casual. All our guests, Ms. Lukman Pulmada, Dr. Salman Salahuddin, and Ms. Sheila Matija, they have shared their valuable thoughts on emergency, clinical emergencies. And the vote of thanks proposed by Mr. Nasim, Associate Professor and Head of the Department, Medical Surgical Nursing, Scholar Nurse. Further, the third session starts after tea break at 11:15 a.m. The session discussed about uterine rupture and amniotic fluid embolism by Dr. Sia Keke, Assistant Professor, Government College of Nursing, Calicut. Madam has discussed regarding the role of stomach, prostaglandins, and thromboxane in therapy, amniotic fluid embolism, and anaphylactoid syndromes of pregnancy. Further, a session was taken by Mrs. Ishaya, Assistant Professor, Government College of Nursing, on postnatal emergencies. Madam explained about postpartum hemorrhage, various types, and 4 important P's and A's that leads to PPH. That was briefly described. The fifth session was started at 12:45 p.m. on emergency management of polytrauma, hemorrhage and shock. That was led by the former Professor of Surgery, Government Medical College, Dr. P. Rajan, presently working as Senior Consultant and Surgery, ASTER MIMS Calicut. Sir explained regarding trauma care and different types of trauma, especially intra-abdominal trauma and spinal injuries. Sir also discussed regarding ways of controlling the various techniques for to control hemorrhage by means of surgery, followed by the identification and the grading of hemorrhage. He explained various resuscitation techniques and ventilator methods in emergencies. The post-scientific session started with pediatric medical emergencies led by Dr. Suresh Kumar E.K., Senior Consultant and Head of the Department Pediatrics, ASTER MIMS Calicut. Sir explained regarding anaphylaxis in children and emergency management, and stressed out the role of IM adrenaline for the anaphylaxis management in children. Sir discussed regarding respiratory distress due to foreign body aspiration, initial stabilization, identification of causes, bronchoscopy, and management of complications. Sir also briefed the management in various pediatric emergency situations like pneumothorax, asthma exacerbation, status epilepticus, corrosive liquid injection, poisoning, shock, dehydration, infectious disease, meconium aspiration syndrome, multi-system inflammatory syndrome in children, cardiac and neural emergencies, snake bites and animal bites. Further, Dr. Sajina, Assistant Professor, Government College of Nursing, Calicut, leader session on nursing management of neonates and children after surgery. Madam explained regarding the principles of pre and post-operative care of children. Madam also discussed regarding post-operative hypothermia, pain management, maintenance of fluidified agar formula. Madam explained clinical emergencies like esophageal atresia aspiration, brachioesophageal fistula, ICD bag drainage, congenital diaphragmatic hernia, infantile hypertrophic stenosis. And the 8th session on day 1 was on acute abdomen in children and neonatal cervical emergencies by Dr. Abraham Ahmed, Senior Consultant and Head of the Department Pediatric Surgery, ASTER MIMS Hospital, Calicut. Sir has highlighted the importance of notifying emergencies like malrotation, bilious vomiting, duodenal or intestinal atresia, LATS procedure, intestinal obstruction, infantile hypertrophic pyloric stenosis, congenital hypertrophic pyloric stenosis, respiratory disease, anorectal malformation, respiratory distress in newborn, diaphragmatic hernia, neonate with jaundice, intussusception and UTI. And the last session on day 1 was regarding the forensic nursing implication in emergency fight. Our Dean, National MIMS Academy, Principal Scholar of Nursing, Dr. Asma PM Madam. Madam discussed about the importance of forensic nursing, role of forensic nursing in emergency department, types of forensic cases in India, procedure for registering a medical legal case, how to report MLC, evidence collection, documentation and chain of evidence and preservation of evidence. And the first day of conference has came to end by 4:30 p.m. followed by tea and snacks. The second day to start at 9 a.m. with an informative session on substance use disorders, emergency slide. Lidu James, Associate Professor and Head of the Department of Mental Health Nursing, English College of Nursing. Sir provided us with illustrated information on various substance uses related emergencies and its prevention, addiction prevention. Further, Dr. Salman Salahuddin, Senior Consultant, Cardiology, Ashman Hospital, Calicut, made a session on emergency management of ACS, acute coronary syndrome. Sir explained various types of ACS, STEMI, and unstable angina. Sir discussed the symptoms, recognitions, cardiobiomarkers with the different case scenario. Sir also highlighted different management of ACS, which include fibrolytic therapy, reperfusion therapy, primary PCI and VAS, coronary revascularization techniques, various complications like tachyarrhythmia, bradyarrhythmia, heart failure, mechanical complications, and bleeding. Cardiogenic shock and its management were also discussed at the end. Following the pre-break, Dr. P. N. Suresh Kumar, Managing Director and Consultant Psychiatrist, Center for Neuropsychiatry, Calicut, gave a very informative deliberation on management of violence and suicide threat. Sir explained various psychiatric emergencies and areas where psychiatric emergency services are provided. Sir mentioned about schizophrenia, mania, delusional disorders, personality disorders, alcohol intoxication, alcohol withdrawal, neurological illness, endocrinopathies, metabolic disorders, serotonin syndrome, drug overdose, role of ECG in agitated violence, violent assault and aggressive patients. He also highlighted various psychotherapies. Followed by the Suresh Sarkon, Dr. Paul Anapa, Consultant, Department of Neuroscience, Hospital, Calicut, took a very interesting session on emergency management of stroke. Sir explained regarding the emergency management of acute stroke, both small artery and large artery stroke. Sir discussed various bypass techniques to shorten emergency department stay. Sir explained stroke protocol, NIHS scoring, and the management like IV properties, mechanical thrombectomy, and IV recombinant tissue plasminogen activators. Then Dr. Keshav, Consultant Pediatric Hematology, Hospital, Calicut, started his session at 12:25 p.m. Sir discussed on topic discussed about the various oncological emergencies. Sir explained chemotherapy-related complications like vesicle infiltration, seizures, and allergic reaction. Sir also highlighted the topics like anterior mediastinal superior vena cava syndrome, superior vena cava compression, then hyperleukocytosis and leukostasis, hemolysis syndrome, hypocalcemia, hyperkalemia, and febrile neutropenia and its management. After the lunch break, we had workstations, simultaneously parallel paper presentations and course presentation. We have 5 workstations. So all the delegates divided into various groups and directed into the various workstations. So the first workstation led by Blaisy, Associate Professor in College of Nursing, along with his colleagues from Ashman Hospital. And the other presentation session was handled by Regina, faculty, Department of Medical Surgical Medicine, College of Nursing, along with staff from Ashman Hospital. Then similarly, we have pediatric resuscitation and de-escalation technique sessions along with the last session. Next slide. management of OBD mustard, that was about management of solid dystocia, that was led by Professor Ishayas from Department of Obstetrics and Gynecological Nursing, College of Nursing. So the whole scientific sessions came to an around 5 o'clock. So that's about the brief report of this two-day national nursing conference. And we have one more result has to announce, that is the pre-test process score. Okay, there is a statistically improvement in the knowledge. We have calculated t-test. So that shows it is statistically significant. So post-conference, post-test score is high when comparing with the pre-test. So it means the conference is really helpful. All the way. Thank you all.
Thank you, sir. I request Dr. Shitila CH, Vice Principal, MIMS College of Nursing, to deliver the vote of thanks.
Good evening to all. It's a great pleasure. I am proposed the vote of thanks for this occasion. On behalf of the conference organizing committee of MIMS College of Nursing and ASTER MIMS Hospital Calicut, may I extend a heartfelt gratitude to the keynote speaker and other dignitaries who have graciously inaugurated the 11th National Conference on Nurse Management of Clinical Emergencies. I must mention our deep sense of appreciation and gratitude to all the speakers who have shared their thoughts on clinical emergencies and brought in the vista of knowledge to all the participants who are present here. We are extremely grateful to our Dr. Aswani PM, Dean, ASTER Academy and Principal MIMS College of Nursing for their constant guidance and support to organize this program. I take this opportunity to extend our sincere thanks to all the delegates who have come from different places for attending this conference with enthusiasm. I would like to thank the Hospital Administration Department, IT Department, and Business Development Department of MIMS Hospital for arranging the auditorium and this arrangements made for IT support and live streaming the session. I also wish to express my gratitude to Imagine Camping Services for providing us with a 2 days delicious food. I also grateful to the teaching and non-teaching faculty of MIMS College of Nursing and the supporting staff of ASTER MIMS Hospital for the completion of the assigned task which is given to them on this conference. Thank you all. Once again, thanks a lot to one and all directly and indirectly involved in this program. Thank you all for your support. Thank you.
Thank you, ma'am. Ladies and gentlemen.
Hello, personally, I want to thank all the participants who come from different places. And also, I wanted to bring you a report. My sincere thanks to IT team, ASTER MIMS, and business development team, and also the administration wing of ASTER MIMS. Thank you. Thank you.
Ladies and gentlemen, thus we conclude for the time being. Once again, thank you all for the time spent with us. We look forward to see you again for the next conference. Dear delegates, please rise up for the national anthem. भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाहे तव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे। Thank you.